the consumables are expensive. And in COVID ECMO, what we've seen is that there are strategy changes. So you may start with a strategy, and then the patient, because there is multi-organ involvement, there may be myocarditis, and you may have to change to a VA ECMO from a VV ECMO. The oxygenators block off very easily because of hypercoagulability. Then you will have to change oxygenator after 20 days on it. The length of ECMO is very long. So cost becomes an issue. But I think even when, and actually in COVID they have capped all costs. So for any hospital to offer it is also difficult because there's a lot of scrutiny and there's a lot of capping on costs for COVID patients. So ventilation also we struggle because TOSI offer kare nahi kare because that is a cost, right? So that's, and there is no organized program. Better survival because it's your first probably in the program. So the programs who are doing ECMO regularly, they are offering on patient selection basis and they're getting results also, even in India. The programs who were just starting off but had the know-how, they're doing well now. They have picked up the rates of patient acceptance. So I think the longest survivor was in Bangalore, Manipal. The problem again with these COVID ECMOs is that the patients are extremely, like they have a surge response initially, and hemodynamically they are not as stable as other ARDS patients. H1N1 patients are excellent indications. They have a very predictable course and their survival rate is more than 50-60%. Like in our institutes also, which is at par because they are pre-ECMO hospitalization and ventilation is not very long. They tell you immediately that put me on ECMO. Like literally the patient clinical picture tells you that they will not survive without it. So, are we done? Should we start?
Yes.
We got everybody in now? Okay. So I'm Dr. Jumana Haji. I've joined HN Reliance Hospital as a cardiac critical care person. I handle their MCS, Mechanical Circulatory Support Program. I've done ECMO training from Singapore National University under the guidance of Dr. Graham McLaren, who's one of the authors of the Red Book. And we basically deal with adult ECMOs. Now my trajectory is not only recovery but also bridge to transplant. So the first ECMO survivor was in 1972. It was a post-bike accident, ruptured aorta with post-traumatic ARDS, and he was on ECMO for 72 hours and survived the run. The father of modern ECMO is Dr. Robert Bartlett. He put this child who was a Mexican immigrant. Mother had crossed over to America, delivered a baby with meconium aspiration syndrome. The authorities took a lot of signatures to put this baby on ECMO. Mother got scared, ran away, and the child survived. This is her at the age of 25. Now she's around 45. Her name was Esperanza, means hope, and she was spotted by the SIM. So that's when the story of ECMO started and picked up during the flu pandemic in 90s for adults. The adult ECMO picked up then. Pediatric ECMO used to be done more often before that. Recently in 2015-16 we had the last trial on ECMO, which is the Eolia trial, to see for the window or for the candidacy or the whether ECMO is really effective in ARDS. Even though the primary endpoints were not very encouraging, the secondary endpoints were good. Basically, their criteria for selection was very stringent. So they used to almost put the patients when their PF ratios were below 50. Anyways, I'll get to that. So basically, it's the same as a cardiopulmonary bypass managed in ICU. For management of acute cardiac, respiratory or combined cardiopulmonary patients who have failed conventional treatment. This is important. We are not in a state now to offer it as first line of treatment, though there are some very few indications where you can put ECMO before ventilation, but usually or ECMO before any ionotropes, but usually we will go by try conventional ventilation. You know that it is failing and the patient, if it continues in this, will die. That's when you offer ECMO usually. Principle is you need to rest the diseased organs. So if you're going to put a patient on ECMO and continue with high ionotropes or high ventilator settings, don't put a patient on ECMO. You must use the ECMO to take over the function of the diseased organs till they recover, and also you should choose the organs. So if it is heart, lung or both, yes. If it is superadded kidney, liver, select your patient, think very carefully whether this is cause or effect, it's like what failed first. If the kidney is just beginning to fail, it's a good window to put it. If the kidney has failed irreversibly or it is chronic kidney disease, don't put the patient on it. So patient selection that way, and brain is something that you have to look out. The CNS is not good, please don't put on it. I'm assuming we are all intensivists here?
Yes.
Okay.
In AKI, what is the time where you should think it is not the right?
If the patient is still diuresing, it's only your creat that's going up, it is a better window to put ECMO rather than put CRRT. So wherever you are about to start thinking, let's try CRRT now, unless it's hyperkalemia or something. If it is urine output related and or you're not matching your... basically I would say that you have to think of the cause of AKI. If it is septic, it's not a good indication. If it's cardiogenic, it's a great window to put it. So for cardiogenic, kidney shutdown, at least in our team, we feel that it's a perfect time to start MCS rather than to start a CRRT, because CRRT further worsens it. For example, aluminium phosphide poisoning, I had a lot of patients who came with complete cardiogenic shock, and they come initially walking with BPs of 80, the systolics going down slowly, then arrhythmia set in, and they have extreme lactic acidosis. So there are two pictures. One is the low BP and lactic acidosis. In these patients, if you put ECMO, and awake ECMO, you don't ventilate them, because they are compensating the acidosis well with hyperventilation. You put them on a FEMFEM, they recover very well. They just need 4 days of ECMO. You put them on ventilator, you put them on CRRT, they start going to a worsening spiral. So that you have to just realize where the kidney is getting hit and from what. Septic kidney hit, usually that it is not a good indication. Sepsis per se is not a great indication. But what happens is when the patient comes in ARDS or COVID, by the time they come to us, they have a mixed picture. Bad lungs and sepsis already set in. So you just have to see whether you will be able to hemodynamically maintain.
Just anything like procaine levels, any shock associated to not to put a septic patient on.
It depends how profound your shock is. So in septic patient, there is only one series which was done in pediatrics where they put all patients on central ECMO, and that had good outcome. Because the problem with septic patients is their demand, they have a hyperdynamic circulation and their demand is very high. So if you put a peripheral ECMO, you will not meet goals. You will not be able to get enough flows and they will require circulatory support. So if you try a V ECMO, because their primary is ARDS, you will fail. You will start getting a crashing patient. So sepsis is a tricky picture, So ideally in ARDS, you put them before, that's why we say we cap the ventilation at 7 days. Because you go beyond that, you're already inviting trouble with, your ventilator-associated pneumonias and your lying sepsis setting. Ideal patient is physiologically young with no comorbidities, but you never get an ideal patient. And now the horizon is broadening. So age cutoffs are also about physiology. If the patient is 65 plus but has had an active life with no comorbidities, then it's not ideal patient. We'll still accept. And it should be acute, reversible, single organ or dual organ failure, that is heart lung failure. If you are looking for bridge to recovery, if you are looking for bridge to other things, like I say, then you have to think differently. So there are different kind of ECMOs. You have VA ECMO, which is for acute circulatory failure. VV ECMO, which is acute respiratory failure. Hybrid ECMO, when there is a circulatory as well as respiratory failure and you are going peripheral, you may have to do a hybrid which is VAV or VVA depending on what your patient needs. So based on the patient's demand, hybrid ECMOs usually have 3 cannulas rather than 2. EDCD, this is for organ donation, where you are putting a brain dead patient or a patient who is you're going to withdraw life support for cardiac death and donation after circulatory death. This is done abroad in a lot of countries. It is not valid in India, not permissible in India because we have donation only after brain death. But still, if there is an unstable donor, brain death donor, who's already brain death certified, sometimes we do put on ECMO to stabilize and this, so that the organ quality is better. And this is basically done to decrease the warm ischemia time. The thing is that when you are doing it for organ donation, it's not to save the patient, it is to have better organs for donation. Okay, so your endpoint is different. Then you have ECPR, which is when there is a witness cardiac arrest, and there are very stringent criteria for ECPR. Basically, it is possible if you have an established ECMO program to do ECPR in-house, in hospital, in your witness arrests in ER, where if you have the equipment and you can do ECPR. So this is where the world is going. There are Scandinavian countries where all their CPRs are ECPRs. They have a response time of 5 minutes. They CPR at the top with a machine while they cannulate the fem, and then it's a bridge to anything. It can be bridge to recovery, to decision, to organ donation. Then carbon dioxide retention, we do what is called as an ECOR. We don't have ECOR available, but the latest MACASE does have an ECOR module, but the consumables are not available, right? So this is only for the advantage is that it's a very small volume circuit. So you're not taking 60% of your cardiac output out and back. Because it's a small circuit, you need higher heparinization. So there's a flip side also. If you have a bleeding patient, it may not be ideal. The flip side, it only helps because carbon dioxide removal on ECMO is the easiest thing. So if you don't have oxygenation issues, you can do ECOR if you have only hypercarbia or type 2 respiratory failure. But if your oxygenation also starts suffering, then you will have to upgrade. So most of us will do a low flow veno-venous ECMO for type 2 respiratory failure rather than do ECOR. The classical indications for mechanical assistance are 4 types. Bridge to recovery, where you know it's a single organ failure, this patient has been well and this is a temporary reversible condition. Excellent indication, should put on the ECMO immediately, should not think too much and counsel early. Bridge to bridge, when you have a patient who comes up with acute or chronic failure, this patient is probably listed for transplant and has come with an acute decompensation, becomes like a super urgent. The only advantage of putting on ECMO is you can put on ECMO and buy time to see if he can recover to his old stage, or he can get a super urgent organ, because once a patient is on ECMO, they become listed as super urgent for an organ. So they get organs easily. Or you can trial other mechanical support. So you remove the oxygenator from the circuit and convert it into a VAD, and then trial them on a VAD and see how he may do well on VAD. Especially if your kidneys are not well at that time, you give those organs time to recover so that their outcomes post transplant are better. And then bridge to transplantation, where you are waiting for an organ and then finally it can be destination therapy, like as a bridge to destination therapy, or sometimes for VADs, and there is a total artificial lung in the works, not yet out in the market, by Dr. Robert Bartlett and his team. And finally, in acute setting where there is an ECPR happening, it's bridge to decision. Whatever it is, you put the patient on ECMO and then wait. The patient will cool the patient, wait. The patient wakes up, great. The patient doesn't wake up, counsel for organ donation. So for this reason, we need to know when you can counsel an ECMO patient for organ donation. And lastly, it is bridge to withdrawal, which is the toughest. So the family must know in every ECMO, even if it is any of these indications, that once we put on ECMO, we are in a one-way street. And there will be a point where if we feel that the quality of life is not going to be good, you will have to take the decision to withdraw that support. So basically calling that quits is very difficult for families. So that you have to counsel before putting a patient on ECMO. Indications for VA ECMO, the good indications for reversible causes is arrhythmias. They come out very well, they stabilize very well. If the patient is having repeated VTVF, not getting ablated, so it can be a bridge to ablation. You take the patient to cath lab on ECMO, find out the points and ablate if that is possible. Otherwise, just stabilize and think of the next strategy. Viral myocarditis, excellent indication, 7 days, 9 days on ECMO, their EF improves. Pulmonary embolism with right heart failure, this one is tricky because pulmonary embolisms usually present in different ways. If they present as respiratory failure, you may need a VV ECMO. If they present as hemodynamic failure, it's basically RV failure. You may still benefit from a VV ECMO or a VA ECMO, both, because even a VA ECMO, because we are, removing from the RV, you do tend to decrease the preload and decrease the right side stress. But ideally we would put on VA ECMO initially just to stabilize and then think of other strategies like thrombectomy on ECMO. So if you are doing a thrombectomy, then it's a good see. Then cardiac stunning from poisonings, like I told you about my aluminum phosphide cases. Amlodipine overdose is another indication which is good. And perioperatively, if you are not, so ideally for a PTCA, if it's a high risk PTCA, culprit vessel is very critical. You put on ECMO, awake ECMO preemptively, like you put on IBP. And I think it is better to put on ECMO than on IBP. Take to the cath lab, open up the circulation, 24 to 48 hours, you can come off ECMO. And then, of course, if you are not coming off CPP, this is the most common indication, a lot of people use it for that. Okay, and chronic conditions are, like I said, as a bridge to LVAD and transplant. There is one series in which they have put, when the patient comes and interacts one condition, they put on ECMO first, wait for the patient to stabilize, mobilize them, wake them up on ECMO, and then decide whether the patient will do well with the LVAD as destination therapy. It downgrades the disease before offering a VAD. So if you go clinically, when will you offer? When you have rising lactate in spite of all your efforts and falling SCVO2. Your mixed venous gas is continuously showing high demand and low supply. Progressive LV failure, worsening left multi-organ failure. So like I said before, your kidney and liver takes a hit. Progressive acidosis, arrhythmias set in, that is when you really think about ECMO quickly. And severe hemodynamic instability. The rate of inotrope change is important compared to, so if you're going up extremely fast on your inotropes, then you have to start thinking of the next strategy. The indications for VV ECMO are direct lung injury like pneumonia, aspiration, and uncommon ones are pulmonary contusion, drowning, inhalation injury, preperfusion injury. And indirect is like sepsis, severe trauma with massive, like Charlie picture. And hepatopulmonary syndrome is the only indication in liver failure patients where you probably may need to bridge to liver transplant. If these patients come with acute decompensation of HPS. So HPS per se, they will be living with saturation of 85 to 90 and their treatment is transplant. But before transplant, if they decompensate, then you may need to use ECMO. And acute and chronic lung diseases for as bridge to lung transplant. The clinical picture is when your saturation is staying less than 88% and your pH is staying less than 7.2. When your mechanical ventilator settings have already reached a plateau pressure of more than 35 and tidal volume you're ventilating is more than 6 ml per kg, that you have already tried diuretic therapy, tried high P, and tried the recruitment maneuvers, proning and paralysis. So you have tried everything. This is the picture when you want to think ECMO. The Murray score is an excellent grade for deciding. So Murray score 3 to 4. There are four elements that you take. The chest X-ray quadrant involvement, hypoxemia, that is the PF ratio, PaO2 to FiO2 ratio. Less than 150, you must start thinking ECMO. Less than 100. The Eolia trials cutoff was 80, which became a bit too low. That's why the results were not good. But this was an established ECMO center. For us, all of us need to have a lot of strategies before we initiate. So our PF ratio cutoff should be much higher, 150s, that's why our cutoff. And PEEP, how much you are using, compliance in all quadrants, and then you divide it by 4. So ARDS related mortality during mechanical ventilation is usually due to hypoxemia, hypercapnia and high pressure, high volume ventilation, all of which will lead to RV failure, and all of that leads to tissue hypoxia as well as ventilator reduced lung injury, finally MODS and death. So how does ECMO improve this? ECMO improves your oxygenation, carbon dioxide removal and enables ultra-protective lung ventilation, all of which will improve the RV function, which is already suffering, avoids tissue hypoxia, really, and better survival. So that's why we are convinced that we need ECMO at some point in these patients. How do you choose? If there is refractory hypercapnia without hypoxemia, you do low flow veno-venous ECMO or minimally invasive ECOL. When it is with hypoxemia, you do ultra-protective ventilation and you can do one of these strategies or do a proper veno-venous ECMO. If there is refractory hypoxemia without shock, it should be veno-venous ECMO. With shock, you go for either the heart failure can be right-sided or RV failure. You have to do a veno-arterial or a veno-arterial venous ECMO. So basically your cannulation strategy will depend, even if it is ARDS. We know primary is ARDS, patient is H1N1 positive. But your RV is failing or you have viral myocarditis, your EF has fallen less than 20, you decide to do a VA ECMO or a VAV ECMO. Because, so what is the most important investigation before you go on ECMO? It's your echo, okay? And how much is your inotrope support?
And even though it is septic shock?
Septic shock is VA. Septic shock is always VA. Because you will never be able to maintain the patient's hemodynamics on a VV. In fact, septic shock is central VA.
Central.
The best results have been seen on that. People of course don't go central that easily. We will go peripheral VA, but it's very difficult to maintain flows and get good outcomes.
Even though it is early shock?
Early shock, hemodynamics, but you know, if the problem is that we don't think in early shock.
Early shock.
When your inotropes are still manageable, you will not think. By the time you think, they are really unmanageable inotropes. Your vessels are already extremely constricted. So your peripheral vessel, whatever access you will get is very small. So these are basically the different criteria for putting on ECMO by the different societies, and like I said, the Eolia had the least PF ratio. But I think the consideration for ECMO is what we should be looking at when we are considering for ECMO. That is a 50% mortality, more than 50% mortality risk, PF ratio of less than 150 when your FiO2 is 0.9 and a Murray score of 2 to 3. By the time they are 4, they are already too late. Who shouldn't get ECMO? The absolute contraindications, basically the smallest child that can be put is less than 1.8 kg for a VA ECMO and less than 2.5 kg for a VV ECMO. Children, no, basically we never do VV ECMO. I mean infants, you will do a VA ECMO only because their accesses are not good, so it will probably be central ECMO. And then major intracranial hemorrhage, more than grade 2 is a contraindication. Severe neurological injury, lethal malformations, untreatable non-pulmonary disease and unwitnessed cardiac arrest are absolute contraindications. Relative contraindications are gestation age less than 34 weeks or age, so extremes of age basically. So if it's a premature baby, very premature baby, then I don't think you should do. And more than 65, again 65 is a very broad cutoff. You can still do at 65 or 66, I mean more than 60, 66 is more than 65. But If the patient is physiologically good and fit with no other comorbidities with the reversible condition, you should offer ECMO. Ventilation, mechanical ventilation more than 14 days. I think this we have already, in COVID ECMOs, we have already broken this rule. Everybody is more than 14 days on ECMO, on a ventilator before they are offered. Uncontrolled coagulopathy is a relative contraindication. It just makes your life very difficult to have this patient on ECMO. VV ECMO, you can still put these patients, just don't give any heparinization. And you can, especially with some of these biolined and newer circuits, you can use them without heparinization for a very long time. Worst come, your oxygenator will start clotting off and then you need to change oxygenator. But you don't need to give heparin, like we do CRRT without heparinization, you can do that. Not for VA ECMO. If you're considering for VA, please be very careful because you have to heparinize on VA. And you will find it very difficult to heparinize these patients. Grade 1, 2 intraventricular hemorrhage, you can still go ahead, again if you don't use heparin. Syndrome with poor prognosis, I would say things like immunosuppressed patients, HIV positive patients, you have to really think how their quality of life is and how it will be if we give ECMO. But ECMO C is not like transplant. Once they get out of the acute phase, they survive without any long-term treatment. They don't need immunosuppression and things. So it's different. So you can still consider them for ECMO. Overwhelming sepsis, again we come back to sepsis because it's our major tender Achilles in India. And congenital diaphragmatic hernia with pre-ductal saturation less than 90% at all times is not a great indication. So CDH is an indication in pediatrics, but you have to be careful about what your pre-ductal saturations were at all times.
And what about mechanical ventilation? What is the ideal duration there?
Less than 7 days is ideal. So on the 7th day, you must think and put on ECMO. So by 6th day, you should start thinking ECMO. If you are not achieving anything with proning. So now one thing that has become sure is that you should prone the patient before you put on ECMO. Because many a times you see reversibility there and all your mixing of zones and your posterior consolidation, it helps to know whether these lungs are irreversibly damaged also or no. So if proning is showing some, but it is technically difficult as well as your airway pressures are going very high, but your oxygenation is improving, you have to take a call based on that whether it's a good candidate or no. But I think proning first is important. Oh. So former invalid indications were sepsis. Now most patients get it in sepsis only. Then trauma because of the bleeding ongoing. But again, trauma after you've given massive transfusion, your lungs have taken a hit now and you've been able to get control of whatever bleeding was there. It is an indication for sepsis. So, sorry, for ECMO. Okay, malignancy depends, how what kind of malignancy. We have done ECMO in lung, post pneumonectomy patients with malignancy and pulmonary hemorrhage. Actually, pulmonary hemorrhage is a good indication for ECMO. You don't heparinize and you wait for the lung to clear up. Pre-ECMO investigations, whatever, we'll have APTT as well as fibrinogen and your platelet count. Full blood count with platelet count, then also your infection levels, TC, hemoglobin important. You always have cross-matched blood and products when you are initiating ECMO. Basically kidney function, liver function you assess to decide candidature. ACT you need a baseline to decide on your heparin dose, and ECG and echocardiography. Every time whenever you are initiating ECMO, you should have an echo which is not more than 4 hours old. So do an echo, then you decide. And for neonates, you need to do a cranial ultrasound to rule out, and it will be something that you will keep doing to rule out any intracranial hemorrhage.
What you will say in echo for fresh echo, why do we need to take?
If your LV function is less than 20%, then it will be VA echo. So basically, to decide your cannulation strategy, you need a fresh echo. Maybe myocarditis, maybe high supports, but you need to rule out what is your ECMO components. Iptisha will discuss in more detail, but basically you have a centrifugal pump which works on the flow and pressure principle. Then you have the membrane oxygenator, which is like your membrane lung, which will take care of oxygenation, carbon dioxide removal as well. That is the gas exchange, and it is also a heat exchanger. Morning, sir. And then you have the inflow and outflow cannulas. The cannulation strategy tells you what type of ECMO you will be initiating, a VA or a VV ECMO. So there's a big difference between the native lung and the membrane lung. The membrane lung, native lung, the alveolar capillary membrane is about 150 meters square wide, while that in a membrane lung is 4 meters square. So there is a big difference, okay? So your expectations from ECMO should be realistic based on this kind of lung. The interface between the blood and gases is 1 to 3 micrometer thick, while the interface in this is 10 to 30 micrometer thick. And the blood surface volume ratio is 300 square meter, where this is 10 times lower, it's only 30. And the capacity of gas exchange is 3000 ml per minute, while here it is only 250 to 200 ml per minute. So when we are on ECMO, you should understand where all you're going to be compromised as to how much gas exchange you will get, and you have to work on it to get the best thing out of your machine. So first is choosing the membrane lung. So every membrane lung has a rated flow. Like up to that flow, you will get improvement in oxygenation. Beyond that flow, even if you increase the flow, the oxygenator capacity is reached. So for every machine, the rated flow is different. That is 90% saturation at outlet, at inlet. This is, if it is 0.8 meter square, after 50 you will not get any improvement in oxygenation. While if it is 1.5 meter square your membrane lung, you will get better. These are empirical numbers, but what I'm trying to say is choose your oxygenator, to understand. Then there are 3 settings on ECMO that you are looking at. The ECMO blood flow, which is controlled by the RPM that you set by that knob, and the sweep gas flow. The ECMO blood, the sweep gas flow, which is set on this Secrist, blender, gas blender, and the ECMO FiO2, which is also set on the Secrist, blender. So whether you're giving usually on VV ECMO, you will give 100% oxygen on the ECMO and only go down when you start weaning. On VA ECMO, if the lungs are good, you need not give 100%. You can give 50%, the same as whatever you're giving on the ventilator. Okay. So this is your ECMO settings. Cannulation strategies, you will have the simplest peripheral ECMO cannulations. For VV ECMO, it is femorojugular. The access is from the femoral, so you take blood from the femoral, take it to the machine pulls blood from the femoral, goes through the membrane lung, comes back through the IJV. This is the most physiological, you get best flows in this, and it is along how your body returns blood. On a VA ECMO, the access is in the femoral and return can be in the femoral or the axillary. When you are doing a CPR situation, fem is the easiest. You quickly cannulate both the femoral arteries and vein and you push in the cannulas while CPR is ongoing. If you have time or the patient is in cath lab, our axillary works better because there are certain problems with fem which are not there in the axillary artery cannulation, but it is a surgical procedure. So if your patient should give you that stability to do that. So these are the simplest forms of you have to realize that you are returning blood in a veno-arterial ECMO through the aorta against the gradient of your normal blood flow. So your normal blood flow is from the heart downwards from the aorta, while your ECMO blood flow is coming upwards. Okay. Then this is a cannulation. This is another cannulation strategy for VV, which is a single cannula, double lumen, where the same cannula will take blood from the RV and return blood into the RA at the so the cannula is faced in such a way that the return port should face towards the tricuspid valve. So the blood goes into the circulation. Okay, so this is also a great cannula, but for mobilization when it's a bridge to transplant kind of thing. But it also requires some technique to put it. It has to be TE guided. Should be done with in cath lab with radiological guidance. So it's not a easy bedside procedure. And this is central ECMO for mostly used in pediatrics because they don't have good vessels developed and up till 10 years of age, the lower half of the body. So all cannulation has to be done in the top half. If you are doing peripheral, it will be jugular and carotid. And if you are doing otherwise, you just go central. So your circuit consists of a venous cannula, which with tubing goes to a centrifugal pump. Whatever gas you collect from the pre-pump section or the pre-oxygenator section will be your SCVO2 or your mixed venous gas. Okay, that tells you a lot. It tells you the patient's supply and demand. If your SCVO2 is exceedingly high, it will tell you whether there is recirculation, which is one of the problems where whatever you're giving as oxygenated blood is getting sucked out again from the body by your access. So the SCVO2 is a very important investigation in ECMO patients. It will tell you more sometimes than your the same ABG. Whatever you collect post oxygenator will tell you your oxygenator function. Okay. So when we are checking the oxygenator function, we do a pre-membrane and a post-membrane ABG to see. Other components are you have the blender attached to the oxygenator and you have the CRR or you have the same heat exchanger, which is always there because the body is always the blood is kept at a constant temperature. This is necessary and this is actually advantageous to us also because you can manipulate the temperature a little. So if your patient's metabolic demand is very high, you will start meeting goals if you make them a little cooler. So sometimes you go down on the temperature. But on the flip side, you will never, you have to monitor the patient's temperature, plus you will never know if the patient is spiking a fever because you're controlling the temperature. So you have to look for other markers of infection. The CRRT machine can also be attached in series. CRRT machine filters can be attached and even your newer filters for septic this thing can be attached in the circuit, ECMO circuit. You have to do it carefully. It can be done. You have to just make sure that perfusionists are around to do it so that there is no air embolism or any thing of your flows. So this is what I was talking about, recirculation. When you do a fem jugular insertion, your cannulas are usually lying at the IVC-RA junction as well as one is lying at the IJV-RA junction. And the distance between the two cannulas should be 10 centimeter, around 10 centimeter. If they are too close, then whatever blood you are getting back from the machine gets sucked back if your flows are high. So that is called as a recirculation. There is always some amount of recirculation happening in patients, but if some of it is acceptable. If a patient starts getting hypoxemic, then you have to separate these cannulas out. So this is a problem of VV ECMO, where your strategy for cannulation is fem-jugular.
What about hybrid use?
So hybrid is complicated. Hybrid you go on when you are doing a VA ECMO and then the patient is not getting oxygenated enough. I'll come to that. Yeah. So oxygenation of your, so how will you, what is the markers that determine your oxygenation on VV ECMO? It is a membrane thickness and geometry. So what membrane lung you have chosen, the hemoglobin concentration. So if you are not meeting goals with the ECMO machine, then you improve the patient's hematocrit. Usually the cutoff, according to Bob Bartlett, is 14. He wants like every patient to have 14. But realistically speaking, we keep our targets at 8 to 10. Depending, if you are not meeting your targets, then you go up to 10 at least. But if you are meeting targets, then it's okay. No need to transfuse. Blood flow. So as you increase the blood flow, your oxygenation improves. The sweep FiO2. So how much oxygen supply FiO2 you are giving to the membrane lung? You have to give 100% in VVA. Residence times of the RBCs in gas exchange area, that is how much RPM. So if you are running very high RPM, sometimes you may have a problem. And the inlet saturation, that is your rated flow, which I told you. 75% of venous blood should get saturated. In carbon dioxide removal, membrane geometry and blood PaCO2 makes a difference. So if you have a PaCO2 of 75 before you go on ECMO, it gets washed out faster because there is a gradient. So blood PaCO2 makes a difference and blood flow doesn't make so much of a difference. Only like if it's too low, you will have problems. Otherwise, blood flow doesn't make a difference for carbon dioxide removal. Sweep flow makes a difference. So how much flow you are setting on the blender. So initially if you start 1:1, like your flow of ECMO flow is 3 liters and you start 3 liters on that, it will be a very quick washout. We start at low and we increase gradually. So you have to be very careful about this because especially when you are transporting this, we tend to go very high on the flow on the gas exchanger, which is a problem. It will wash out your carbon dioxide very fast, causing a sudden drop from 75 PaCO2 to 25, which will cause intracranial events. That is the only time when you have an intracranial event on VV ECMO. Okay? Blood flow rate, you have to, so usually the blood flow rate for ECOR is less than 1 liter. For ECMO blood flow for VV ECMO is somewhere between 1.5 to 3 liters, and for VA ECMO you need a little higher flows, 2.5 to 3.5 and above. So for oxygenation you need to at least put 60% of your cardiac output through the circuit to be able, through the membrane lung to be able to achieve this. For VA ECMO it's different. VA ECMO you go by your map and you find a map target where your lactates are coming down, your patient starts passing urine. So more than 65 is what you want on the map target. The other thing you have to be careful about in a VA ECMO is the pulsatility. So as you go up on your ECMO flows, I'll come to that later, your pulsatility starts going down. This is a carbon dioxide removal, so depending on the gradient, and carbon dioxide removal happens in the first beginning of flow itself. Because and once the equalization of flow happens, then no more carbon dioxide is removed. So it depends on your gas flow, and always we start with 0.5:1 flows on the blender for carbon dioxide removals. If your ECMO flow you're starting at 4 liters, you start your gas flow at 2 liters and then slowly go up. So half or 3/4 is okay. Don't even start 1:1. Sometimes that also causes very quick carbon washout. Then VA ECMO, like I told you, you are returning blood up the gradient of the aorta. So there is a point at which your native heart flow and your ECMO flow meet, and that is the cutoff point. Now, if your LV function is extremely bad, that point will be higher, somewhere in the arch. So then your right and left side both will get equal blood. But when your heart function starts improving, that point keeps moving down. And there is a point where only the lower body is getting better oxygenation. So always remember that your ECMO flow is not giving oxygenation to your coronaries most of the time or to your brain. It is your lung flow, lung blood flow. And if your lungs are bad, that is when you have to start thinking of hydrate, where you do a VA plus VV. So you do that by keeping one access cannula and two return cannulas. One returns into the femoral artery, one returns into the jugular. Okay? But sometimes that is why axillary is better. When you do an axillary, then it is physiological, it is forward flow, and it will supply your coronaries and your brain. So this is called as differential cyanosis or Harlequin syndrome, where half the body is better oxygenated and the top half is less oxygenated. And you can come to know that the patient is getting Harlequin syndrome where your right side saturation is less than your left side saturation. So in a VA ECMO, always have either an arterial line on the right side or a pulse oximeter on the right side, and when that saturation starts falling, then you start worrying about your neurological, your supply to the brain. So you can do a Massimo or a NERS saturation of the same brain, both sides of the brain, to see whether there is any drop in saturation there. It's a mixed venous saturation that you get in that machine. Okay? Clear?
What do we do then?
Sorry?
What do we do then?
Yeah, if you're getting Harlequin syndrome, then you have to do strategy change. You have to either go to a VAV ECMO, or you have to go to an axillary cannula, or you have to go to a central cannula, depending on how sick your patient is and how much options you have. Then your peripheral VA ECMO will not work. But you have to choose. Do you really need to go drastic, or you're meeting, a patient is awake, then you don't have to worry about neurology. The patient is not awake, you have to worry about neurology, you have to worry about, and you have to improve your oxygenation on the ventilator. So this is one time on ECMO where you are supposed to ventilate harder, because your basic aim of putting this patient is for a cardiac thing. So you cannot rest the lung in this case. Okay, so you first try
VA
it.
ECMO, what she is talking about, VA ECMO is mainly for cardiac.
Cardiac,
For
yeah.
cardiac and lung, both. You have to support the both. You see this figure on this corner here on the screen. So it says, you see the blue blood which is ejected from the heart, and the red blood which is coming from the ECMO machine, which is red.
Mm.
So there is a Harlequin syndrome or a north-south syndrome.
Mm.
In north there is a blue, and in south down is red. So kidney, up to kidney you get well oxygenated. But the problem is that blood does not reach out. And if I increase the flows to reach that blood up, then pulsatility goes. Pulsatility goes, then problem of non-pulsatility blood flow is another chapter by itself. So we want the pulsatility, we want the heart to eject. If I do not allow the heart to eject, because my ECMO flow, which is going opposite to the aortic valve, is high, my heart left ventricle will not able to eject. What will happen? LVDP will increase. What will happen? LA will increase. What will happen? Pulmonary edema. What will happen? Pulmonary hemorrhage. So she will come to that, but this is a problem of VA. So peripheral. But in emergency, to save the patient, I have to put peripheral. Or if I have a time, I will rather put axillary cannula. So the perfusion will be from subclavian artery down, everything will be red. Only as Dr. Shimana mentioned that your coronaries will not get pure red. So whatever the heart is ejecting with its own lung, so the aim of VA ECMO is usually to extubate the patient.
Yes.
Give rest to the lung and heart. See, this heart lung, this ECMO machine now is a bread and butter of the heart surgeon, cardiac surgeons. Let me tell you very honestly. Or a cardiac anesthetist, if there are people. What is difference is, this oxygenator lasts for 2-3 weeks, while our oxygenator lasts for 3-4 hours. So I have to finish that operation. Another major difference is that we go centrally, always. Here, in emergency, we can go peripherally. You can put the ECMO machine at home also, right? And thirdly, major difference is there is no reservoir in this. So I have a reservoir. What reservoir does is that whatever the left ventricular volume or the lung volume which is flooded, I can bring it out in my reservoir. So my left ventricle is empty, my lungs are empty, but still I am perfusing all other organs at a very good mean pressure of 65.
Right.
Right? So there is a limitation, but this is the lifesaver. And I think I was going to talk, but just now because you asked that question. So especially, I wish there are some cardiologists here. In PAMI or in patient who come crash to the cath lab, there is a huge series of more than 10,000 patients from Europe and North America. Previously, we used to put IBP first.
Right.
Intra-aortic balloon pump.
Yeah.
The intra-aortic balloon pump is the ECMO machine is far superior in saving the life than intra-aortic balloon. But what the cardiologist mindset is that this has happened last week in Mumbai. I am not blaming anybody. It's just but even in the center where the ECMO is there, so they put in IBP. The cardiologists think that once I open the coronaries, everything should be fine. No, but whatever the muscle has got stunned myocardium or damaged, it takes time, and this is very good tool for that.
Occurrence of harlequins.
So that figure down there is very important.
It will be VA in that.
VA. It's for heart. If it is for heart and heart lung, it is VA. It is only for lung. Lung is a problem. My heart is good on echo. VVA.
So occurrence of Harlequin syndrome is more often when you have a patient with ARDS as a primary and you have put in a emergency situation on VA because it was hemodynamically unstable. So this patient you have to, once stable, you have to either think of changing to a AV or a VV. So when you have a Harlequin syndrome, more often than not your heart is ejecting better. That's why your point has moved so low down that you're getting a knock sound. So if you can get off the VA and turn to VV, that's best. Otherwise you make it VAV. Otherwise you change to axillary. But initial, like sir said, will be VV fem because you're in an emergency situation and you know that the patient will not survive if you try to move him to OT or do anything fancy. Okay. Anyhow, so this is how it is. VA ECMO, like I said, is physiological. VV ECMO is physiological. It is in series. This is two different. They are parallel circuits in VA ECMO. Your heart circulation is going on, while your ECMO circulation is going on, and they compete with each other at some point. So how do they compete? This is how they compete. As you keep on increasing the flow of your ECMO from say baseline of 1 liter to 4.5 liter, your LV volume goes on decreasing and your pressures go on increasing, the back pressures, the SVR increases, and what you get is a competition, and your heart is actually under strain. It will start filling up, your MAP will increase as your flow increases to 60, 70. But the pulsatility decreases. So what you get is a mean pressure of 5, 4, sometimes only a non-pulsatile flow. That is not a good scenario. You have to keep some pulsatility, otherwise what is happening, like sir just mentioned, is that your heart is ballooning, then your LA balloons, then it goes into your lung and then you get pulmonary apoplexia. So when you start getting blood in your ET, it's a very late stage. So before that you have to take control. So this is a time when you can start a little bit of inotropes to just make sure that you are getting some sort of contractility. If you don't achieve it with that, then you may have to put in an LV vent, which goes back into the ECMO circulation. So it vents the LV, goes back into, or you can put an impeller, or you can put, so this is also a scenario where having an IBP in situ and then putting an ECMO is good. So IBP with ECMO results are better compared to only ECMO. But in an emergency, if you have a choice, please put ECMO. Don't put IBP first, like I said. So it is a extracorporeal blood flow can be non-pulsatile flow sometimes. That's what, and the map is what you are looking at to see your ECMO targets. But always keep. So you have to see two things: map and pulse pressure. And keep a pulse pressure at least more than 10. You know, till the systolic pressure you don't worry about so much, but there has to be some pulse pressure. So what is the effect it has on the heart when you are on a peripheral VA ECMO? It will decrease the RV preload because it will take away blood into the ECMO machine. Retrograde blood flow, so it increases the LV afterload. The aortic valve barely opens and there is stasis of blood within the LV chamber. So because of this SVR increasing, your blood starts stagnating in your LV and you may have an LV clot happening. And there is increased afterload of the LV which can cause back pressure changes and pulmonary edema. If you want to reduce the LV afterload, what we are causing because of putting the patient on a peripheral VO, we have to reduce the ECMO flow slightly. So if you're overdoing it, you will get this. Sometimes you need to come down on the ECMO flow and see if your targets are still met, great. Otherwise, you have to resort to inotropes, I already told. Sometimes you even give vasodilators so that the body's, instead of inotropes, vasopressors, you give vasodilators along with inotropes. IABP is a good method of unloading, and balloon atrial septostomy you can do. Cannula from LA to aorta connected to venous port to the ECMO circuit. That is your LA vent, LV vent, and then finally a central ECMO. So if you are having problems with all of your peripheral ECMOs, then you have to resort to central ECMO.
So again, basic come down is that we're talking VA ECMO now, right? And emergency, I put a peripheral ECMO. I saved the life of a person. Life problem is
But in an acute situation, VA is the only option you have for even for oxygenation because it is heart-lung support. Then you have to back think and think of strategies to get off the VA ECMO also within the next 48 hours, because you will either have to change to VV if your primary was lung, or to other strategies if your primary is heart, like an LVAD or whatever, depends, or other strategies of cannulation. But an emergency, you will have only peripheral VA ECMO, irrespective of it. So that's why you have to understand this, and then you have to understand where you're going from there, when you're putting on ECMO. This thinking has to come before you initiate, because then you are stuck with the patient on ECMO and no exit plan.
Very true. So you see in your mind, if tomorrow I get a patient like this, right ventricle is bad, I am giving peripheral ECMO. If I have time, I'll take the patient, tell the surgeon to take the patient to the operation theatre and put either an auxiliary and the venous cannula, so VA ECMO or VVA, whatever. VVA ECMO, when the lung is a problem and your heart is good, heart is excellent, and only lung, oxygen and carbon dioxide is the problem, VVA ECMO is.
So your ECMO flows are preload dependent as well as afterload dependent. So if you are not achieving your ECMO targets and not able to go up on the flow, then you have to see the patient's volume, why you are not able to get. If there is no volume in the patient, then you will not be able to suck out any volume. You have to see the venous tone. If you've been on very high inotropes, your veins are completely collapsed along with your arteries. So you will not be able to suck out. You may have to back off on inotropes after you go up. And create space in the veins to be able to suck out. Then position of the venous cannula is important. Sometimes it is very high up, very low down. You may have to adjust that to be able to come to a point where you are able to suck. Diameter of and the length of the cannula. So if your diameter is very big for a small vein or very small for a big patient, you will not be able to get enough flows. And diameter and length of the venous tubing. Usually I keep long length, but your venous tubing should not be mismatched. So basically you make a channel which is easy to get. So this is preload dependence. There are other clinical conditions where your preload decreases is because of increased intrathoracic pressure, your IVC is collapsing. So when you have ruled out all these things, if you are still not able to understand why you are not getting flows, you do an X-ray chest, you look for a pneumothorax, hemothorax, pneumopericardium, which is hemopericardium, which is causing your intrathoracic pressure to go up. Sometimes it's just your patient who's a young man who's waking up and coughing very badly, which is causing your intrathoracic pressure to go up. And the length of the cannula. So if your diameter is very big for a small vein or very small for a big patient, you will not be able to get enough flows. And diameter and length of the venous tubing. Usually I keep long length, but your venous tubing should not be mismatched. So basically you make a channel which is easy to get. So this is preload dependence. There are other clinical conditions where your preload decreases is because of increased intrathoracic pressure, your IVC is collapsing. So when you have ruled out all these things, if you are still not able to understand why you are not getting flows, You do an X-ray chest, you look for a pneumothorax, hemothorax, pneumopericardium, which is hemopericardium, which is causing your intrathoracic pressure to go up. Sometimes it's just your patient who's a young man who's waking up and coughing very badly, which is causing your intrathoracic pressure to go up so much that your IVC collapses and your IVC just kind of holds onto the cannula and you don't get enough flow. The afterload also again depends on your length and diameter. Basically kinks in the circuit will cause problems. So that you start from the circuit always and then you go up and position of the cannula you look at. Sometimes what happens when you are inserting, that time only you have kinked your cannula. So it becomes an irreversible problem and then you have to actually change the cannula to be able to get the flow. So think that way, do an X-ray, see if your cannula looks funnily kinked. Finally, it's because it is re-injection, it is opposite, you're going against the afterload of the, it's the afterload of the heart. So if your blood pressure is high, then you will not get enough flows. So it is, actually that is the time when you come off it. So when you start, so there is a competition of flow basically. You have to optimize the demand and supply. Like I showed you, the membrane lung is very small compared to your native lung, but you're putting on ECMO because your native lung is not even coping that much. But still you have to improve the supply and decrease the demand. So supply improvement, I've already told you, FiO2 of the sweet gas, choosing the right membrane lung. You may go up slightly on the ventilator FiO2 if you have exhausted all other. But before you go to the ventilator for anything, you have to start looking for other causes to remove. So that is decrease the supply, demand by decreasing the patient's temperature. I already touched on that when I talk about the heater cooler unit. Decrease the stress of the patient. So you sedate them, and if there is sepsis, then that is one issue. So you have to go up on your antibiotics. You check the patient's thyroid status also. So I think out of all this, the easiest to do is to manipulate the temperature a little bit and sedate the patient. The hemoglobin concentration I already told you, with your hematocrit, your oxygen carrying capacity will improve. This is just to show you that when your cardiac output is more, so if for the same patient, his cardiac output is 3 liters, you will get a good enough oxygenation of the blood. But as the patient gets septic and the cardiac output becomes 12 liters, the amount that is going through the oxygenator at the same flows is much less. So suddenly the patient desaturates. So you will have to go up on your flows to be able to match the cardiac output. It's not because the patient's demand has increased. Okay, so that is the septic picture. So 60% of your cardiac output should go through your membrane lung in order for you to meet ECMO targets. These we will discuss as we are, doing the hands-on. But again, if there is low flow, then you have to look for the, like I said, preload problems and remove the cause of the low flow. You should get enough flow. Then recirculation you should look for. So when the position of the cannulas is close, there is recirculation. Patient will be hypoxic, but your oxygenator is working well. Oxygenator dysfunction, again you look at the oxygenator to see whether it's getting clotted. That's why you're not meeting targets. Pulmonary shunt, you have to optimize the lungs. Like you may have units which are ventilating but not. So for that positioning you may have to do of the patient proning, sitting up, or you have to add nitric oxide. Then low oxygen transport is low, you have to add hemoglobin, improve the hemoglobin, and the cardiac output you have to manipulate the flows, or you have to decrease the SVR, okay, or give a beta block. So special needs of the ECMO patient is anticoagulation, rest of the disease organ, and investigations and complications to anticipate. Anticoagulation, we usually give 100 units per kg bolus at the time of cannulation for ECMO. It is much less compared to CP bypass, and you then titrate with ACT or APTT. You maintain them 1.5 times the baseline, and usually we go with about, if the baseline is 180 to 120, we keep 180 to 200 as your ACT targets, and APTT targets for VV ECMO is around 45 to 65, and for VA ECMO it is 55 to 75, little higher targets for VA ECMO. You have to have optimum platelet function. Usually you will have a platelet drop, so you try to keep it more than 80,000. Basically just a sheer force of going through the oxygenator causes platelet drops. fibrinogen level you keep balancing, and now you have surface coated circuits, so better to use those. Your anticoagulation problems are bleeding from the access sites, from intracranial or GI bleeds, so keep a big degree of suspicion for those kind of bleeds. Always do all invasive procedures, especially NG insertion if you have to, before you go on ECMO. You insert an NG on ECMO and you will be in real trouble. Suctioning from, especially from tracheostomy tube, even ET suctions, but tracheostomy tube, no, they tend to go and injure at the carina or places where you can't reach to solve the problem. So be very careful and have policies for suctioning on tracheostomy tube for this kind. And clotting. So you have to look for clotting in the circuit. We do a circuit check for clots every day, especially if you are not on target heparinization or you are going heparin free for patient indications. And in patients with who have a tendency for thromboembolic, you have to look for neurology every day to see the limbs you have to look at to look for thromboembolic problems, especially on VA ECMO. So these are complications of VA ECMO where you may have to increase anticoagulation for those reasons. Rest means you have to go to ekdam rest settings for the lung, keep a tidal volume less than 4 ml per kg, FiO2 less than 0.4, PEEP less than 10, rate less than 10 per minute, and inspiratory pressure should be less than 20. For the heart, you decrease the inotropes to minimal and keep a pulse pressure of more than 10. So pulse pressure map, you get a target. You may compromise a map target a little bit if your lactates are not going up, your output is there, your urine output is good, but don't compromise on the pulsatility completely. Finally, these are guidelines for ventilation. Basically, they add nitrogen, and then they also recommend moving the patient to CPAP or to extubate the patients if you are meeting. But VV ECMO, we don't extubate, we do a tracheostomy. VA ECMO, we extubate. Okay? Because the pathology is in VA is not lung. Monitoring, we do a ACT hourly, SpO2 continuous. Respiratory settings, you have to keep a watch on. Every time the patient desaturates a little, somebody will come and increase your FiO2 or 1 settings. Then you are just beating the purpose of the ECMO. So always keep a very close look on your ventilator respiratory settings. BP, heart rate, CVP, usual targets, usual ICU management, and pre and post membrane pressures. Itisha will talk a little bit about these. They are basically to check whether there is the flow is correctly, the flow gradient is correct across the ECMO machine. Daily monitoring, we used to have something called as plasma-free hemoglobin, which told us about hemolysis because of the basic circuit running all the time, and especially when you are on a high flow, there is hemolysis to some degrees. So, but we don't have plasma-free hemoglobin available as a point of care test in our hospitals. So what we go by is a peripheral smear or an LDH reading once in a few days to look for hemolysis. If once you start seeing hematuria, it's probably too much hemolysis, so we should stop. The cola urine can happen. Then your renal functions daily, your CBC and your hematocrit and your X-ray chest to see. X-ray chest is more to look for your cannula positions daily. You must see whether they are moving up or close to each other to account for your recirculation or your. So you have to keep a watch on your cannulas. Initially, there will be a whiteout of X-ray, and then after a few days, when your clinical picture improves, your X-ray will improve. So you're not really following it for that. And a coagulation profile you must do daily to meet your ST targets. And SOS, so you do blood gases. Sometimes initially when you're not meeting, you should do an ABG, SCVO2 both to look for your demand and supply. Then you can make it once a day or something like that. You don't need to do it very often once you meet targets. Usually you should meet ECMO targets in the first 48 hours. Otherwise you have to look for change of strategy, something's not working. Electrolytes, CRP, LFT, cultures and echo in a actually you do an echo daily or very often in a VA ECMO patient to see your strategy. While coming off again, you do an echo always in a VA ECMO. VV ECMO, you don't need not repeat echo.
What do we do when there is hemolysis? into the circuit.
You have to come down on the flow, or you have to change circuit because your oxygenators become old, you're getting more hemolysis, or you're running very high flows. So always keep your targets very realistic when you're on an when you're on ECMO. Don't try to aim for 100% saturation on the monitor or for 70-80 map on the monitor, because what you will end up doing is causing problems of the ECMO machine. So be happy with a PaO2 of more than 60 and an SpO2 of more than 92. Like what you would do in an ARDS patient on ventilator, do the same thing with ECMO, with rest ventilators. Okay? Then VA ECMO, the problems are vascular, thromboembolic. Of course, you're just putting blood into the arterial side, so you have to be very worried about that. Harlequins or north-south syndrome. Neurological complications very high because you are giving more heparinization also, as well as you are putting blood into, so you may cause embolic as well as bleeding complications and stroke. VV ECMO is mostly vascular, congestion of the limb can happen, there is recirculation which is also a correctable one, and neurological happens only when you cause very quick washout of carbon dioxide. So again I will say be very careful how fast you remove the carbon dioxide from, especially in a patient whose PCO2 was very high to start with. Don't rapidly wash out, that's what causes the neurological complications on VV ECMO. The teams addressing, we have the intensivist who takes daily decision of the ECMO, does the counseling for ECMO, activates the team, and all decisions for daily management of the patient clinically as well as the machine. Basically all the prescriptions of the machine, how much temperature you keep, how much flow, how much sweep gas will be done by the intensivist. The cardiac team will help with cannulation in OT or ICU with strategy changes, with the ultimate goal, like if it is a VA ECMO, then the cardiac team has to finally decide where we are going. Addition of cannulas to achieve flows or change in cannulation strategy, and coming off ECMO, they repair the vessels. The perfusionists will take care of priming of circuit and initiating ECMO, transporting patients safely from OT to ICU, securing all cannulations and connections, daily checks of circuits for clots, flow variations. So basically when you have a patient on ECMO, you must have an on-call perfusionist to come and troubleshoot the machine. Even though we are going to be teaching you troubleshooting of a machine, it's more important for you to be able to keep all the things ready for the perfusionist and call in on the time when they are needed, okay? And nurses will take care of the logistics. Basically, most important for the nurses is infection control as well as running the labs on time and getting, calling the right person to the right. So it is a team effort. Recognizing the alarms and calling. So you need intensivist, cardiac surgery team, perfusionist nursing for the ECMO, and ECMO equipment. A blood bank backup is very important. Diagnostics should be there. You should be able to do a CT scan in your and X-ray. And super specialty support is also important. Nephrology, neurology is usually part of the ECMO, program. So ECMO is a bridge to transplant, and it's a bridge to whatever. It's a bridge therapy. That is what you need to understand. And it's a window to stabilize the patient. We have to use it correctly, otherwise we'll end up, unnecessarily causing morbidity. Thank you.
This is very important. That lies in the bridge to the very important. It is not a cure.
It is very
It is
important
not
to
a cure.
realize that.
It doesn't cure your patient.
Good morning. I think it's always good to listen to the legends and learn from their experiences, but he only has given me the responsibility to talk on this topic. Myself, Dr. Pranav Mai, I'm a cardiac surgeon from your own city, Nasik, and I've been involved in last 5 ECMOs done in Nasik in last 2 years. Out of which 3 we couldn't, the patients couldn't make it, but 2 we could cannulate and one of them could be sent home. The problem with our team was we didn't know, when retrospectively seeing, I think we didn't know where that bridge should end. So for cannulation, is cardiac surgeon really needed? That's my thinking. I was thinking what to tell to the people about cannulation. Then I think we'll come to that question later, but I think cardiac surgeon is very important in all this process. Why? Because the whole external mechanical cardiac support was started with a cardiac surgeon called Dr. Gibbon. I think nobody must be knowing about him, but everybody must be knowing about the date 29th September. It's World Heart Day, and it's the birthday of Dr. Gibbon, who was working on development of cardiopulmonary bypass machine when the whole world was in war. 1953, he made a successful machine and operated first patient on his cardiopulmonary bypass machine, which in our OT we use it, the heart lung machine which Dr. Mule was talking about, which has a reservoir, which has a roller pump, and we do open heart surgeries with the help of it. And then comes our ECMO machine, which is a miniature form which doesn't have a reservoir, and it uses a centrifugal machine. Coming to the goals of care, in Nasik, we stick to only first A group. The bridge to recovery was our persistent thing. See, no, patient should go home, patient should go home. From Nasik itself. And then bridge to decision came with last patient when I was in constant touch with Dr. Mule for the guidance which was done in one of our hospitals, which was a VA ECMO. I'll come to that also. So the goals of cannulation is putting appropriate size cannula at appropriate position. So well begun is half done. The beginning of entire process begins with the cannulation, and the flow is everything. It depends on good size. The bigger the diameter and shorter the length, better will be the flow. To achieve a good venous drainage and an unobstructed return, whether in artery or in vein, is our goal. So there are different cannulation sites. Arterial cannula, central position, it is ascending aorta. In peripheral locations, they are right common carotid artery, femoral arteries, subclavian artery or axillary artery. Similarly, for venous cannulation, when it is central, we can cannulate in right atrium, superior vena cava or inferior vena cava. When it is peripheral, we can put it in IJV, internal jugular vein, femoral veins or subclavian vein. So the cannulation techniques, those depends mainly on type of support we require, that is veno-venous or veno-arterial, then age and size of the patient. Mostly when a child or a very small kid, we have to go for veno-arterial only because the veins are pretty small in these kids. Clinical situation, the patient requires emergency VA ECMO, we can put it peripherally because that's the easiest thing and fastest thing we can do. And skills and preference of the skills of the person doing it and preference of the center. So transthoracic or central cannula, they are usually done in cardiac operation theatres, especially done when the open heart surgery and difficulty in weaning off from the cardiopulmonary bypass, and then ascending aorta and RA are cannulated. And extrathoracic or peripheral ECMO are done with open technique, semi-open and percutaneous. These are self-explanatory words. In VA ECMO, it's already been discussed in detail by Dr. Jumana. The VA ECMO, the return cannula resides in arterial system and the venous cannula or the drainage cannula in the venous system. The VA ECMO functions parallel to support the native heart and lungs. So central cannulation, drainage of venous blood is through right atrium, and the arterial cannula is inserted in the ascending aorta. This cannula can be tunneled from the chest wall so that the chest can be closed, and central cannulation is frequently used in post-cardiotomic cardiogenic shocks, especially in pediatric after surgeries. So advantages are improved venous drainage because the cannula is directly into the RA, and it reduces the concern for upper body hypoxemia as compared to peripheral cannulation, as already been discussed in meantime. The disadvantages are sternotomy, the bleeding chances are more, re-explorations are there, mediastinitis can be there, and it precludes the patient extubation and mobilization most of the times. So then comes the peripheral cannulation. The venous drainage is from intrahepatic IVC using a 21 to 25 French multi-stage cannula inserted in femoral vein with its tip near RA, and less commonly the IJV can also be used. Artery return is in subclavian or axillary artery, but for that you all need me for putting a graft on the artery. In emergency situation, we can put it in femoral artery through Sediges technique percutaneously. So this is the pictures of last VA ECMO we done at Ashoka Hospital. So the in first picture is a left axillary artery cannulation. The graft was put end to side on the axillary artery and the arterial cannula was inserted into it. The patient already had IVP in situ and the right subclavian vein was accessed for inotropic supports. So I have to go for left-sided things. Left axillary artery and left femoral vein was used for ECMO. So the advantages of peripheral cannulation are they are easy to put. We can put with Sediges technique percutaneously also, or we can just cut down, expose the vessels and put directly into the vessels. It can be done at bedside. We don't need to go to the operation theatre, and can be accomplished in patients undergoing chest compressions like in CPR. And the disadvantages are there is upper body hypoxemia because as already been discussed about Harlequin syndrome, aortic root thrombus because heart or LV majority of time may get distended, LV distension, lower body, lower extremity, especially the limb which has been cannulated, ischemia, and peripheral vascular disease where we cannot put in femoral arteries. So this is Harlequin syndrome, hypoxemia of the upper body in peripherally cannulated via ECMO patients with concomitant lung failure or ventilatory mismanagement, where the picture as shown, the coronaries and the brain will get hypoxic blood. And this results from watershed that forms in the aorta when retrograde oxygenated blood from the femoral arterial cannula joins the undrained blood from the RA that transits through the heart. So these are some other types VVA ECMO where we put another venous line from IJV, or sometimes veno-venous ECMO can be converted by putting to VVA ECMO by putting another arterial cannula. So this is indicated in patients with significant LV distension due to inadequate drainage, or in patients where small vessel caliber prevents insertion of larger bore venous drainage cannulas. And also in veno-venous ECMOs where patient starts developing RV failure, we can convert it into VVA ECMO. So this is VVA ECMO where another line is inserted from the IJV, and there is another configuration VAV ECMO where part of the arterial flow is directed towards the RA, providing mechanical, circulatory and respiratory support. This is more complex thing because we have to manage the pressure and flow to the venous cannula because it is coming from the arterial side. This is VAV ECMO configuration. Coming to the graph again, subclavian or axillary artery cannulation, it reduces the concern for root thrombus and upper body hypoxemia because it is more closer to the coronaries and brain, and it gives antegrade supply to the body. But it takes time. We have to go to OT and expose the vessel, put a graft, and then initiate the ECMO. Lower limb ischemia, it happens on the side of the arterial cannula put into femoral artery. Almost 1 in 6 patients experience this, and 1 in 20 patients may require amputation for this. The solution is distal perfusion cannula, where we put another sheath distally into the femoral artery, or a graft can be placed on the femoral artery. So this is DPC cannula attached to the arterial line and perfusing the limb distal from the groin. And this is another picture is showing side graft to the femoral artery, where the arterial cannula is inserted into the graft and supplies on both sides of the artery. So pulsatility is important. It decreases the incidence of intracardiac or aortic root thrombus, as well as reduces the LV distension. Intracardiac or aortic root thrombus is dangerous because it can go to anywhere. Especially dangerous go to coronaries or brain. LV decompression, I think it's discussed with the Dr. Anvay Mule. The simplest way is to put IVP. It reduces afterload and decompresses the LV. It can be done surgically by putting a catheter into LA or directly into the LV apex, or an impeller device may work. Cannula sizing. Generally, cannulas are chosen to support a flow equivalent to cardiac index of 2.2 to 2.25 liters per minute per meter square per minute, which is considered full flows. Arterial cannulas are typically 15 to 25 French. Venous cannulas are usually 19 to 25 French. One can use ultrasound machine and Doppler machine to see the diameters of the vessels and put accordingly. Veno-venous ECMO is a therapy for respiratory failures, and it works in series with the lungs. Veno-venous ECMO provides blood to the whole body of similar partial pressure of oxygen. It's almost around 90 to 92%. As against veno-arterial ECMO, where the oxygenation is differential. The most common configuration with veno-venous ECMO is right IJV and either femoral vein. The femoral vein drains the blood and the IJV cannula returns it to the heart again. So the femoral vein cannula resides at the RA IVC junction or just below it, and the return cannula from IJV resides at RA SVC junction. Sometimes femoral veno-venous ECMO can be done in emergency situations, but it has more incidence of recirculation. Both the femorals are accessed, one for drainage and one for return. So the recirculation is already discussed by Dr. Jumana. When one cannula is too close to other, the return blood is again drained by the drainage cannula. So recirculation also occurs as a result of increased veno-venous ECMO flow as compared to the native flow, or due to increase in intracardiac or intrathoracic pressure, which impedes venous return to the heart. So we diagnose it with the help of chest X-ray or echocardiography or fluoroscopy, or clinically by seeing the color of the drainage cannula and the return cannula, or the partial pressures on ABGs. Treatment is withdraw one of both cannulas or inserting an additional drainage cannula, or we can use the double lumen cannula which is available nowadays. So this is a diagram showing the recirculation, and the B part is showing double lumen cannula, where which can be placed through IGV, and it drains from SVC and IVC, and it returns from a mid portion to the tricuspid valve and into the RV. So advantages are, it permits single site cannulation in the upper body, facilitates the patient extubation and mobilization, decreases the infection due to groin cannulas, very little recirculation risk. And the disadvantages is mainly it's very expensive, and it has to be put in cath lab or some other setting. Cannulation problems can occur at different procedure levels, like from puncture, putting guide wire, or threading the cannulas. So while puncturing, needles may transfix the artery and then enter the vein, which can cause arterial injury. Guide wire can be kinked or misplaced into RV or LA through undiagnosed PFO or opposite side iliac vessels when it's groin cannulation. And difficulty in threading venous cannulas can be because of too big cannula selection, vein spasm or left superior vena cava without innominate vein, pathologies like diaphragmatic hernia and pneumothorax causing severe mediastinal shifts, and technical problems like hyperextended or hyperrotated head. And the complications of cannulation can be vascular injuries, bleeding from the cannulation sites, for which you have to call a surgeon to intervene, arrhythmias and intrathoracic vein perforations. Thank you. This is the picture of our first ECMO patient who was sent home after 28 days of ECMO. And this is the entire team, and we always need a team for ECMO management. And we can manage it in Nasik. I think with the help of all intensivists and physicians, it will be easier for us to use the ECMO, and with the guidance of Dr. Anmay Mole and his team, we can manage to the bridge therapy to next level. Thank you. Good morning.
Khan. I'm a clinical application specialist with Getting It. Before starting with this session, I would like to thank Dr. Jumna and Dr. Prana for the wonderful session. So once we have everything, the contraindication, we have the right patient with us, what else we need to have a proper or a complete ECMO system to bring everything together, as in the equipment and the consumable part. To help with that, with Mackey Getting It, here we have the complete ECMO solution for you, starting with the equipment and the consumables. Equipment as the hardware. What does equipment and hardware includes? That is pump unit, which has drive and console. Next we have is heater unit, air oxygen blender, trolley with the cart, and holder for the oxygen and the cylinder as well. As now we have with us, that is complete ECMO system, and currently we have first generation Rotaflow. On my left hand side you have the complete system of Rotaflow. On my right hand side you have second generation and the most advanced one, that is CardioHealth. So you can see with Rotaflow all the equipments are there, the trolley cart, the IV stand, the console, heater unit, drive unit, and also in the center you have a hand crank. So what is the essence of hand crank over here? In case of electromechanical failure and to resume the therapy with manual operation, we need the hand crank so we can keep the therapy resume on the patient side. Disposable. So disposable vary from patient to patient, as in each disposable cannot be reused. What are the components in the disposable we have with us is cannula, Rotaflow pump disposable, oxygenator, heat exchanger, and tubings with connectors. So these are all the disposable you have in the set. Okay. Talking about disposables, what does disposable again include of or comprise of? That is cannula insertion kit. You can see the shorter ones with the red cap is the arterial cannula or the return cannula. The one with the The one with the longer dimension, can you see the longer one with the blue cap, is the venous cannula or the drainage cannula you have with us. Next is PLS kit. What PLS stands for? Permanent Life Support. The kit is approved for 14 days of usage. It can be also used for more than 14 days, that is up to 40 days as well. So in the PLS kit you have the Rotaflow pump, that is in the unique quad rock shape, the heat exchanger and the tubings as well. On my left hand side in the top corner we have the PKI kit, that is percutaneous insertion kit. We have along with us, that is a different part of the consumable for the cannulation purpose. So with components of ECMO, starting with first we have is console and drive unit along with the pump disposable, that is RF32, Rotaflow 32. So all these components together act as a working heart outside the body. In the extracorporeal circulation, all these three components together help us to manage or take over the function of the heart. Blender with the oxygenator. We have the quadrock shape oxygenator. Blender with oxygenator helps us to maintain the function of the lung outside the body. Cannulas with tubings act as an extended vasculature for the extracorporeal circuit or the ECMO circuit we have with us. So here how the PLS kit looks once the ECMO is initiated, once it is mounted on the patient side. You can see the diagrammatic representation on my right hand side, and once the ECMO circuit is primed and the therapy is resumed, this is how the circuit looks like. Okay. So this is a small animation just to show you how the cycle is. The blue part, the arrow which is facing downwards, is the venous side from where the patient is getting drained. Once the patient is drained with help of the venous cannula, next the blood enters into the centrifugal pump. In the centrifugal pump, when the force is generated, it is now moving forward towards the oxygenator side. In the oxygenator, it is getting oxygenated, whereas also the heat exchange takes place. In the essence of heat exchange taking place is maintaining the temperature of the blood. From the oxygenator, the blood is again re-infused back into the patient body. The red color dot which is moving back, it is into the return system or into the arterial system. So here with us we have the single lumen cannulas, that is the shorter one. As mentioned before, the shorter ones are the arterial cannulas and the longer one with the blue cap is the venous cannula. So, yes. So with us we have a wide range of cannulas, starting with the drainage cannula. The size ranges from 19 French to 29 French. Along with the size, we also have mentioned the length, flow and approximate patient weight. So we can take help of this chart to evaluate what size and what flow does the patient requires. Next we have the return cannula for which the size ranges from 13 French to 23 French. Again the same pattern follows: length, flow and approximate patient size. All the cannulas are specially designed for percutaneous ECMO insertion. So here you can see the picture. At the top we have the red arterial cannula inserted, and down in the femoral artery and femoral vein you can also see the venous and the arterial cannula inserted. One UPS of these cannulas are, they are tip-to-tip bioline coated. So what is the essence of tip-to-tip bioline coated cannula? We have that in the upcoming slides. Okay. So as Dr. Pranav has very precisely touched upon on the cannulation part, just a gist, what are the cannulation techniques we have with us? First is open technique, that is the central cannulation, semi-open and percutaneous. Semi-open in pediatrics where cannulation is a bit difficult. Talking about the PKI kit, that is percutaneous insertion kit. What are the components of the percutaneous insertion kit? You have the two-step dilator, two size one dilator, as in one dilator itself can dilate two veins of two different sizes. For example, 10, 12, 12, 14, 1416 and 1618. So you have 4 dilators in the kit, where one single dilator can dilate vessels of 2 different sizes. Next we have this J-tip stainless steel guide wire with advancer. So this is how the total kit looks like. So this is the whole component of the Rotaflow console and drive unit. Starting with the first part, that is the console with the drive unit. The upper part with the black color depression is the drive unit where we mount the centrifugal pump. So that is a magnet area where your centrifugal pump will be mounted, and in order to adjust the RPM and the LPM or to have any alarms or settings, we use the console. Rotaflow has integrated flow sensor and bubble sensor. So in case we need to use the console with the HL20 unit or any HL unit, we can also use that, as the machine has integrated bubble sensor and flow sensor as well. Next we have is the again the emergency drive unit, that is the hand crank to resume the therapy in case of any electromechanical failure. Down you can see the again the drive unit with the black color depression. So that area shows where the jelly has to be mounted. So the jelly is used, what is the essence of using that jelly? So your flow, the LPM can be sensed by the centrifugal pump and it will be displayed on the screen itself. The red color dot is nothing but how precisely you have to glide the centrifugal pump. You just cannot make sure, like you just put the centrifugal pump in the drive unit and it will sit automatically. You have to glide it in a 45-degree angle and match that red dot so it fits properly and there is no breaking or there is no cracking of the centrifugal pump or any connector in the pump itself. Okay, here talking about centrifugal pump and its working. We have been familiar with working of the roller pump. The churning of the blood takes place. The blood is displaced in the forward direction with help of the tubings getting churned or compressed by the roller pump. But here with centrifugal pump, the difference is the centrifugal pump is magnetically coupled. Now how it is magnetically coupled? Once you have the centrifugal pump, it is mounted on that black color depression. Everybody can appreciate that depression. Once you mount it on that black color depression, an electric field is applied. What happens when the electrical field is applied? The center portion, if this is my centrifugal pump, the center portion will be negatively charged. So essence of the center portion being negatively charged is that your blood will be drained in the center, and after the electrical field is applied, the blades will start moving. Your blood is getting drained, your blades start moving, now positive pressure is created in the centrifugal pump. Once that positive pressure is created, your blood will be propelled outwards towards the patient side. So this is how the centrifugal pump works. And negative pressure, as in low pressure zone in the center, because we are draining the patient, right? So the center part is low pressure and negative pressure, whereas the outlets are positive pressure and high pressure zones. This is how the vortex is created. You can see the vortex once, for example, in morning we take a cup of tea or coffee, we add some sugar, we stir it. Once we stir it, can we see the vortex created? When that vortex is created, the down part, the most lower part is negatively charged and the peripheries are positively charged. If I drop a piece of paper in that vortex, that piece of paper will move in the peripheries itself because it is positively charged. Same works in the centrifugal pump, as the blood will be propelled outside, that is on the positive part. So negative pressure at the inlet, working is it draws the blood to itself with negative pressure and propels outward with the positive pressure. This is the working of the centrifugal pump. Okay. So what are the ideal features or what characteristics should a centrifugal pump comprise or should have? Starting with first, higher efficiency with lesser RPM. 5000 RPM provides 10 liters flow per minute. So any centrifugal pump we take, ideally it should have lesser RPM and provide greater flows, as in lesser churning of blood, lesser complement activation, but greater flow offered on the patient side. Less hemolysis, minimal heat generation, less thrombogenic, no sharp steel, one point bearing. No sharp steel as in if there is a higher numbers or larger numbers of shaft and seal, there are chances of blood getting stagnant at that zone and chances of thrombotic events as well. Less resistance, and it works on Gyro's principle with laminar and radial flow. No stagnant blood zones. Approval for 14 days. 14 days for the adult kit. The PLS kit, as mentioned before, permanent life support, comes in two different parts. First is the adult kit, which is approved for 14 days of usage. Second is the pediatric kit, which can be used up to 30 days. Next is minimal transition time, that is MTT, as in blood should not stay transit at one point. Again, the same thing comes up. If it stays stagnant or stationary at one point, there are chances of clot formation or any thrombogenic event in the centrifugal pump. So, working of the centrifugal pump is preload dependent and afterload sensitive. What this diagram signifies is making this more simpler. Preload means in any condition, if the blood is entering the centrifugal pump, then only the forward flow will be generated. While in roller pumps, what we see is if the roller pump is working, there is no preload, then too it will have the forward flow or air can be passed to the patient side. But with centrifugal pump, in case there is no preload, no afterload will be generated. So in simpler words, it is preload dependent and afterload sensitive. Afterload sensitive as if there is, if we have the ECMO circuit, anybody has a clamp or kink on the afterload side, the pump will automatically stop. Or it will keep running but no blood will be forwarded or moved to the patient side. So it is preload dependent and afterload sensitive. Discussing about the contractility, if the preload is good, if the patient heart is pumping good, the machine will automatically reduce the flows. So it does adjust according to the working heart, or it does moderate itself according to the working or pumping of the heart itself. In case the contractility is high, it will decrease the flow. In case the contractility is less, the higher flows can be offered to the patient side. So in simpler words, centrifugal pump are preload dependent and afterload sensitive. Any resistance after the pump will make the pump stop and no forward flow will be generated. So the membrane oxygenator, the quadrox shape oxygenator we have with us, what are the ideal principles of the oxygenator is, it has diffusion membrane made up of PMP, that is polymethyl pentene, plasma coated tight. What are the functions one ideal oxygenator should perform is oxygenation, CO2 elimination, low pressure drop, long duration and heat exchange fibers in it. Talking about the heat exchanger we have with us, it does help us to adjust the temperature of the perfusate we have in the ECMO circuit. So, in case we have a patient on ECMO run, how will you analyze how is your quadrox shape oxygenator working? So in the first picture, you can appreciate blood coming from one side and getting released from the other side. Once the blood is entering, you can appreciate the darker color of the blood. Now it is getting oxygenated and moving to the patient direction. In the second picture, you can see blue and green color dots that are nothing but fiber mats. So what that fiber mat says that in the blue dots, there is water flowing. As in the water or the, you can say fluid coming from the heat exchanger flows in the blue pathway. Whereas the gas, the FiO2 connection we attach flows in the green pathway. All these fiber mats are arranged perpendicular to each other, that is 90 degrees. So whenever we have a ECMO oxygenator, what matters is the pressure drop. Lesser the pressure drop, greater the flow or good flow is given to your patient. So this 90 degree perpendicular fiber mat design makes sure that when you have the patient on ECMO run using this quadrox shape oxygenator, there will be lesser the pressure drop. And the blood flows outside the fiber mat. Can you see in this direction the red color on the outer side? So blue side your water is getting released, on the green side your gas is flowing, and outside the fiber mats there is the blood flow generated in the oxygenator. You can, the last but not the least picture, you can see blue color arrow facing outward. That is nothing but the vent port. In case of any accidental air entry, if I have a patient on ECMO and there is any accidental air in the circuit, you have to just simply release the knob, the yellow color knob, so the air can be vented into the atmosphere with the help of the vent port. The vent port is also very essential when you do the priming procedure, because during the priming what we do is we replace the air in the circuit with fluid, so that air will be vented out in the atmosphere with help of that yellow color vent port, and vent port are specially colored with yellow in all the ECMO circuits. Okay. So as discussed before, this is the normal blender, the secret blender. We have the blender and the FiO2. Okay. Oxygenation is titrated by FiO2, whereas CO2 is titrated or can be controlled by the sweep gas flow. So, in oxygenation, what are the other factors that control oxygenation in the membrane lung? First is the amount of O2 delivered in the system. Patient's own HB and hematocrit plays a very important role in the oxygenation part. Blood flow, surface area of the oxygenator, rated flow and FiO2 of the ventilating gas. Why surface area is essential? If we open all the alveoli in human lung, they can cover the half size of the tennis court. So that half size of the tennis court function should be taken over by this single small oxygenator. So that is the reason why having greater surface area is important. The human lungs are so huge and so compliant, but that function should be done properly by this small unit, this quadrox shaped unit. So is the essence of the surface area in all the oxygenators. The CO2 is controlled by again the same sweep gas, and surface area remains the same as an essential to control the CO2 release in ECMO circuits. So the PO2 and PCO2 on the higher side, the green color line is the gas permeable surface. How the exchange takes place once you have initiated the ECMO, once you have set the FiO2 on the 100, you can see PO2 is 400 plus and PCO2 is 0. Now this happens when the gas exchange takes place. This slide just, the message of this slide is that once the ECMO is initiated with 100% FiO2, you can see the O2 saturation rising from 70% to 100%. The CO2, PCO2 decreasing from 45 to 40 and PO2 rising from 30 to 350. So once the therapy is resumed, these are the essential changes you will see on the patient side. The dark venous blood changes to good red color, saturated blood, which is indicated with red color arrow. So the ECMO tubings we have in the circuit, what are the features of the ECMO tubing, what essential features they should have? First is non-toxic, non-irritant medical grade PVC material, soft and kink resistant, phthalate free, and they should be tip to tip bioline coated. Okay. We have came through this word bioline coated numerous times. So what is bioline coated in simpler words? It is a combination of pharmacologically inactive heparin bounded with albumin. So on this surface, the triangle shaped and there is one small yellow color line on it. So that is nothing but on the ECMO surface or on the ECMO tubings, this coating is done, that is bioline coating with albumin and heparin. So once this coating is done, once the blood enters, the coating is swollen. Can you see on the second picture the coating getting swelled? So once this coating is swelled, now what we do here, what we are doing is we are treating the blood. In simpler terms, we are making it feel it is still inside the body, because this layer mimics the endothelium. So once the blood is entering a bioline coated circuit, when we have a ECMO run, first thing we always come through is decrease in platelet count. Drastic decrease in platelet count. So in case you have a bioline coated circuit, the negligible or there is quite less decrease in platelet count. Once the ECMO run is initiated, after some days, after some time, blood itself forms a layer on the ECMO circuit. So there are once the blood has formed the layer above the bioline coating, there are very less chances of any platelet count reduction here. So just essence of this slide is that during initiating one ECMO, first thing is once the bioline coating is there, the platelet count is less decreased, less complement activation, less SIR's reaction on the blood side. So this is a microscopic image of a coated and a non-coated circuit. On my left hand side you have a non-coated circuit. You can appreciate the roughness of the non-coated circuit. So when the blood flows through the non-coated circuit, there is stress on the blood, turbulence added to the blood. On the coated surface, you can see the surface is quite smooth. So the blood run in the ECMO circuit is in a very smooth manner, less turbulence, less shear stress on the blood, less complement activation, less churning or less damage to the blood components as well. So this was all about the ECMO system we have with us, the consumable part, the equipment part. Once we are done with the presentation, we can surely have the hands-on session and the bed drills for everyone. Thank you so much for your patient listening.
People who need to manage these patients, you have, and always keep the patient family in the loop and give them the expectations that they should have from that day. So usually the first 24 hours are intense when your patient goes on ECMO. They will require, the patient can crash at initiation, the patient may not tolerate that configuration of ECMO. After 24 hours, we have a better idea that the patient is, you start achieving some stability and it plateaus for the next 48 hours, and then you start looking at recovery or next strategies. The surgeon, intensivist, perfusionist role and ICU nurse role I've covered, and we start on the physiotherapist and respiratory therapist, but these allies are extremely important because as soon as a patient is on ECMO or stable on ECMO, you have to start looking at rehabilitating patients, because these patients have been already receiving intensive care treatment for say 7 days, 8 days. Their muscle power has become zilch, they have been paralyzed all the time, heavily sedated. So you can start the rehab as soon as your patients are able to are achieving goals on ECMO, because you're backed off on the ventilation, make them comfortable, keep a level of sedation when they are awake, test their neurology and start their nutrition as well as their muscle power. The types of ECMO we know, but always remember that there is no hemodynamic support in veno-venous ECMO. So your hemodynamics is supported the conventional way with your pressors, inotropes. If your requirements are going up, assess whether the patient is becoming septic, whether the patient needs more fluid. As soon as your hemodynamics suffer, your ECMO holes will suffer all over again. So that is the most important thing to remember. As soon as you're putting a patient on ECMO, you have all these things in the room. So first thing when you start planning is you must have space. You may have to create an OT atmosphere in the ICU, so start clearing off all the excess furniture from the room and get in most, you may have a CRRT machine already on standby, ready to start, because patient's renal function is bad, but you're going to give a trial of ECMO, start the CRRT. You need to have an ACT machine, lot of syringe pumps, a backup machine. So in Singapore, we used to have a backup ECMO machine. In case one fails, you put on. Here we don't have that. So at least whatever backup we have on the machine should be there. That is the hand crank and the clamps and a couple of other things which we will tell you in the practical session. So everything should be rounded up. This is the nursing role to get this everything organized, and you have to give clear instructions. The labs that you will need, I already covered it in the previous lecture, the ABG, CBC, all this will either be to manage later or to decide what kind of ECMO you're going to give this patient. So all these investigations will tell you that. We already covered that in the first lecture. So the activation, you have to take a call. Are you going to do immediate ECMO insertion at bedside? If no, are you inserting in the OT? If yes, you have to do a complete pre-op checklist, standby blood, ensure that a consent is signed and send the patient to OT, so like a pre-op case. If you are not going to send to OT also, then you prepare a bed to shift the patient to an ECMO unit. If supposing you are in MICU and you are doing it in CT-ICU, you shift the patient to the ECMO unit so that whenever the decision is made to do ECMO, you are already ready with all of it. So sometimes the patient is in borderline condition and you are still not ready. You're counseling, but to always shift them to the safe area early. If you are going to insert bedside, then you have to do a lot of things. You have to move the unnecessary furniture, get the consumables that you need for the ECMO initiation, get the heparin ready, assist the same pre-ECMO catheter insertion, whatever. So sometimes you just put in a quick line in both the fem artery and fem vein while you are getting the ECMO scenario ready. So that you can do a thread, or you can put a guide wire and thread over it. So you can put a single lumen in the fem or the IJV. Most important is you will have to change the IJV. Most of us have a right neckline as a standard. When you are thinking ECMO, you will have to shift that to the left side because your ECMO cannula will come on the right. So when you start thinking ECMO, you can change these lines over. If you are thinking VA ECMO, make sure you get a right radial artery in place. So this is your preparation to go on ECMO, okay? And you get all the departments rounded off. So if you are the person driving the program, then you have to call the perfusionist, inform, call this thing, make a strategy with your team, call the OT, and let the nursing manager know that you will need 1:1 or 2:1 nursing. And after the ECMO insertion, you have to get the patient safely back from OT if the patient is in OT. All these steps are extremely important. You can lose the patient in any of these steps. Till parked and handed over correctly, your job is just starting, So the ECMO machine, you have to hand over the power source when you come back. Okay, you have to see this line. Also, all this will cover in the hands-on, but the power source, the battery indicator should not be blinking, and the alarms are set appropriately when you start off. The perfusionist will help you with this. The gas supply, you have to be sure that you have taken the gas supply from the oxygen cylinder and put it in the mains, the center. Okay, if that step is missed, after some time your cylinder will wash out. Your ECMO is still running, but your patient is hypoxic and you don't know what's happening. This is the green line which goes from the machine to the blender. So that green line you have to check. Then you have to check how much sweep flow you have set, as well as how much is the sweep FiO2. Okay, so sweep flow should be how much? Half or 3/4 of your flow, your ECMO. Okay. And the FiO2, when you start, is always 100%. Then you start weaning off depending on how your patient is doing. Titrate the ECMO gas blender instead of the ventilator. So always just whatever goals you want to meet early. So first, your ventilator settings are very high. You have gone on ECMO. You can come down on the respiratory rate, your FiO2, as well as your so respiratory rate and FiO2 and tidal volume, or your pressure control, whatever PS you say. Don't come down on the peak very fast. If the peak is 15, come down by 2 at a time. Otherwise, you may cause sudden, pulmonary edema because of coming down too fast on the peak. But you are aiming at very low ventilator settings. So at least wean down the FiO2 as well as the ventilator, whatever is causing harm to the patient. Sleep you slowly wean off. And you go to 100% on the ECMO blender. And then you check the first APG, usually we check 1 hour after we go on ECMO, and to see whether there has been an improvement. So within 1 hour, some amount of the PO2 improvement and carbon dioxide washout has happened. Then you can further, play around with the carbon dioxide and with the flows basically. So initially you will go on a flow. So as soon as you go on ECMO, usually if it's BB ECMO, you will see the saturation stabilize. If it has been at 80 all the time, it will go up to 100. Then you go back, go down on the ventilator settings, it will come down a little bit. Then again, you may go up a little bit on the flow, it will come up. So all this fine tuning you can do. First day you may do ABGs 2 hourly or 3 hourly. Then next day onwards you can do 8 hourly and see what is happening. The heater cooler unit, very important to hand over. Suddenly you will find your patient bradycardic, coagulopathic, and you don't know what's happening. So you have to hand over the heater cooler unit with a prescribed temperature. Sometimes they will set at 37.5 for example, or 38. The patient is warm, vasodilated, you are not meeting ECMO good. Basically because the patient is too warm. Patient's too cold if you don't start this unit. So it gets missed very easily because it's not on the monitor of the ECMO machine. So please make sure you see that it's connected and started. And you have prescribed a temperature to your handover, in your handover. The sensor should be clipped on properly so that you get whatever feedback you get. Otherwise, it will keep alarming. Then you should always have the backup, hand crank and the clamps. Minimum 2 clamps bedside. This is all backup machine equipment. There is a checklist, handover checklist, where you have to see the power source, the gas supply, the heater cooler unit, the flow sensors and the backup equipment. This is a sheet we use. You can have in your monitoring in the ICA, if you all have ICA or whatever you have in, or you can have a chart where you have specified what is your starting blood flow, what is your pump speed, what is your sweep FiO2 and sweep gas flow, then your if starting ABG, SCVO2, hemoglobin, and your targets. So in the targets we write in this ECLS treatment sheet where every target you write. So if you say I want platelets more than 50,000, then they have to raise it to you if the platelets are falling below 50. You can still take a decision whether you want to transfuse or no, but you have to be informed about it. Hemoglobin target you have to say, temperature target you have to say the care plan of the day and investigation. So this kind of so the bedside nurse needs to optimize the neuro status, cardiovascular status, respiratory status, GI status, renal status. Basically what nurses do, like but as I tell, you have to give a sedation vacation within the first 24 hours. As soon as, within 12 hours also, as soon as you meet goals, please wake up the patient. You have to know the neurology. Sometimes you receive the patient in a ventilated, paralyzed condition, sedated, paralyzed, and you don't know really the neurology. You just go by pupils and they say, he was awake before we started the sedation. So that's all you have to go by. And these patients have been prolonged hypoxia, so they may never wake up after you go on ECMO. First thing is give a sedation vacation, wake up the patient, show the relatives. After that, you start giving, then you see how much the patient is tolerating. Sometimes they tolerate well the tube and they, you can keep them with low sedation. But by low sedation, I mean comfort. So usually I use fentanyl and bucket loads of fentanyl because 70% of the fentanyl gets absorbed in the circuit. So if you are running the regular 50 mics per hour, it's not going to work. Usually these patients need up to 300, 400 mics also, so long as they are comfortable. If you can manage it with only fentanyl, then why not? It's not going to cause any harm. Then otherwise you fall back on dexmedetomidine, depends on your hemodynamics, your propofol. I like fentanyl and dexmedetomidine because I can maintain them comfortable and awake and cooperative. Propofol of course becomes an anesthetic agent. Then neurological status, you have to, if the patient is not woken up, then you have to go or do a CT on ECMO. Many institutes want to do a CT before putting on ECMO, but it's not practical to do that. You can do ultrasound, you can do bedside, whatever you can do, but you can't really transfer. But once the patient is on ECMO, not waking up, you have to do a CT scan to decide what you're going to do next. Keep a low threshold, but don't rush into it. Feel that they will wake up, then it's okay. Your pupils are safe and there's not been very much downtime, you can give them time. And you have to assess for intracerebral changes, that is hemorrhagic or embolic, if there is any change in neurology. Psychosocial, once they wake up, you have to reorient regularly, get the family to meet and and start telling the patient what is the next step, because you know how things are going. You have to assess and make plans so that you can rehabilitate and start physiotherapy. Please rehabilitate on ECMO. Don't. It's a bridge. It's a safety net. Please use it correctly. Then only it's important. You know you do. So if you just keep the patient again paralyzed, sedated, ventilated, and on ECMO, I think you're just compounding the adverse effects of both without getting anything out of your run. So cardiovascular system management, you have to maintain systemic perfusion and intravascular volume. So you have to check for systemic perfusion by seeing your SEVO2, whether you are getting, if you are, you know, whether your patient is, the lactate is normal, your SEVO2 is normal, then you are achieving goals. And you have to maintain certain amount of flow, so you may have to hydrate these patients initially before drying them out. The volume status has to be assessed by your urine output, CVP, and your mean arterial pressure. And the native cardiac output can be enhanced by inotropes to maintain a pulse pressure of more than 10. Okay, I'm repeatedly telling you that just maintain contractility. Don't worry if it is low contractility, but it has to be some contractility. At the same time, maintaining a good map on VA. It's okay if your BP is like 80 by 70, don't panic. You're getting somewhere. But if it is like 70 by 70, like only a map and you need to do something about it, and you have to think of next strategies, which we have see. Again, ventilation management I have discussed. Decrease the ventilator settings. If permissible, even go to spontaneous. So the only thing is, if your patient is not comfortable and is hyperventilating, there is a sheep study where they gave oleic acid to 10 sheep after putting on ECMO and studied the esophageal variations as well, esophageal pressure as well as the rate while they were, normal healthy sheep and ARDS sheep. So the healthy sheep did not alter their, but the ARDS sheep, their respiratory rate increased to 30, 40 as well as the esophageal pressure increased 10 times from what it was in healthy sheep. So this can lead to spontaneous induced lung injuries. So if that is happening, then you have to sedate better and stop the patient from spontaneously. So you have to find a sedation window where the patient doesn't hyperventilate. You would think that washing out the carbon dioxide on the ECMO machine will suppress ventilation in these patients. There's another study which showed that it took almost, to get the patient apneic, you had to really wash out a lot of carbon dioxide, get the PCO2 to almost below 10 before in ARDS patients. It was not that way in COPD and bridge to run ILD patients. So ARDS patients somehow they get more hyperventilation and more spontaneous induced lung injury. You have to take care of infection control in these patients. You have put 2 huge cannulas and there's a lot of lines to manage. If you're going to give them infection, then that's the end of the road. So, and chest physiotherapy you must do. All physiotherapy I feel you must do. Sit them edge of bed. Don't worry about the cannulas, whatever. All these patients will have one femoral cannula. The access cannula is not too much of a problem because it's a very long cannula going right up to your diaphragm. So there is almost 35 to 40 centimeter inside the body. It may get pulled out slightly. You check on it every time you mobilize the patient. It doesn't kink. It usually kinks at insertion. It doesn't kink at movement because it is wire reinforced like your endotracheal tubes which are wire reinforced, which we use in prone position and difficult position. So you can mobilize these patients with your groin cannula. The return cannula is something you have to be very careful of because that is only 5-10 centimeters inside and that can slip out very easily. So whether it is your neck or your, again the femoral return cannula will have a distal reperfusion cannula in it. So it is sort of sutured at many places. So it doesn't slip out as much as the neck cannula does. So be very careful about the tubes and there is a definite way to mobilize these patients. Hemodynamic monitoring, remember the patient's own hemodynamics. So you have to monitor everything like you do. For VA ECMO, you have to manage a map of more than 65 and the ECMO flow should be more than like you should make sure that the cardiac index is more than 2.2 and there is no tugging on the this. We'll talk about that when we are bedside again. What if you have lethal cardiac arrhythmias on a patient who's on ECMO? If it is a VA ECMO, you can only deliver shocks, no CPR. Okay, if it is a VV ECMO, you will do CPR. If you do CPR in VA ECMO, you may dislodge and you will lose the support that the ECMO is giving. So arrhythmias is, the cure is ECMO, you don't have to do anything. VV ECMO, you have to perform CPR. Just remember this and teach this to your staff. Otherwise, they don't know what to do. Okay. Respiratory system management, again, like I told you, I think we've visited that many times. Gastrointestinal, so how soon can you start? A recent study had, we studied some prospective and retrospective feeding studies on ECMO patients. Well, it's the same as your other patients. If you have any high lactates, if you're thinking that there is GI edema as well as ischemic changes, don't start early. Otherwise, the average time, and so when you're on BA ECMO and the patient has been on inotropes for a long time, you may need a little time before you start unless you have good numbers. But VV ECMO, there is no contraindication, and on an average within 13 hours everybody has started feeds. And only 4% in one of the prospective studies of 107 patients, only 5 patients had some sort of GI bleed or GI, sorry, not GI bleed, ischemic gut injury. So it's quite safe to start with early feeds. Please insert your NGs beforehand and please ensure bowel movements to add prokinetics early. Fluid management, what we do differently in this is that you look for hematuria. So all your other things are icing management. You want a good urine output and you want to dry these patients aggressively once on ECMO. But you have to look for heparin, hematuria for your cell lysis, and you can do your plasma-free hemoglobin to check for that. Skin care and dressing, there is always a lot of hematoma as well as cannula site bleeding, so you have to look for that and manage that. And usually a good pressure bandage in the area or a stitching time helps a lot. Regular, you must turn the patient on ECMO. So basically once you get on top of the bleeding, you're okay. You have to take care of back and use transparent dressings so that you can pick up the, so what I do is I put small gauze pieces at intervals and use the transparent dressing so that if there is any bleeding, it should be like watertight, so it just collects and clots off inside. And put the pressure relieving mattress earlier. So the risk and complications of ECMO are infection, clots, stroke, bleeding, air embolism, limb ischemia, DIC, pressure ulcers, cannula, that is your, and cannula dislodgement. Hand hygiene important. Document. So you have to document clots or air bubbles in the system. This is done daily by the perfusionist. They put a tape everywhere they see a clot. And what you see is a very thin fibrin film. So almost it's white in color usually, not like what we imagine a clot to be. And you have to write the date when you saw it and where you saw it. Bleeding, you need to avoid, you need to maintain your platelet counts, avoid the invasive procedures on ECMO. You have to maintain the INR in the normal range, give your FFP, keep a low threshold for giving FFP and vitamin K, and fibrinogen in the normal range. Platelet is a tricky thing, so be careful how much platelet you give and when you give. It usually falls very fast. It starts halving sometimes as soon as you start, and then it stabilizes at some point, like Refresher said, when your biofilm is formed by your own blood. But it is quite distressing to see your platelets go down. So look for any bleeding complications. If you have bleeding complications already or you're anticipating, then replace. Otherwise, they will go and block off your. So heparin, we all use IV heparin. There are other agents, but the monitoring is difficult and availability is not there for pyrolinidine and gatroban. They have all been used on ECMO. basically we don't have anti-10A monitoring, so we go by ACT and APTT. ACT is bedside, cheap, but it is a little non-specific, so sometimes you don't meet the target, you can't make out whether you're meeting targets. That's when you do APTT. What we used to follow was APTT, where I said in VV ECMO 45 to 65 seconds, while in VA ECMO 50 to 75 or 55 to 75. So we would start at 10 units per kg per hour, and then we would do our first APTT after 6 hours. The target is met, the next APTT after 6 hours, then every 24 hours. The target is not met, you have to titrate it. So we used to titrate it this way, where less than 35 you give a bolus and then continue at a higher rate. So this is what we use, and otherwise we used to do every 12 hourly APTT check once the target was met. Then limb monitoring, very important. Distal limb perfusion cannula, you should see that it is not blocked off. Your peripheral, you should do a Doppler, look for mottling, look for any signs of limb ischemia. It's one of the most common and most devastating complication of a peripheral VA ECMO. So we have to get on top of that. Another thing that so otherwise we need to put a graft if we feel that this is suitable. Then specific care of ECMO patients, anticoagulation, ECMO cannula, anchoring and circuit. So you look, listen, feel. Care of the cannula, you have to make sure that the dressing, so basically, your lines should be properly fixed at intervals. So there is no tug. So, there should not be one single dressing, it should be at intervals. And there should not be any torsion or tension on the line. And skin marking on the peripheral cannula should be done with a permanent marker to see where it was when you fixed it initially, so that any slippage can be visible. And you must do a line check every shift or every time you come in the morning. Your ECMO, you have to start from the dressing, you have to see all the marking as well as how your cannula is. Then you have to look for kinks. So if you are not meeting targets, first you will look for kinks, and look at the tubing. Look at the tubing right from the patient end till the machine, and look for any clots, kinking, air bubbles, dislodgement, and what is called as dancing flow. So what happens in a dancing flow is you have a patient, you have put a cannula in the IVC, which is a kind of collapsible, it's a vein, so it will collapse. Now if you are on a very high flow, you are sucking at a very high level, there are holes on all the sides of the cannula, the vein goes and sticks to the cannula and your flow gets cut off. 2 seconds, 3 seconds of flow is cut off and then it loosens up again. And again you are on a high flow, so this happens cyclically. So this is called as dancing flow, because outside what you will see is your lines doing this kind of a chattering or a dancing movement. And on your monitor, if you see on your console, your flows will go from 4 liters to 2 liters, back to 4 liters, back to 2 liters. Sometimes this is tolerated, sometimes you will start seeing hypoxia or hypotension depending on what configuration you are on. What you can do in that case is, if you are running a very high flow and your negative pressure is too high, you can try coming down on the flow slightly if your ECMO targets are met. And instead of expecting 100% saturation, if you are getting 92 but there is no dancing flow, then that's fine. So you first come down little bit on your, secondly you look for giving little volume so that the vein is not so collapsible. IVC is not so collapsible. Thirdly, if the patient is hyperventilating, you try to come down, you try to improve the sedation, so that again the intrathoracic pressure is not causing this kind of a flow. If you have done all of
Good morning. Myself, Dr. Preetham Mahirao. We'll be starting next lecture. Will be delivered by Dr. Mufazzal Lakrawala, popularly known as Dr. Mufi. Sir is India's best known laparoscopic surgeon, specializing in bariatric and gastrointestinal surgeries. Sir is a director of surgery in the department of in Hospital HN Reliance Foundation, Mumbai. Over the last 2 decades, Sir has helped thousands of people to get rid of obesity and obesity related issues like diabetes. Dr. Mufi Sir is honorary surgeon to the Vice President of India, Mr. Venkaiah Naidu. So over to you, sir.
Thank you, Dr. Preetham. I hope you can hear me loud and clear.
Yes, sir. Please share the slides.
I think this will be a little better. So I'll just share my screen. Today I'm going to speak to you on something which is is it visible?
Yes, sir.
Yeah, okay. So I'm going to speak to you on something which is pancreatic surgery. Like Preetham said, we've now started doing at the Sir H.N. Reliance Foundation, we've started doing a lot of minimal access surgery. Our intent is to develop one of the best of its kind minimal access surgery. We already have a very robust gastrointestinal department that feeds in these complex cases to us. So we've always thought of laparoscopy being for gallbladders or for appendix or various other things, but we've never really thought of it going beyond that in the realm. Well, laparoscopic surgery, as you would know, was started by Professor Eric Mouet from Germany and Professor Philippe Mouret from France. Around same time, both of them started when they attempted to do a laparoscopic gallbladder. Now, the funny part is that these gentlemen were not really surgeons per se. They were gynecologists who had actually started off with their journey in laparoscopic surgery. But laparoscopic hepatobiliary surgery or pancreatic surgery or various other things like took much later to come in. So it was all limited to just a gallbladder or an appendix. Hernias came much later in their journey. So what were the reasons? Well, the reasons for delay in uptake of laparoscopy and pancreatic surgery was very clear. All right. The problem was they were technically demanding. We had a very long learning curve. And that is why nowadays you see there are a lot of people are adapting to the robo, because robo kind of allows you access it and gives you a much better 3D view and various other things. Then tumor localization was very difficult, actually. So because tumor localization was very difficult, you had to go in and put in the laparoscopic ultrasound. When the laparoscopic ultrasound came in, then you could locate the tumor correctly, you could locate the pancreatic duct correctly, you could locate the nodes, the vessels, and everything. So with the advent of the laparoscopic ultrasound, kind of everything changed. So endoscopy kind of came in, and a lot of procedures which were so far not possible to do in open surgery, endoscopy like the ERCP, the MRCP came in and did imaging wherein you didn't even need to do an invasive endoscopy. But when endoscopy came in, then laparoscopic enucleation of neuroendocrine tumor, laparoscopic necrosectomy, laparoscopic Busto's procedure. So that's where laparoscopy came and changed the entire field of what we started doing, because the morbidity came down. We've heard of a lot of people with acute pancreatitis. Now, the dictum in surgery is, when do you go in too early and do too much, or go in too late and do too little? So it's never really clear, even with the best of surgical brains, as to when to intervene in a laparoscopic pancreatic case. Now, especially with laparoscopic necrosectomy, when you might have to go multiple times to go and remove a little bit of the slough and the pancreatic necrotic material, people used to do something like a zip laparostomy, so that you could open the abdomen, go in, do various things, because fistulas were very common. Now, with the help of laparoscopy, you could just go and reinsert your laparoscope without too much of cross-contamination and do the same thing. Very, very large pancreatic ducts with multiple stones. They failed even despite multiple sittings of ERCP and endoscopic stenting. And that's where laparoscopic pustules really played a role. Here I'm going to show you a case of a pustos and in a documented case of multiple stones. As you can see, these are the CT images that you can see, and that's the massively dilated duct with this multiple stones. This is the laparoscopic view. We lift up the stomach by just a simple suture. And then we divide the greater omentum to enter the lesser sac so that we can get a view of the pancreas. That's us dividing the colon from the stomach so that you enter the lesser sac. We've got enough of, this is me using the harmonic scalpel. You can also use the ligashore, you can use the thunderbeat, various devices that are now available which make it very, very safe to do these kind of surgeries. Once we've lifted this entire thing, we identify the anterior surface of the pancreas. That's me mobilizing the duodenum from the pancreas. That's the entire pancreatic anterior surface mobilized along its length from the neck to the body to the tail. That's identification of the pancreatic duct by a single syringe. And once you've identified that, then you start making the incision on top of it. Remember that this in the times was very, very difficult because you really could not access the pancreatic duct without knowing where the pancreatic duct was sometimes if you didn't get a proper localization. Now with MRCP that is possible. And another thing that has completely changed the entire game plan now is your laparoscope. That's the stones that you can keep removing. They are big, big stones as you can see. And you can piecemeal remove. This is putting in a simple flushing tube to flush the entire duct out. Once we collect all the stones, you can see there are multiple stones. Now, this wouldn't have been possible endoscopically to remove, despite multiple sittings. Then you go and identify the ligament of Treitz. That's the starting of the duodenojejunal junction. That's the inferior mesenteric vein. And take around 30 or 40 centimeters away from there and divide it into two so that you make a Roux-en-Y loop so that bile does not come at the site of your anastomosis. Now, with the help of staplers, this is very, very, very possible and it's very safe to do. It hardly takes any time to create a jejunojejunostomy. Then you make a 75 centimeter or a 50 centimeter limb and do a side-to-side jejunojejunostomy. That's us. We use the white stapler to create a side-to-side jejunojejunostomy. We close this defect. With a monofilament 30 PDS suture. Once this jejunojejunostomy is complete, then we turn our attention towards the pancreatic or jejunostomy. Now remember that when you are doing a laparoscopic or an open pustos, the important thing is to try and do as many anastomoses as possible so that you can get a very, very large anastomosis. That's the pancreatic or jejunostomy. As you can see, I'm completing it. We do it in 4 layers, completely hand sutured, and that's the end that we get. Now, sometimes duct mobilization is difficult. As you can see in this video, this is how we put in, and you see us cutting where a little bit of pancreatic juice comes out and then we cut on top of the stone. This is another case wherein you're mobilizing the big, big stones. That's how big the stone is. As you can see, the entire stone will just come out of the pancreatic duct. This pancreatic duct is far larger than anything else. Now that is the laparoscopic ultrasound that you can see. It's a device that we can put in to localize tumors, to localize the exact extent of the pancreatic duct. Now with this help, you can see the superior mesenteric vein there, so you can lift up the pancreas, know where your exact tumor is, so that it becomes very, very easy for us. Now, what about cancer work? Well, in 1935, Whipple, who was a gentleman who presented a series of 80 pancreatic ampullary tumor resections in two-stage pancreatic duodenectomies. In 1941, he reported the single-stage pancreatic. That kind of changed the entire gamut. And to date, that remains one of the most challenging surgeries for any general or oncosurgeon to do, because the various anastomosis you have to do and various things. So it again, of course, will remain the biggest challenge for a surgeon going in. Malignancies, well, there are very, very few centers across the world that perform complete laparoscopic or robotic pancreatic oncosurgery. We are now one of those centers that is performing this surgery. So everything from a distal pancreatectomy with or without a splenectomy, a laparoscopic Whipple's, to a laparoscopic total pancreatectomy, all this can be done without giving you those vicious Chevrolet incisions, which are right from one end to the other, or complete laparotomy incision right from the xiphisternum to the pubic symphysis. So you can do it with either the rooftop incision, which is very painful, or the vertical midline scar, which is very, very large, just with mere few things. And now remember that in malignancy, you always need the entire specimen to come out. So what we do is we just create a small little phalansteal incision later and remove the entire specimen once it is done. This is a video of a young patient with the pot positionings of laparoscopic Whipples. Again, the same way, we lift up the liver, the stomach, and mobilize the body of the pancreas away from it. The next step is like with any defining step of any oncosurgery with the pancreas is to mobilize the entire superior mesenteric vein. That's the gastroepiploic vein, firstly, when we go off the stomach to mobilize, and that's the tunnel of love, us mobilizing the superior mesenteric vein. Now, this is the limiting step. In case the pancreas is adhered here, the superior mesenteric vein, then you might be in trouble and you might not be able to dissect the entire thing. Once you mobilize this entire tunnel of love, then you go ahead and cauterize the entire duodenum. Once you've cauterized the duodenum, that's the IVC. And where it gives off the left renal vein, that's the left renal vein, that's the limit of your dissection. As you can see, that entire veins, the nodal structures, all can be dissected very, very clearly. Then you take care of the gallbladder. Now, that's the entire CBD, and you can mobilize the lymph nodes of the CBD of the hepatic artery clearly. Then you mobilize the gastroduodenal artery, that's the common hepatic artery, and the branch of the gastroduodenal artery. Once you've clipped it, then you turn your attention towards cauterizing the entire duodenum and lifting it off. Once you've done that, then you divide the duodenum. If you're doing a pylorus preserving anastomosis, and then cut the CBD. Now you will see the stent out over here, because this patient would probably have been stented. That's removing the stent. And now the important thing is to mobilize it off the portal vein. That's the portal vein, to mobilize the entire CBD off the portal vein. Then again, you go and identify the ligament of Treitz. That's the ligament of Treitz that we had seen in the previous case as well. And mobilize the duodenojejunal junction and divide it here. Now is the time to divide the pancreas. Once you've lifted it up, you put in an umbilical tape to lift off the entire pancreas so that your pancreas is completely lifted. That's your pancreas. Now I prefer sometimes suturing the inferior and the superior pancreatic or duodenal vessels, because the main blood supply comes from here, and the bleeding, if any, were to come from this side. So I usually ligate the superior and inferior pancreatic or duodenal vessels. And then you can either use a harmonic or a scissor, whichever device you want to divide the pancreas. These are the veins that come off the superior mesenteric vein into the uncinate process of the pancreas. So you have to be carefully clipped and divided, because if at all any bleeding would happen from here. Mobilize the entire uncinate process from posteriorly off the superior mesenteric vein and divide it. And that way your entire tumor along with the lymph nodes will get dissected off the superior mesenteric vein. That's the lymph node. If at all any left behind, you can take it piecemeal. Then you mobilize the remaining part of the jejunum below the mesentery, and that's the pancreatic duct. There are two ways to do this. Either you do a dunking technique, wherein you put the entire pancreas into the jejunum, or if the duct is large enough, you close it in a duct to mucosa anastomosis. The advantage of a duct to mucosa anastomosis is that you have to just take 4 sutures. Because it's stented, the chance of it leaking is very, very low. And even if it does leak, the chance of it healing well is very good. That's how we dunk the stent, and your pancreatico-jejunostomy is kind of complete. Then we go ahead to the next anastomosis, which is the choleltico or hepatico jejunostomy. Again, once this is complete, then you turn your attention to the easiest anastomosis, which is the duodenojejunostomy. That's your third and last anastomosis. You pass in a feeding tube through it so that you can continue feeding this patient within a couple of days. Most laparoscopic Whipples, if they do well, kind of go home within the 4th or 5th day. They hardly need any kind of rehabilitation in the ICU. This is a bit of flow seal just to control the bleeding. Then you leave a drain, and that's the entire specimen that comes out. Now, sometimes it is difficult to identify the gastroduodenal vessel, and that's the most crucial part in a Whipple surgery, because you have to identify the hepatic artery and the gastroduodenal, and that's how we mobilize. So when we do a CT angio prior to the procedure, it becomes very easy to then know the entire anatomy, because then all this nodal clearance can be done. As you see in this case, there are many nodes, and for us it is very important. Sometimes the people who are against laparoscopic or robotic surgery would say that I can't do the entire clearance. As you can see in this case, that almost the entire vessel, you can almost make it skin bare and remove the entire nodal structures piecemeal of the vessel, so that the entire hepatic artery, the CBD, portal vein are all clearly identified and dissected free. That's the identification of the artery. As you can see, it is bare. We are removing all the nodal structures around it so that you can see the hepatic artery, the common hepatic artery. You can easily hold it that way. And then dissect it and close it from there. And finally, I will just like to show you a video of a subtotal pancreectomy. This was a tumor which was present in the neck and body. Again, the same dissection. You kind of dissect and raise the stomach up, mobilize it completely off the pancreatic surface. That's the splenic vein. So you have to be careful that the splenic vein is not very densely stuck there. That's the superior mesenteric vein and the splenic vein. You dissect all these adhesions, and that's the pancreatic surface with the tumor. Now, here it was difficult. because the tumor was not large enough and I could not really feel the tumor. And that is where my laparoscopic ultrasound really came in to help me, because the tumor was where the splenic vein was bifurcating. That's the adhesions to the splenic vein. So I can preserve the splenic vein and still dissect this entire thing. So you lift the pancreas off the renal vein and the splenic vein. As you'll see, now that will come into view, you can see the renal vein and the splenic vein forming the confluence to form the portal vein. So with laparoscopy, the advantage is that all these vessels are into view. Your assistant is not struggling to show you that exact view, as would probably happen with open surgery. You can take your notes, that's where you can see clearly the veins, and so easily you can separate all these veins. That's the splenic vein. Now you lifted the entire pancreas and its body and tumor off the vessels. Now the time to where do we transect, because transection was very, very important as to for us to transect it. That's, I have to divide it there because it's going into the tumor. So just isolate the vessel and then divide it wherever it is going into the tumor. And that's the ultrasound coming in for helping me to identify the exact location of the tumor. Once I've identified the location of the tumor and confirmed it, then I divide it with the help of my stapler. And after I've divided it with the help of my stapler, I'll again reconfirm the insulinoma in this case and where it was located so that I can remove that. So I think this is what I wanted to kind of cover, whatever there was in terms of the pancreatic space, just to make you aware as to what all we can do, what all we can't do in terms of the pancreatic space. I don't know if there are any questions that I need to answer. Well, thank you very much. I'm just seeing some of the comments. So thank you, Prashant, for your kind words.
Thank you, sir. Thank you for your nice talk. For 5 minutes, we'll go for official inauguration of Rhythm, Refreshercon 2021. We have a guest with us, Dr. Ramkrishna Londe, sir, Dr. Shivaji Kakade, sir, Dr. Samir Chandratre, sir, Dr. Rajendra Kulkarni, sir, Dr. Prajakta Lele, madam, Dr. Sudarshana Ahire, Dr. Prashant Sorone, sir, Dr. Ramkrishna Londe, sir, is the State IMA President, and Dr. Kakade, sir, is Joint Secretary, Maharashtra State IMA. Dr. Samir Chandratre, sir, is the IMA President, Nashik. So we are going for official inauguration of the 2021. I request Dr. Londe, sir, to go for right. Dr. Ramkrishna Londe, sir, is a state IMA president. I request Dr. Kakde, sir, also. Dr. Sir is a joint secretary, Maharashtra State IMA. Dr. Samir Chandrakar, sir, IMA president, Nashik. CWC member, Dr. Prajakta Dere Madam, Vice President, Nashik IIM, Sudarshan Agre, Prashant Sohawe sir, President, Nashik IIM.
मास्क काढून मास्क काढून मी तुम्हाला सांगितलं ते सर लोन त्यांच्याकडे सांगतो आम्हाला
Thank you, sir. Now we will move forward with the next lecture. I will request Dr. Lodi sir to have a few words to guide us. Dr. Lodi sir.
Hello. मी डॉक्टर रामकृष्ण नांदे, स्टेट प्रेसिडेंट IIM महाराष्ट्र. देशभर उद्घाटन झालं असं मी जाहीर करतो आणि कार्यक्रमाला स्टेट IIM कडनं शुभेच्छा देतो. कार्यक्रमासाठी बेस्ट ऑफ विशेष फ्रॉम ऑल मेंबर्स ऑफ IIM महाराष्ट्र. ओके.
Thank you, Londe sir. We will move forward with the lecture by Dr. Samir Chandrate sir. Dr. Samir Chandrate sir is a dynamic personality from Nasik. Sir has completed his tenure for presidency of Nashik IIM in the difficult era of COVID. Sir is also Joint Secretary, Maharashtra IMA Board. Sir is also active member of Nashik Association of Physicians. Sir is a consultant case physician and attached in most of the corporate hospitals. Sir is going to guide us on his philosophical view on COVID. Over to you, sir.
Thank you so much, Ritam. I thank my state IMA president, Dr. Ramkrishna Londe sir, and our joint secretary, Dr. Shivaji Kapde sir, to come here to Nashik to inaugurate our annual Refreshercon, which is not limited to Nashik sir, under the able guidance and support of Dr. Rajendra Kulkarni and Dr. Prajakta Dere, Dr. Sudarshan Agre, Dr. Prashant Sohawe, and entire my team. Our annual Refreshercon sir is now almost a state event. I thank to my digital platform Digital, who has really given a lot of support to organize this. Actually, I was given a talk to talk about COVID and the curtain falls, because it was almost 15 days back that the topic was selected. And I wanted to present that how Indian Medical Association has worked in COVID pandemic and how the curtain is falling and what are the after effects. But see how it turns out. In the last 7 days, COVID is back in action and rising all across Maharashtra and all across the nation. COVID is changing colors probably. These colors have been changing at the national and international arena, the way the society and the government looks at doctors, thinks about doctors. If you remember, way back almost a year ago, Honorable Prime Minister had applauded the healthcare workers for the first time in the country. The society realized how importance should be given and how they should respect the healthcare workers. And we appreciate that move. But it was just going to boost the army to fight against an enemy. Enemy is your COVID, and army is healthcare professionals led by Indian Medical Association. There are a lot of challenges which the organization faces. Challenges are faced by individuals, families, challenges are faced by parents, children in the COVID era, hospital staff, healthcare workers. It may be government or private institution, but challenges are everywhere when we're going to manage COVID. There is a rapid rise of COVID, followed by a fall, and no one realized that round the corner there will be rise again. Pandemics will come and go, surprises will come and go, challenges will remain in front of the organization. I wanted to actually tell a few words about how every local branch, every state branch, and every national such kind of branch has faced the challenge all across the world. As you know, Indian Medical Association is the largest NGO of doctors in the world. Right from the government and power corridors at the national level, state level, to the local panchayat levels. Wherever the letter goes, it says Indian Medical Association. It never says, even though code is stated by mostly physicians, it never says Association of Physicians of India. Gynecologists have carried out their duties by performing deliveries, and surgeons have done surgeries. All branches are working right from the beginning. But when it comes to an official letter from the government, it's always termed as Indian Medical Association, because it's an association which represents all kind of sub-association or faculty or subspecialty associations. I hereby request that every doctor of modern medicine should be official and a proud member of Indian Medical Association. Few challenges which early in the pandemic we faced were like just simply as simple as creating awareness about COVID. So IMA, with the distinctive leaders, local branch activities, we approached the press, the social media, the radio channels, the television interviews were given, pamphlets were distributed, posters were used, just to make people aware about what COVID is and how to protect themselves. The second most important challenge was actually how to create the infrastructure, how to treat the patient at OPD basis, at indoor basis. Again, Indian Medical Association was at the forefront at every nook and corner of the city. With the respiratory community clinics, with individual OPD functioning, with lot of barriers and protective gears, our doctors were round the clock serving the nation. Infrastructure of the government was improved because of that particular period of lockdown, which Indian Medical Association supported right in the beginning, because we bought time, and that time factor increased the possibility of improving our healthcare infrastructure all over the nation. Indian Medical Association supported that time for the lockdown. Indian Medical Association has given a lot of guidelines and support during those crucial days when the entire country was shut down, locked in its house. Doctors, policemen, and other government officials were working day and night to see to it that COVID does not cause that much of damage as it has caused in the European countries or America. The fact is, when the challenge is put to you, your brain analyzes in its mind what is the possibility of the threat, what are the possibility of the intensity of the damage.
So the potential damage and the threat perception goes through a process. The threat is analyzed and the solutions are sought. That exactly goes on behind the doors of Indian Medical Association. IMA has got a federal structure from nation to state to local branch. Every challenge faced by a doctor is reported, analyzed by IMA's think tank and official office bearers. Decisions are taken. It was tough time for us also, but our organization stood firm and actually pulled up their stocks and got ready to fight this COVID. Another most important thing which we faced right in the beginning was personal protective equipment shortages. PPEs were short, they were in black market, they were tremendously high, and IMA put their foot down to reduce the prices. Though we were very late, sir, that the government agreed to our request. But still, I think now the N95s are at the rock bottom price. But those were the tough times when the doctors had to pay from their own pockets. And mind you, the gowns and the face shields and all kinds of PPEs, IMA has been at forefront. In fact, to say, for the face shield campaign, Nashik played an important role by involving the Rashtravari Medical Welfare Trust to distribute face shields all across Maharashtra, including the Maharashtra Association of Resident Doctors. IMA has always been at forefront to see to it that the cost price of these things go down. In fact, many branches like Thane, Beed, Jalgaon, Nashik, and many more branches bought these things at bulk and distributed to their members. I think that's a very credible thing because doctors are not known to do such things. But the time asked it, the challenges were thrown and the challenges were accepted and we seek some solutions. Similar problem came with the treatment protocol. There were self-proclaimed treatment guidelines issued, but with the implementation of task force at the national and the state level, our specialists could actually improvise, analyze, and put down proper guidelines for the Indian scenario, right from the grading of the COVID disease, like mild, moderate, to severe, who all will require oxygen, who will require ventilators, who will require what injectable drugs. So the protocols were laid down by the task force at every stage. After analyzing and actually going through the scientific data, this again involves a teamwork, this involves some processes, analysis to seek the solution. It has to be an amicable solution. One more thing which we faced in those times were the shortages of remdesivir and tocilizumab. I remember that many doctors, when they were first attacked by COVID, we had to try and bring remdesivir across the border. Things changed. We had to hasten a lot of things with DCGI also. IMA plays a lot of roles behind the curtain, and that only an Indian Medical Association member realizes. There were shortages, there were black marketing, and every illegal stocking, everything. IMA opposes everything which is illegal. Sooner or later, whenever it happens, the prices of remdesivir decrease. They might decrease much more again. Tocilizumab prices also decreased. Another problem came to us while fighting COVID, that was oxygen supply. Oxygen was shortage. The storage facilities were poor. Infrastructure of manufacturing oxygen was very poor. Industrial oxygen was moved to domestic and requirement of the hospital was fulfilled. Again, IMA played a major role to notify the government at all levels that the industrial supply has to be cut down and we should save lives. IMA members work to save the life of our countrymen. IMA has always stood beside the country, for the countrymen, whenever a problem arises, whether it's pandemic, whether it is flood, whether it is drought, any kind of thing. IMA is always there to help the government. One more thing, which I think I have to mention, is that the analysis of the new strain, I mean, the data which is to be given to the government and the think tank, because now we see since last 7 days, there are a lot of cases cropping up all over. It can be the second wave, it can be a UK strain. We don't know exactly as of now, but it can be because we are little caught off guard with the festivals of Ganpati, Diwali, the festival of New Year, and the recent festival of Valentine's. We see that the guards are gone, the masks are off. So IMA always says that the mask should be on, your guard should be absolutely on, so that we don't get infected again. IMA has also supported the vaccination drive all across the nation. Even though the healthcare professionals or the frontline workers, which includes the policemen, are receiving the vaccines, but these vaccines are rolled out. The fastest rollout of the vaccine in the world is India. And I'm proud that just last day we had the Serum Institute's executive director to talk about our Vasantrao Gupte oration, a splendid talk about vaccination. IMA has promoted this drive right from the nation's political power, and we have gone across the way to help out to create more and more facilities. In fact, Nashik itself, Savita Desai Rugnalaya is now a facility for vaccination, and this is offering all over the branches. But remember, we have done everything for the country. We represent a noble profession. My initial talk was COVID and the curtain falls. Someday COVID will go, and it might be a bitter truth. But there is a saying in Marathi, Garad Saro, Vaidya Mano. It could have been Garad Saro, Engineer Mano. It could have been Garad Saro, Contractor Mano. It could have been Garad Saro, Swayambaki Mano. It could be Garad Saro, Ekada Mota Neta Mano. It never happened that way. Because it's a human tendency to forget. It's not a human tendency to forgive. Members, Garad Saro Vaidya Mano, he's Goshta Puri Gandhar. People are going to forget what doctors have done. People are going to forget what the relatives of doctors have done. A doctor has not visited his parents. A doctor has not stayed with his family. A doctor has not stayed with his children to protect them. This is a fight which is absolutely different from the fight which goes at the borders. A soldier gets a bullet and he dies over there. But a doctor gets infected, brings the infection home, and maybe his family member dies. And that's what has happened all across the nation, all across the world. Remember, a human tendency is to survive the threat. And today, the society is going to survive the threat and come out of it. Vaccination is the first step. I request everyone to become the member of Indian Medical Association and do not expect anything from the society. Keep on doing good work, and the good men will follow us, will respect us. And someday they'll realize what doctors and healthcare professionals have done in this pandemic. Do not expect anything from the society. Keep your guards on. Indian Medical Association will always see to it that its members, all the doctors, irrespective of the parties, irrespective of what kind of doctor or what kind of party you are, whether you are a staff, whether you are an ambulance driver, the guidelines are clear cut from Indian Medical Association. Use appropriate PPEs and appropriate things. Be safe, treat patients, serve our nation, serve the countrymen without expecting anything, whatever it can be. It could be capping of charges, it could be a lot of regulations, it could be like when the COVID gets over, all the government will come and bang on the regulations on your head. Everything can happen. Be ready for it. We have to fight it with good valor and vigor. Yesterday, Lunde sir said, our president sir said, because the fight, the future fights would most be legal. There will be a government coming out with a regulation and IMA would be going to the courts against it. The fight will no more be on the street now. We might have to go for everything legal. And we have to be a bit diplomatic. We have to be having a lot of foresight for all the problems which are coming our way. COVID was a challenge, global challenge. We are coming out of it slowly with stricter protocols, with vaccines and better infrastructure. But remember, this is just a pandemic which will come and go. It may rise, it may fall, it may rise again. That's what is happening. But the government and the regulations will keep on coming. Maybe a Clinical Establishment Act is coming our way. So the problems are around the corner. What's important is the attitude with which we have to face them. Be a member of Indian Medical Association. Our leaders are ready to fight everything which is thrown at us. All challenges will be processed by our think tank and we'll go for a solution. Whether it's legal, whether it's amicable, whether it's across the table, we'll do everything which is possible to see to it that our members are benefited. I can request all the association members or anybody who is a modern medicine graduate, see to it which is an association which features in the Prime Minister or President's rule or letter. It's Indian Medical Association. We should work for the association together. We should fight the disease together without expecting anything for the society, but always keeping with good intention and working for the society. My talk, COVID and the curtain falls. Actually, it's a curtain raiser. And I think it's a curtain raiser for everyone. 15 days back, everyone was jumping to take the credit that we have controlled the COVID. And what happens within a week? Within a week, the table turn around. We have to be ready for the second wave or the strain. This COVID can go for 3 years, 4 years, we don't know. Important message is, let's be united. Let's fight it together. And let's make our country safe, healthy, and happy. Thank you so much. It's Nashik. I am a President, Dr. Sameshwar Ratne. Now, handing over to my MOC. Thank you so much.
Thank you, sir. Nashik IIM is really fortunate to have a president like Dr. Samir sir in the difficult COVID era. And sir has done incredible job to fight for doctors while bureaucrats and government try to exploit doctors. But at the same time, sir has balanced social responsibility as well. Hats off to you, sir. Going forward with some non-medical topic and non-COVID topic, that is financial literacy. Dr. Mahindra Dhongde Patil is going to guide us on why doctors fall under GST. Dr. Dhongde Patil sir is a MCom, done his PhD. Sir is a teacher and associate professor, HOD, Department of Accountancy in MSRK AKBK Mahila Mahavidyalaya Nashik. Sir is also a life member of Indian Accounting Association. Sir has its own firm practicing as Dhongde Patil Cooperative Charter Accountant, Nashik. Sir has attended many national and international conferences. Over to you, sir. Dr. Dhongde Patil, sir.
Good morning, one and all. Am I audible?
Yes, sir.
Good morning to everyone. First of all, I take this opportunity to congratulate and thank all the medical fraternity for the hard work, for the hard efforts you have rendered during the pandemic COVID-19. So really, doctors have survived many lives, and I have seen it from very near. Many of my relatives have been saved by the doctors. So congratulations and thank you to all the medical fraternity. I also take this opportunity to thank all the members of IMA who have invited me to talk on the topic why doctors fall under service tax. Actually, for us, being practicing chartered accountant, now service tax has been abolished. Service tax is no more, and it has been subsumed in the GST from 1st of July 2017. Many taxes are taken together in GST, and service tax is also one of them. So now, practically speaking, service tax is no there to be levied or to be collected. But as you are aware, it has been a hot topic for all the doctors because many of them have received notices from service tax department to pay taxes. Show cause notices have been issued to pay tax for the year 14-15. So almost after 5 years, we have received those notices. And as we all are aware, doctors were outside the purview of service tax. Services of medical professionals were not taxable at all during the service tax era. But now, as we have received the notices, we will have to see what service tax is and how it is levied on doctors. So we will just see how it started and how it is, if it is at all applicable to all the doctors, how it is applicable. So my presentation will go in this manner. We will see introduction of service tax, what is negative list, what is threshold exemption under Service Tax Act, what are healthcare services, what are taxable services, what the recent hot topic show cause notices we have received, and what is the course of action to comply with the notices. So service tax was introduced for the first time in the year 1994 through Chapter 5 of Finance Act 1994. So it was the first time when service tax was introduced. To start with, there were only 3 services which were notified, but number got increased to 117 by the end of financial year 11-12. So जो सर्विसेज शुरू में 3 थी, बाद में वो 117 तक चली गई थी, लेकिन फाइनेंस एक्ट 2012 had radical changes which were made in the Finance Act 1994 by providing that service tax is payable on all services rendered in taxable territory except for a negative list of services specified in section 66D. What had happened earlier, government was, or service tax department had notified the services. It started with 3, बाद में वो ऐड करते गए और 117 तक वो फिगर चली गई थी. बाद में लेकिन 2012 का जो फाइनेंस एक्ट आया उसमें उन्होंने निगेटिव लिस्ट दे दी कि और एवरीथिंग विल बी टैक्सेबल एक्सेप्ट व्हाट एवर इज इंक्लूडेड इन निगेटिव लिस्ट. जो निगेटिव लिस्ट में है उस पे टैक्स नहीं लगेगा, उसके सिवा जो भी रहेगा वो हर चीज पे, हर सर्विस पे टैक्स लगने वाला है. तो ऐसा एक निगेटिव लिस्ट का कंसेप्ट आया 2012 में. To a lay person, a negative list of services implies 2 things: a list of services which will not be subject to service tax, that is given in that list. Other than the services mentioned in the negative list, all other services will become taxable which fall within the definition of the supply of services. Supply of services में जो भी आएगा, everything will be taxable except what is listed in negative list. From the financial year 8-9, the threshold exemption on the aggregate value of taxable services provided up to a maximum of 10 lakhs. So whenever taxable service exceeds 10 lakhs, that particular person had to take registration from the service tax department and had to pay service tax on the service rendered or service provided. So small service providers having receipts or having aggregate value below 10 lakhs were not under the purview of service tax. So what is aggregate value? Aggregate value means the sum total of value of taxable services charged in the first consecutive invoices issued during a financial year, but does not include value charged in invoices issued towards such services which are exempt from the service tax leviable thereon under section 66B of the Finance Act under any other notification. तो जो टैक्सेबल सर्विसेज है, जो इनवॉइसिंग आप करोगे तो साल के शुरू से, दैट मीन्स ऑन 1 अप्रैल एवरी ईयर विल स्टार्ट काउंटिंग. जब आपका 10 लाख क्रॉस होगा तब आपको सर्विस टैक्स पे करना है, 10 लाख ऑफ टैक्सेबल सर्विसेज. सो वॉट एवर इज नॉट टैक्स लेविएबल, जो नहीं है, जो एग्जाम सर्विसेज नहीं है, उनका इनवॉइसिंग कंसिडर करने की जरूरत नहीं है. तो वो क्या है वो भी हम लोग आगे देखेंगे. आफ्टर इंट्रोडक्शन ऑफ नेगेटिव लिस्ट, notification number 25 of 2012 that exempted levy of service tax on healthcare services as rendered by clinical establishment. So what is clinical establishment? What is clinical establishment? Clinical establishment establishment means hospital, nursing home, clinic, sanatorium, or any other institution by whatever name called that offers services or facilitates requiring diagnosis or treatment of care of illness, injury, deformity, abnormality, or pregnancy in any recognized system of medicines in India, or a place established as an independent entity or a part of an establishment to carry out diagnostic or investigative services of diseases. So that is called as clinical establishment. It has been defined in the Service Tax Act. According to that, this is the definition of clinical establishment. अगर इसमें किसी की treatment हो रही है for the diseases or for the abnormality, deformity, then that will be treated as healthcare service rendered by clinical establishment, and it is exempted service. So whether all healthcare services are exempt? The answer is no. Only services in recognized systems of medicines in India are exempt. So what is recognized systems of medicine? That has been defined in clause H of section 2 of the Clinical Establishment Act 2010. The following systems of medicines are recognized systems of medicines. क्या क्या था उसमें? एलोपैथी, योगा, नेचुरोपैथी, आयुर्वेदा, होम्योपैथी, सिद्धा, यूनानी, and any other system of medicine that may be recognized by central government. अगर इनके तहत कोई मेडिकल ट्रीटमेंट हुई है तो that will be exempt. So what is not included? Cosmetic or plastic surgery service. Notification 25/2012, which I had mentioned earlier, it is dated 20 June 2012, excludes service of hair transplant, cosmetic or plastic surgery from exemption. But any reconstructive service, surgery performed as part of treatment of a disease, it is not leviable for service tax. So जैसे आपको पता है कि कभी एक्सीडेंट होता है या फिर कोई डिसीज की रिक्वायरमेंट है, एंड फॉर दैट रिकंस्ट्रक्टिव सर्जरी और कॉस्मेटिक और प्लास्टिक सर्जरी इज परफॉर्म, दैट इज नॉट लेविएबल फॉर सर्विस टैक्स. सो व्हाट इज लेविएबल? द बेस्ट एग्जांपल इज ऑल actors, our cinema actors and actresses. They are performing various plastic or cosmetic surgeries, hair transplant, or many changes done on their faces. So everything to look better, whatever they are making expenditure on that and making any payment to the doctor, that plastic surgery charges, cosmetic surgery charges is taxable service. So that is to be kept in mind. So what are related taxable services? From any doctor viewpoint of doctor or hospital, if receipt from following mentioned services is exceeding rupees 10 lakhs, that is naturally during a particular year, then service tax is leviable. For example, rent received from commercial premises. अगर किसी डॉक्टर का कमर्शियल प्रीमाइसेस है, बैंक को अपने रेंट से दिया हुआ है, किसी और commercial establishment को अपने रेंट से दिया है, and we are receiving rent on commercial premises, that is leviable for service tax. Then medical shop, normally it happens, even if it is a proprietorship, if it is a hospital, we get rent from the medical shopkeeper or that pharmacist, and that medical rent received is also taxable service. Excluding rent from residential property. किसी डॉक्टर के मेडिकल प्रोफेशनल के 2-3 फ्लैट से 2 फ्लैट या 1 फ्लैट उन्होंने रेंट से दिया हुआ है फॉर अ रेसिडेंशियल पर्पज, देन इट इज नॉट टैक्सेबल. So please keep in mind, commercial premises rent is taxable, medical shop rent is taxable, but if it is from a flat or bungalow, it is rented out and we are getting rent from that, it is not a taxable service. Even if in new GST era, it is not taxable under GST. Insurance commission received is also taxable. Cosmetic and plastic surgery we have seen. Similarly, rent from mobile tower. I have got a hospital के ऊपर मोबाइल कंपनी को हमने रेंट से दिया हुआ है, so that rent received will be taxable under service tax. So now the main part of our presentation, show cause notices received from service tax departments and its validity, whether they are valid. So on the basis of information received from income tax department, service tax department has issued show cause notices to medical practitioners. As we are aware, both the departments, income tax department, service tax department, or GST, they are central government departments. So data can be shared easily by one department to the other, or even we can say they have got direct access to the service, access to the server of the other department. So वो एक्सेस उनको है, तो इसलिए आराम से ये पैन नंबर आप डालो तो उसके कितना सर्विस टैक्स भरा है, कितना इनकम टैक्स भरा है, कितनी रिसीट्स बताइए, एवरीथिंग कैन बी नोन टू द अदर डिपार्टमेंट एम्प्लॉयज और पर्सनल. So easily they have received information from the income tax department, and from that they have issued notices to the medical professionals. Not only medical professionals, similar notices are also received by advocates. We are knowing the fact that advocates, they are also exempt from service tax, but they have also got similar notices. जस्ट उन्होंने इनकम टैक्स डिपार्टमेंट से इंफॉर्मेशन, उनको पता चला कि इनकी रिसीट्स पर्टिकुलर साल में 12 lakhs थी, 13 lakhs थी, 28 lakhs थी, 38 lakhs थी, and accordingly they have issued notices. So if they are valid, such notices are valid if show cause notice is issued under any section or subsection other than 73(1), then it is invalid. But only 73(1) under current extended time period can be invoked and notices have been issued. जो भी notices अपने को मिले, they are under the section 73(1) only. तो उसके तहत हमें notices दी गई है, तो they are valid notices and we will have to comply with such notices. So what is the course of action available? So first of all, we will have to give reply in writing to the show cause notices either in person, आपने खुद भी तैयार किया तो भी चलेगा, or through your authorized representative, that is CA or tax practitioner. So first of all, give written submission, take acknowledgement of the submission you have done with the service tax department. उसका एक कॉपी, उस पे उनका स्टैम्प और सिग्नेचर लेके अपने पास रखना है as a proof that we have made first submission. So they may ask, or along with first submission, we can provide details of receipts during the year. अभी जो notices मिले हैं, they are for the financial year 14-15. तो उस साल के receipts के अगर details है, तो we can provide with the details. 26 AS, काफी हॉस्पिटल्स हमारा TDS काट लेते हैं, और 26 AS में हमें पता चलता है कि कौन से हॉस्पिटल ने कितने पैसे हमें दिए हैं और कितना TDS काटा है. So that establishes the fact that it is an allopathy hospital. Some services or some diagnosis, some operations have been performed in that hospital and professional fees have been received from that hospital. So 26 AS is also important because it is to be downloaded from the income tax website. Financial statements, that means profit and loss account and balance sheet. ITR, that is income tax return, etc. as proof of medical receipts. हमें मेडिकल रिसीट्स मिली है, प्रोफेशनल रिसीट्स है. मेडिकल जो भी डायग्नोसिस और ऑपरेशन हमने किए, दैट इज फॉर द प्रोफेशनल फीस वी हैव चार्ज टू आवर पेशेंट्स एंड हॉस्पिटल्स. सो दैट इज अ प्रूफ दैट दे आर ऑल exempted services and we are not liable for service tax. For that, all these documents are the documentary proof which we can submit along with our submission. If needed, service tax officials may call the doctor or his authorized representative for personal hearing for the closer proceedings. अगर कुछ केसेस में उनको लगता है कि कुछ एडिशनल इंफॉर्मेशन चाहिए या पर्सनल हियरिंग भी लेना है, तो दे मे कॉल इन फ्यूचर बिफोर क्लोजिंग द SCN issued. शो कॉज नोटिस जो इश्यू किए उसको क्लोज करने के पहले में भी पर्सनल हियरिंग भी हो सकता है. तो ये तो हो गया, जो एक्ट अभी है ही नहीं उसकी नोटिसेस मिले और उसका कंप्लायंस हमें करना है. लेकिन अभी मैंने जैसे बताया कि GST तो एप्लीकेबल है, तो उसके लिए क्या करना है? चेक यूर स्टेटस. बेसिक डिफरेंस क्या है? इन केस ऑफ सर्विस टैक्स, ओनली टैक्सेबल सर्विसेज वेर कंसिडर्ड. मेडिकल रिसीट्स आपकी 50 लाख है और रेंट रिसीव्ड कमर्शियल प्रीमाइसेस या मेडिकल शॉप का रेंट रिसीव्ड अगर 5 लाख है, सो दैट सर्विस टैक्स was not to be required to be paid on the 5 lakhs of rent received, even if total of your income during the financial year was 55 lakhs. 50 लाख का मेरा मेडिकल प्रोफेशनल की रिसीट्स हो गई और 5 लाख रुपए मुझे रेंट मिला मेडिकल शॉपकीपर से, तो my total was 55 lakhs and I was not liable for service tax because taxable service amount did not exceed 10 lakhs of rupees. But this is not the case in GST. GST में taxable limit या basic threshold exemption जैसे मैंने बोला, तो threshold exemption has been increased to 20 lakhs. Professionals के लिए that exemption of 10 lakhs has been increased to 20 lakhs. But now all such non-taxable services are to be considered as your turnover. So same case, same doctor है, 50 plus 5 is his income. 50 lakhs professional income, 5 lakhs shop rent, medical shop rent income. So in GST era, as total 55 lakhs is exceeding 20 lakhs, such medical professional will have to take GST registration, will have to pay GST on rupees 5 lakhs, that is rent received from medical shopkeeper. So that is the difference in your GST era. So first of all, consult your CA or practitioner, and if you are covered under GST, then you will have to take registration of GST and pay taxes accordingly. अगर लिया नहीं है तो अभी भी टाइम गया नहीं है. There may be some interest and some penalties levied, but अर्ली स्टेज पे किया, बाद में अगर जैसे आपने देखा है 5 साल बाद नोटिस आती है तो तब कंप्लाई करेंगे तो तब इंटरेस्ट काफी बढ़ जाएगा. सो जस्ट चेक योर स्टेटस with respect to GST registration, etc. So I again thank you all the members present, all the medical professionals present for this webinar. So thank you once again. My contact details are also shared. In case of any queries, you can contact me either on telephone, mobile, or even right now you can ask your queries.
Thank you, sir. Thank you for your lucid presentation. We'll continue with improving our financial intelligence. Next topic will be investments after COVID. Dr. Ajay Shukla is going to guide us. Dr. Ajay Shukla, sir, is a PhD in stock market analysis, MBA in finance from Pune University. Sir is a financial education resources person for SEBI and NSE. Sir has a 10 years of industry teaching and training experience in financial sector. Over to you, Shukla, sir.
Fine. Thank you very much, Dr. Preetham, for such a nice introduction. Very good morning to the August gathering, panelists, participants all across the Maharashtra who have spared their valuable time and been actively participating in this refresher program organized by IMA Nasik branch. And I also extend my heartfelt thanks for IMA Nasik branch for inviting me to share a few words of wisdom about finance that we know and we have been working across. I hope I am audible to everyone. Can I just get a confirmation about it? I hope I'm audible.
Yes, sir, we can hear you. Please carry on.
Surely. So basically, I'm today speaking here on behalf of National Stock Exchange, wherein we are trying to conduct investor awareness and financial literacy program for investors from various background. As Sir just introduced in the basic, that I am a speaker for National Stock Exchange. Moving ahead, just a This all has been done under the guidance and instruction of Security Exchange Board of India, which is the apex regulator of financial market in our country. So towards the end of this session, I'll also talk about investor grievance handling, and there are been cases where people are being duped or cheated, or there are systematic fraud which are being conducted, and we generally have one option to go to police. But in majority of the cases, the police are equally financial literate as we are. In that case, we have an option that we can go to the Security Exchange Board of India as an individual investor to file our investor grievance, and how to do it, what are the steps, and where we have to do it will explain towards the later part of this session. So Security Exchange Board of India was formed in 1992, which was basically due to various scams which we have already heard about took place in the market since 1975 to 1990. So this was a period where this stock market was booming, but there were also many scamsters and people who had financial irregularity coming up. Hello.
Yes, sir.
Hello. Am I audible?
Yes, sir. Yes, sir.
Okay. So with that objective, the government had set up this specific organization wherein people will have an option to reach back, and wherein the irregularities in the market where people are trying to take undue advantage of those can be covered up. And for that, they have also instructed stock exchanges which are there to set up investor protection fund, wherein individual account holders have a limit up to 15 lakh rupees, as well as they have also instructed you have to educate people. So as we just spoke about that, we are doing it under the investor awareness program. So why investor awareness program or this series have been done? As I said, ki Security Exchange Board of India is taking care of complaints. Similarly, there are also such point where individuals can file their complaint with the stock exchange. So whether it is National Stock Exchange or Bombay Stock Exchange, or previously there were regional stock exchanges also, like Bombay Stock Exchange, under we had Pune Stock Exchange, or in Ahmedabad there was a stock exchange. There was 18 more regional stock exchanges, but now we are confined to two national level stock exchanges. Going ahead with brief, as Pritam sir already introduced, I've done my PhD in fundamental analysis of stock market. I've done my MBA both from Pune University. I'm resource person for NSE, for Security Exchange Board of India. Formally, I was just listening to a session about service tax and GST. So I'm also resource person for National Academy of Custom Excise and Central Tax, which is under Ministry of Finance, wherein we speak on GST and also consult on cases related to GST wherever help is required, and that we are doing even before GST was approved as an act, so that we can spread awareness about how GST is easier than the previous law. I'm also instructed at Udemy, which is an international training platform. So anyone who wants to learn more about that can go to Udemy. There are 3 courses available in English and Hindi to learn about stock market investment. I've taken more than 75 workshops, training more than 5,000 participants, 30 plus research paper in international national journal, 1 book, and I'm glad to say that I am amongst top 5% researchers at SSR in Germany and ResearchGate US. There are many things to say, but I guess that's not a forum today and the time is limited. So let's start it on. Today's session is being organized and conducted by BAIP, that is Board of Industry Academia Partnership, which is the implementing agency for National Stock Exchange for Maharashtra and Goa, and under which we are conducting this event today. Going ahead, here we start on with the core part of our session, the securities market. So in general, all the medical practitioners, once their practices settle, they have a fair enough source of income, but their background had a very limited to do with, right from whether your junior college or your complete education. It has nothing to very little to do with the commercial education and financial education in specific. Of course, you can upgrade from the news channel, financial news channels, from books, from YouTube channels, or you can do courses which are available online as well as offline. So based on that, the securities market is divided into 3 verticals, and there's a derived vertical. Which are those vertical? So first there's the equity market, which is typically known as share market or cash market, where people invest and buy shares and get delivery of those shares. Over the period of time, equity investment has become very popular among people because of the good return which people get out of it. Means the expectation of good returns. Second market, that is derivative market, which is often known as FNO or futures and options market. So we'll talk about this also. What is a futures and options market and why it is called as derivatives? So futures and option market is a market where there are securities traded, but there's a contract. So in equity market, let's say, for example, I buy shares of ITC Limited at X price. So what I have done, I have directly purchased shares. Now there would be a future of ITC, there would be option in ITC. So if I decide to buy a future, I am not buying ITC shares, but I am buying a contract to buy or a contract to sell those ITC shares based on a particular lot size, which is being specified on time to time basis by the stock exchange. Now, the returns from derivatives are far more higher than equity market, because in derivatives market we have something that is called as leveraging or margin. So I can do a contract to buy something worth rupees 100 just by paying rupees 5. So I just pay rupees 5 and do a contract to buy rupees something which is valued at rupees 100. So simple, मैंने 5 रुपए देके 100 रुपए की चीज खरीदने का कॉन्ट्रैक्ट किया है, मैंने चीज खरीदी नहीं। ये एक कंफ्यूजन होता है लोगों को, इसलिए मैं उस पर स्ट्रेस कर रहा हूँ कि मैं चीज नहीं खरीद रहा हूँ, मैं वो चीज को खरीदने का कॉन्ट्रैक्ट खरीद रहा हूँ। दैट्स व्हाई व्हाट यू गेट इज द लॉट, दैट्स अ कॉन्ट्रैक्ट on a contract note. So I do a contract by paying 5 rupees. Now, why the returns are high? If that 100 rupee, asset becomes 101 rupee and I close it off, I get 6 rupees rather than 5 rupees. Uh, everyone is getting this? सिंपल, आपने 100 रुपए की चीज खरीदी, उसके लिए 5 रुपए एडवांस दिया, वो 100 रुपए की चीज हो गई 101 रुपए की। अब मैंने 100 रुपए में से 5 रुपए दे दिया था, 95 रुपीज देना बाकी था। जब मैं 101 रुपए को बेचता हूँ तो उसमें से 95 कट होके मुझे 6 रुपए वापस आता है। सो in a layman's language, I had put in 5 rupees and I got 6 rupees for that, maybe within one day, which is 20% return, which is a mammoth amount of return which I can get 20% in one day. But it is vice versa. It's a two-edged sword. वो 100 रुपए की चीज अगर 99 रुपीज की हो गई, so I am at 20% loss. And this is really, really risky. For people who cannot monitor it on real-time basis, we suggest please try to stay out of it. For people who have limited access to market and have limited information about financial market and the movement, should try to stay away from derivative market. I remember what Warren Buffett quoted about derivative is that derivatives can be a instrument for mass destruction, because it can create wealth and it can erode wealth with a greater pace. So it is only for those people who have a very high risk appetite and where they have the ability to digest big losses and are ready to take risk to get big gains. So it's a very high risk and very high reward kind of market. Of course, by default equity market is risky, and this is even more riskier. The next set of instruments are the fixed interest bearing securities, which are bonds, debentures, etc., which is also divided into money market and bond market. So there are short term instruments where you can put in money. Now these are assured return instrument. The returns are low, just like bank FD is one option, postal deposit. What new option can doctors think about is subscribing to NCDs. So NCDs are non-convertible debentures. Now what typically happens is, um people put money to bank and there are lender who borrow money from bank. So I make a FD at 6%, and a company goes to bank and get loan at 8.5% for business if it is secured loan, correct? So the margin is being earned by bank. If the loan is unsecured, it goes up to 11%. So bank is getting money at 6% fixed deposit. If it is a saving account, they are getting like 2.5%. The margin is the money that bank earn, right? Now, what big corporates decided, from where bank gets money is public. So why to take it from bank? Go directly to public. And with this thought, instrument which is debentures got popular in the market. So just for example, um, I don't want to make a fixed deposit, but I keep on observing news and market, wherein I see, for example, latest there was a NCD of Shriram Transport Finance few months back. So Shriram Transport Finance NCD I can subscribe, and the rate would be anytime at least 20% higher than the fixed deposit which are being given by any nationalized or private bank. So if let's say currently the FD rate is around 6%, you can easily get an NCD at 7.5% in the market. And there are companies which often come up with NCD are like the NBFCs, because they easily get permission from RBI. Now, why it is more secured? You might be feeling that why I'm saying so much about NCD is because this is an avenue which is very good, and it is still not so popular, but it is very secured because they are being rated by rated agencies, so you can check rating of that. In equity market, in derivative market, I cannot get rating whether it is A plus plus or A plus or B plus or C minus or whatever is the rating. वो रेटिंग हमें दिखाई नहीं देती, वो मेरा पर्सनल एनालिसिस है. बट यही जब आप डेरिवेटिव या बॉन्ड मार्केट में जाओगे तो उन्हें कंपलसरी है कि अगर आपको इशू लाना है तो आपको रेटिंग लेना ही लेना है, एंड ऑल रेटिंग्स आर टू बी डिस्क्लोज्ड. सो अंडर दैट दे विल गिव यू इंफॉर्मेशन. आई कैन चूज highly rated instruments to invest my money. Plus, they are secured against asset. There are secured debentures, so in case even the company goes in liquidation, though asset would be liquidated and you will have a preferential right on getting your money back. So this is the third market of security market which you should take care of. And the fourth market is a hybrid. A mutual fund market is something where they try to pool money from public and put it in the other three markets, wherein they earn money, they deduct their margin of managing and maintaining the funds, and the balance is being transferred to the investors. I hope many of you would be investing. If not, you can think it as a very good instrument as compared to equity directly, because I hope all of you are practicing. You would be occupying, you would be having your own day-to-day schedule, which would be hectic in itself. And in such a case, mutual fund investment becomes a very good option. Why? Because there is an expert who is being appointed to manage your money. What a doctor does when there is a critical case, they will suggest it to a specialist. So if I go to a general physician and there's a particular problem which the person is facing, he'll send it to a MD who specialize in that. Similarly, mutual funds are managed by experts. So rather than doing it locally, there are experts who are experienced, who have very good connect with market and proven expertise in managing money, are being made fund managers by these AMCs. AMCs means the asset management companies who run just like HDFC AMC or SBI Magnum AMC or ICICI Prudential AMCs. All these mutual fund companies who manage money are called as AMCs. So जब AMC जिन फंड मैनेजर्स को अपॉइंट करते हैं, ये बहुत ही कैलिब्रेटेड लोग रहते हैं, जो एक्सपीरियंस रहते हैं, नॉलेजेबल रहते हैं, तभी वो उस पोजीशन पे जॉब कर रहे हैं. एंड वी कैन सेफली पुट आवर मनी टू देम as compared to managing it ourselves, because they are 24/7 365 job is to manage money. So that was the first part. Now, with the COVID and the market condition varying, there are various thoughts which are coming in the mind of people that what should be the most uh, favorable destination to put money. Where should I park my surplus fund? So people think of gold, stocks, mutual fund, real estate, fixed deposit, and all other options which I said. Uh, Now, what is being suggested as a financial angle is check few things. Whichever option you want to choose, you have to check certain criteria. Don't just check the returns. Don't just look for what has historically happened. But there are a set of systematic things which everyone should check. And the first one is liquidity. Now, why I'm calling liquidity as the most important? Because I need to check, can I liquidate this when I need money? What is the time of liquidation? Just for example, if I invest in stocks, I can get my money in 2 days. If I sell something today, T plus 2, तो 2 दिन बाद मुझे पैसा आ जाएगा. If I put it into fixed deposit, it is within day. If I go and redeem it today, afternoon, maybe by day end I can do it. Just it should be a working day. So liquidity is very high in that case. If I put it into mutual fund, generally it takes 4 days to clear and get your money back. Similarly, if I put into property, now if I put into real estate, which which is also a all-time favorite option to invest, but in that case the liquidation time is very long, so liquidity uski ho jati hai kam. So I cannot park all my money into real estate asset. Going by thumb rule, I cannot put all money. Why? Because जिस दिन मुझे जरूरत पड़ेगी वो quickly liquidate नहीं हो सकता है. Because even if I have a buyer, there's a time that legal process will take and I realize that money. Second thing, if I own a real estate and if I try to sell it in hurry, the other party will try to take advantage and bargain price. Second most important, in case of downtime, if I want to liquidate when I'm in financial trouble, liquidating a real estate property is very difficult because in every time whenever there is a recession or there is a slowdown or there's a market crunch, the real estate market is the first one to be affected. So I'll not get good returns on my investment. So this is how we have to compare. Next is risk return. As I said, every option I should try to compare कि कितना risk का level है और कितना expected returns का level है. And then I have to decide what is my risk appetite. Most important, how much risk I can bear. That is another angle that I have to think. And how much loss bearing capacity, if there is any loss I have. Next is transfer cost. In majority of the instrument, there is some cost which is existing whenever I want to buy or sell any asset. If I buy equity shares, I have to pay brokerage and there is some stamp duty. On mutual fund, if you sell within a time period, there would be a entry or exit load. Now entry load is being cancelled, but still exit load is there, which is there in the market. So वो हमारा एक cost बन जाता है. If it is a real estate property, there is a transfer cost, maybe in the form of registration, stamp duty, legal cost. तो ये जो transfer cost है ये हमें consider करना है. In case of bank and fixed deposit, there is hardly any transfer cost. Just there could be some deduction if I try to close it before the maturity. So ये cost हमें consider करना है कि हम अगर maturity के पहले उसको close करते हैं तो what would be the cost or what would be the loss. Next is lock-in and maturity. Many instruments have a lock-in period. Specifically, the tax saver one. If you're putting into some instruments like tax saver FD or tax saver mutual fund, or you're putting money into insurance, because nowadays insurance has not remain a pure insurance. It is always investment plus insurance. So there is a lock-in. So will my money be locked? So if I need money, what can I do? I have to check that maturity period of that instrument. So I'm getting very good returns, but I have to lock in money for 6 years. Can I do it? Because I cannot get that money in between if I need it. तो ये भी एक एंगल है जो हमने इन्वेस्टमेंट इंस्ट्रूमेंट चूज करने से पहले देखना चाहिए. The sixth angle is future income. I am putting the X amount of money that I have in my hand. But what is the prospect of future income? If the prospect of future income is very bright and there's a continuous source of income that I'm getting from various sources, then I can put my money into maybe an instrument that has a lock-in, an instrument that has a lower liquidity. Why? Because it's okay, in next 6 months, 1 year, 2 year, I'll recover the money. So any contingency that comes, let's say 3 years down the line, I can eventually prepare myself for that contingency. So my expected future income has also to be incorporated while choosing a instrument. And the last one is to hedge. Now, how to hedge? Basically, derivative instruments are being derived as an instrument to hedge against market. So if I have a very good amount of investment in equities market, and I have a fear that the market has ran from Nifty 8,000 to Nifty 15,000, and now I'm worried that it can fall anytime, and my the portfolio, which is today looking very green, might again turn red. In that case, I can hedge my investment by doing something, by just say buy a put option of a lower option. So होगा क्या कि जो मेरा इन्वेस्टमेंट है, अगर इसका वैल्यू कम होता है और वो पुट का वैल्यू बढ़ता है, तो जो पुट से मेरा प्रॉफिट होगा वो मेरे इक्विटी कैश मार्केट के लॉस को कंपेंसेट कर देगा, एंड माय पोजीशन इज हेज्ड. Second option is which commonly everyone suggests is आपके पोर्टफोलियो में कुछ सेक्शन गोल्ड का होना चाहिए. Why? Because whenever there is a bad time and market will go down, people feel gold as a safe option and gold prices will appreciate. And this is historically proven. If you see, before pandemic, the gold was around 37,000. During the peak of pandemic, it has reached around 57, 58,000 rupees in the futures market. Now it has reduced because the market is trying to stabilize. But gold always remains a good option to hedge yourself or to protect yourself against the potential loss. So I hope these 6 points will help you to choose a more prudent investment option and make your own portfolio of investment and assets. Now, in this slide, I have tried to just give a comparison of few popular instruments. You can have a glance of over that, which talks about the return, safety, and liquidity. Because these three are the prime criteria which should consider, wherein you have equity, bond, bank deposit, PPF, life insurance, gold, real estate. So you can just take a screenshot of this and keep it for your record whenever you want to choose what is the position and how it stands. That can be to your reference. You can have a glance and take a snap of it before we move ahead. Now, we have seen the historical movement of market, stock market, gold. So stock market, which had talking about Nifty, which was around 12,000, went down to around 8,000, which was 33% erosion. And from that, it has almost given us a 75-80% return and is above 15,000 now. Gold, as I just told about the journey, from 37,000 to 58,000 and down to 45,000. Now, many people put money into a bank as a fixed deposit. I don't want much headache. So simply I go to a bank and convert it into a fixed deposit. But over the period of time, with declining in the rate of interest and rate cut by RBI to make available finance easier for industry so that the economy picks up, the FD rate has also eroded a lot and it has come down to a 5.5% range. And saving account, it is as good as nil because they're giving mere 2.5 to 3%. And a market where inflation is 6% and I'm getting 2.5%, it is nothing. So putting there and keeping your money idle in your saving account is as good as reducing your money because it will not increase apparently if you talk about time value of money. So don't keep it idle, put it into some good option. Just keeping your contingency cash margin, which should not exceed more than 5% of your total asset portfolio. Now, as it is said, or it is being expected on a personal opinion basis, as things improve and the market sentiment will go up, the bank FD rates will go up. And looking at the union budget, it is expected that government needs to borrow good amount of money from market, which will also increase the yield on bonds and debentures. So that rate will also go up, wherein you can track to put money into some options wherein you can get good returns and in a more secured manner. If you see the quarterly earnings and the results which are coming up, industry is recovering. The third quarter result of industry is also better than the expected. This is all my personal opinion, non speaking on behalf of National Stock Exchange. So even that investment which is done from a long term perspective will give you good returns. Just you need to follow a few thumb rules which I have brought specifically for this session. So here are the 10 commandments that one can follow for a good investment life. The first one is stay away from greed and fear. There are two types of sentiment that always hurt investors. First is greed for a very very high return, wherein he makes some poor investment decision. Second is fear, a sudden news or a fall in market, or there is some news or rumors spreading around that create panic. So I don't need to carry greed. And second is I should not get panic. Second most important thing is think long. Whatever good and bad can be in short term. In long term, uh, all the investments specifically that are linked to equity market will give you very 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 good returns. You can just note from this fact that the Sensex, which was on 100 rupees in 100 basis point in 1982, today it is standing above 50,000. So in simple layman word, अगर किसी ने 100 रुपया सेंसेक्स में लगाया होता 1982 में, तो आज वो 50,000 रुपया हो गया होता. 100 रुपए का 50,000. That is the growth potential which is just in front of you. And if it is being compared with any other investment option, I don't feel so कि they can match. But the thing is you have to stay long. इसमें कितनी बार मार्केट गिरा होगा, क्रैश हुआ होगा, वो सबको भूल जाइए. In long I'm talking about. Third, go with quality. So whether you choose stocks, whether you choose mutual funds, whether you choose any other asset, don't compromise on the asset quality. Invest right and sit tight. This is a famous quote by uh, billionaire investor who says that you have to choose the right stocks, right companies, right mutual fund, invest and then forget it. Point number 4. Don't put your all eggs in one basket. Over this past 15-20 minute session, many times you might have heard I said make your own portfolio. So what I mean by that, so if I have 100 rupees or 1 lakh rupee, don't put it all in one investment option. Try to diversify. Maybe I'll put it 20% based on your priority. And how to prioritize, there are 6 things which I already said, like the liquidity, the maturity, and so on, the safety of that product. So I try to put in 20% of my fund will put into real estate, 25% into mutual fund, maybe 25% into bond market, 10% into bank FD, 20% into gold, and I'll keep 10% liquid for any opportunity that I get. So आपको इस तरीके से अपना फंड प्लान कर लेना है और सभी एक ही जगह नहीं डालना है, क्योंकि कभी एक ऑप्शन अच्छा रिटर्न देता है, कभी कोई और ऑप्शन अच्छा रिटर्न देता है. सो ओवरऑल आपका जो पोर्टफोलियो है वो बैलेंस रहेगा. So the fourth commandment is don't put your all eggs in one basket. Fifth, use FNO to hedge. I many times find people using it as an instrument to make money, but it is very very high risk instrument. If you can afford to take that risk, put money. But for professional who are not full time dedicated to stock market, I suggest use it only as a hedge instrument. Sixth, invest objective wise. Whenever you try to put money with objective. Now objective could be anything. It could be for achieving your particular goals, it could be your children's education, their marriage, your retirement, and so on. So you can decide an objective for which you want money. You can put a timeline when you want that money, and then you put that money accordingly and choose the investment option for that objective. Point number 7, make your own corpus and target amount. So as I said, the portfolio. So make your own corpus and put a target that every year, if I put so much amount of money, it will expand at this. And at the age of 50, I want this, or at the age of 55, I should have this much amount of net worth, or 60, I want this, or 40, whatever it is. Put a timeline and a targeted amount, because that will help you to achieve the required target corpus that will make you financially independent, wherein you stop working for money and money starts working for you. Point number 8 is plan for retirement. Specifically, uh, people under 40 many times don't think about retirement because they say it's a very, very long time to go. Why I should today think about retirement? But the thing is, the earlier you invest, you get things at a lower cost. Just for example, if somebody had brought an investor shares 10 years back, If somebody had invested 10 years back in land and you compare the prices with today, the returns would be very higher. So the early you start investing, the higher is the returns, because समय के साथ चीजें महंगी होती जाती, जितना जल्दी खरीदोगे उतना सस्ता मिलेगा. Point number 8, consult expert whenever required. As our core field of expertise is not finance and stock market, so it is always advisable that you go to an expert whenever you are trying to construct any option or do any investments and reviews. And the last is review. Don't review your investment daily. So whatever investments you are making, don't review every day. Just like I put in a FD and I sit for 5 years to get that return. But what happens is when I invest in an option where I can see every day, just like for mutual funds, for equity, तो लोग रोज सवेरे आज मेरा शेयर बढ़ा या नहीं बढ़ा. If I'm putting it from an angle for getting return 3 years later, don't check it every day. You can check maybe once in a month or once in a quarter. That's sufficient. But रोज उसको देखते मत बैठिए, क्योंकि आप कुछ गलत डिसीजन ले सकते हैं. Maybe to buy it more or to sell off the shares you have in panic. So there could be a short-term issue, but in long term the issue would be resolved. And overall, from a conclusion point of view, as I said before, that uh, people should buy mutual fund, right? So these are the reasons that why I suggested buying mutual fund or investing in mutual fund is a good option. First, as I said, it is professionally managed. It is highly regulated, because Security Exchange Board of India has a keen eye on how the portfolio is being maintained. Second thing is transparent. Everything has to be disclosed at the day, and they have to give the what is the उसका unit value क्या है, ठीक है, पूरा जो उसका वैल्यू है वो क्या है, कौन से शेयर्स है, व्हाट इज द लिस्ट ऑफ कंपनीज वेयर दे आर पुट इन मनी, व्हाट इज द परसेंटेज, व्हाट इज द बाय सेल, एवरीथिंग इज डिस्क्लोज्ड. देयर इज नथिंग अंडर द कारपेट. Third is it is liquid. You can easily sell it off, and within 3-4 days you'll get your money back. And there's a good liquidity. You can easily convert. Fourth, it is convenient. Now there are many options using your Demat account or using various options like ET Money or Grow Plus. These are apps which you can use to buy mutual fund very conveniently. The fifth option is small size. You can start investing with SIP like 500 rupees, 1000 rupees, और लम सम फ्रॉम 5000 रुपीज. सो बहुत आसानी से कोई भी इन्वेस्ट करना शुरू कर सकता है. टिकट साइज कोई बहुत बड़ा नहीं है. नेक्स्ट इज इट इज डाइवर्सिफाइड. एज आई जस्ट सेड that don't put your all eggs in one basket. A mutual fund company don't put all money in one stock. They put it into maybe 50-60 shares with diversified sector, diversified across industry. So maybe sometime pharma industry does good, sometime maybe IT does good, sometime banking does good, but anyone will outperform and your returns would be good. Next is well regulated. So government guidelines are very strictly followed, and low cost. The transaction cost of mutual fund is very low, and very less brokerage is not brokerage. The expense ratio which is being done is also very low. So these are some of the reasons why I feel people should buy mutual fund. Now, before we sum up this session, there are some myths which are to be busted, which I feel. First is stock market is gambling. Many people still feel that stock market is gambling, but that's not the case. It is the aggregate amount of buying and selling that takes place in the market will decide movement of the share, and it is not mere like a lottery. Second is people also feel what goes up will come down. For example, just take a reference. If I feel that during lockdown there was a X company, X bank share, say SBI came to 150, 152 rupees, and from that today it is at 400, 410 rupees was 2-3 days back, the high which SBI reached. So I assume no, again it will go back to 150. So this is not going to happen. There were X circumstances for which it was at that. Now that circumstances don't exist, so the share is not at that point. Or third myth is people feel that The shares which are at a lower price are good to buy and will give you return. I often get call from friends who says ki Ajay, tell me a share which is below 25 rupees and I will buy. And I say, why you're looking for something which is at lower cost? Because they feel increase of 5 rupees in a 25 rupee share is easy. But that's not the case. Market percent पे चलता है, rupees पे नहीं चलता है. So the effort required by a share to go from 25 to 30 is same as that is required from 2,500 to 3,000 rupees. So don't choose your shares by the share price, the one which are available at a lower price. Rather, choose one which are more fundamentally strong, which are quality stocks, which are posting good results, where the governance is good, the management is positive, there are no issues related to regulations. Try to look for such companies which are quality stocks. And the last myth to be busted is buy what's in news. People feel watch a news channel and whatever comes in news, typically go with that. But just for your information, the time required from the actual happening of the news to it reaches to news channel till it reaches to you is very long. And there are people who have a better update of market than us who are just watching news. So many times when the news reaches to a retail customer, it is already factored in. And when retail customer tries to get into the market, the stock starts correcting. You might have sometime experience also. It's not necessary that this will happen every time, but it happens. So don't just blindly follow what news says. And moving towards the end of this, as I said, Security Exchange Board of India can help us to take care of the complaints. So there is SCORES, SCORES, that is SEBI Complaint Redressal System. So if you are done some investment and there are some grievances related to that, where you are, at loss, you have evidence of it, and you have done it in a prudent way. So you can file a complaint through the SCORES, which is online grievance redressal system. Additionally, there are two helpline number which are being shared here. These both belong to Security Exchange Board of India. So they are available in almost 14 languages. You can call them during weekdays from, I guess, 9:30 to 6 o'clock. You can even do a demo call and talk your queries or anything that is related to the investments market. On behalf of BAIP, I suggest that you can follow us on various options which are available. That is Board of Industry Academia Partnership. So thank you all of you for patience listening. Here's my contact number and mail ID. With the time available, whatever best we are being able to serve, I have tried to do it here. And anyone else has any query, they can WhatsApp me across the number. They can also drop me an email to the mail ID which is mentioned, and I'll try to revert you within 24 hours on that. It was pleasure interacting with all of you. If there are any question, please route it. I'll love to answer.
Thank you, sir. Thank you. I'm sure that all of our delegates will follow your 10 commandments. Thank you for your lucid lecture. Thank you. So moving on to our next topic.
Network
Hey everyone, I wish to inform you all that there are some technical glitches on their side and they're working to resolve them shortly. Please stand by.
Hello.
Yes, Dr. Kiran.
Hello. Sorry for the technical glitch. Is Dr. Nagarkar online?
Yes, he's here.
Yes, sir.
Yeah.
I guess we lost him again.
This is Dr. Nagarkar here. I'm online. Kiran, I think we're not able to connect to you.
Yes, he's just signing in. Okay,
Yeah.
he's connecting. Dr. Kiran.
Yes, sir. Yes, sir. Sir, without wasting much time, I request you to start with the lecture.
Well, friends, good morning. And I think I would disagree to some aspects of Dr. Ajay, because here he talked about the financial aspects which a doctor should be knowing about. And while listening to his talk, he was pretty clear that as doctors, we do not know much about share market or gold market and financial parts because we are not trained for it. Let's be honest. I think we are trained to see patients and manage patients. And with that note, I would say that every doctor can be an entrepreneur. And in fact, we should practice focus more on what we are trained at. And if we are able to do that, we'll be able to do more justice to our profession and our society also. Looking at the current scenario of all our youngsters, students, like whenever we are going through a medical education, I would put it. In fact, this morning I was lucky to be invited for breakfast with one of the greatest educationalists of India, Dr. P.D. Patil, the Chancellor of D.Y. Patil University, Pune. And while discussing with him, these were, I think, the same slide popped up over there. Students, after completing the education, their expectations are that they would be getting to work in one of the best infrastructures with a team of colleagues who would have joint responsibility. Obviously, along with that, they would be patients queues who are waiting for their professional advice and clinical care. And well, all of this is going to be followed by a lot of financial returns, lot of revenue. But is it true in reality? Reality, it's not so. There are a lot of stresses. Not everyone is lucky enough to have one of the best infrastructures or colleagues or human resources. And along with that, the major challenge comes up is how do we keep a match of ethics and clinical care while managing the financial aspects about it. Now, I say that, and I believe in this three phases of a professional career. Each one of us, every professional goes through these three phases. The first one, I call it as a kameshana, where we are desperate to get work. We are looking out for work as a major part. And once we are satisfied with the Kameshana part, we get a lot of work. Then we start focusing on Dhaneshana, where we feel that we need financial returns. We need to be rewarded in that particular manner. Once you are satisfied with the Dhaneshana arm, then comes the phase of Lokeshana. There is no fourth phase in a professional career, I feel. And the earlier we climb up the ladder from Kameshana to Dhaneshana to Lokeshana, I think that's when one starts enjoying the professional career which he or she has chosen for. Well, this would be a simple question for all the August members in this gathering. It's which phase of this professional career are you going through at this point of time? What are the types of medical infrastructures in India we have been looking forward to working in? One is obviously the consulting clinics, the age-old scenario, nursing home practices, large nursing home practices, corporate hospitals, trust-run hospitals, government and semi-government hospitals. Let me be honest with you, friends, that none of them seem to actually satisfy most of us. And I have worked in quite a few of these type of infrastructural practices, and I realized that I was not happy because each one of them had their own concerns. Like the reasons for discontent were various at various levels. They could be personal also. Working in small nursing homes or clinical practices, or in fact large nursing homes also, the major challenge was working with untrained staff, lack of team members, lack of facilities and infrastructure, lack of protocols being followed related to that particular specialty, non-compliance and irregularities when it comes to the statutory requirements, non-alignment of goals. I think this is a very important aspect of a professional part. If there is non-alignment of goal, no wonder how beautiful that infrastructure or how modest that infrastructure is there. These non-alignment of goals mainly I feel are related to ethics, related to technology, and the third one comes up for revenue. And as doctors, almost all of us are so highly educated. We go through the grind of 10, 12 years of education. Nowadays, it's almost 14, 15 years. We need to start developing this nature of getting sulking to work under non-medico CEOs, or even for medical, medical bosses where our philosophies do not match. And in the current scenario, the medical legal issues also have coming up. And now in the last 5 years, I would put it, is what is important is the patient expectations. Patient expectations are changing. I have been in a private practice or a professional career for almost 2 decades now, and I have seen a marked change in the patient expectations from doctors over these last decade or so. Well, there could be schemes like Ayushman Bharat and Mahatma Jyotiba Phule. Schemes like this could be responsible, or is the changing healthcare scenario responsible, is an entirely different topic. I feel this is the era where the need for hybrid hospitals is very important. Hybrid hospital, meaning I would put it that these are doctor-driven enterprises. They're doctor-driven enterprises because they can be highly well regulated. They can be hassle-free. We as a doctor, I would be best to understand the requirements and expectations of my patients. We can offer them good hospitality, make sure that all available facilities for that particular care are available under one roof. It has to be technically updated. I'm sure none of us would be satisfied working for a big high packet of remuneration if we are not satisfied in working in that setup, because it is not technologically updated, or it is not as per the ethos of medical practice. Implementing government schemes and insurance schemes, when it turns out to be a turnover driven practice, has now become an integral part of every clinician. In fact, I always feel, in fact, today morning also I added that probably every doctor during his MBBS curriculum, time has come that he should be given an assignment regarding empathy, regarding management of skills related to interpersonal relationships, as well as managing your own setups also, because that's something most of us we are missing, because we have been trained so well to diagnose, to prevent, and to treat. But how do we amalgamate all these things when it comes to management is what has to be incorporated, I feel, in the clinical curriculum also. Overall, better patient care and a better hospital is obviously going to be associated with a better patient satisfaction index also. There have been various articles, right from Harvard to Cleveland, Forbes, all of them have proved it beyond doubt that the best hospitals in the world are actually managed by best doctors. And however, everything there is the other face of the coin as well. Because if you look at this particular slide, it actually says that of the top 50 hospitals, almost 27 of them, that's more than 55% of them, were managed by physician-driven CEOs. And at the same time, we have another chart which is talking about the bottom 50 hospitals. And if you look at the bottom 50 hospitals, majority of them have been managed by medical CEOs. So not always that physician-driven CEOs manage the hospitals in the most profitable way. Probably because many a times I put it that we think from a heart and not from a brain in some part. However, times have come that these things also need to change. So when a healthcare professional involves entrepreneurship as part of his clinical day-to-day curriculum, I feel we are coining the word of a doctorpreneur or a healthcare entrepreneur. This COVID-related scenario, all of us have seen, all of us have voiced the feeling that there is now the time is right that we need to have we need to have scenarios where rather than an IAS or a non-clinical administrator dictating the terms about healthcare management, healthcare administration is the need of the art, not only for need of the time, not only for this country, but for the world over. I feel that a health professional who has ventured into the field of entrepreneurship and innovation is someone who would call it as a doctorpreneur. Now, what are the basic fundamentals of being a doctorpreneur? I think for what I have looked at myself, I would put it that we need to be honest to be yourself. You need to be with your gut and listen to yourself. And if you can do that, if you can be your own guru, follow your instinct, it is not difficult. There would be many times we usually learn or we usually fail because we are afraid to fail. We do not fail because we do not make an attempt to succeed. We fail because of that fear that we will not be able to do it. And that fear actually makes us more conservative and it does not permit us to fly high. Now, there are certain simple rules I feel which need to be followed. And the bottom line is you cannot be an entrepreneur or a doctorpreneur if you are not a risk taker. You have to take certain risks. They could be balanced risk. And as I said that we heard Dr. Ajay talking earlier, whether it is share market or anything, you need to be a risk taker. So why not be a risk taker in your own profession about which you know the best? You know your patient's expectations, you know the requirements of your professional career. So you are much better at taking the risks is what I would feel. The 3 thumb rules which I follow for myself is you need to have a personal integrity. You need to be true to yourself. What are your work ethics? You need to be transparent in your dealings. I have been very, very clear. Like now, I started Curie Manavata Cancer Center in 2007. I was extremely clear that I need to have a scenario which is going to be a patient-driven, focused, a doctor-driven enterprise. Before starting Curie Manavata Cancer Center, I was attached to 84 hospitals in and around Nasik. And on 14th May 2007, I decided no, that I need to be committed only to one setup. Until unless I'm committed, it cannot grow. So that was my integrity, which I have managed to date. And I feel that I'm thankful to the our entire medical fraternity and the patients who have supported me in this integral part of my career, where they did not actually try to deceive me from my goals and my ethics. Every person during the practice, you will fail. There will be failures but failure should not be taken as failure. They have to be taken as lessons. and success needs to be shared. As I said that I started Curie Manavata Center with a team of 35 people. Today we are a team of 685 people. And these 685 people, they have stuck with me, they have stayed with me during thick and thin, only because I have been honest enough to share the success with them. Entrepreneurs are good at, you need to sense an opportunity. All of us know that there is an opportunity. And at the same time, when you know that there is an opportunity, you should be ready to exploit that opportunity. That exploitation of opportunity at the right time is what actually helps you. Now, who are you? Need to be answered by yourself. Are you an entrepreneur or are you an intrapreneur? Entrepreneur, obviously you are your own boss. You have a little more freedom, but obviously it comes at a lot of risk for yourself. Whereas an entrepreneur is someone who has little less freedom. I won't say no freedom, little less freedom. There is very less risk, but you are working for an organization which can be part of it. Now, if I have to look at the entrepreneur within myself, I was very clear way back in 2003 that I had big dreams and big goals. So if I have big dreams and big goals, even if I do not pursue it myself, then I will end up working with someone who has big dreams. So the best part was, why not get into those shoes myself? And it took me about 5 years of planning till the point of time when Curie Manavata was launched in 2007. However, my planning has not stopped after that. In fact, every single moment, every single minute, the planning continues, because you need to go on changing as per times. You need to change your strategies, you need to change your goals, and the goals go on increasing. In fact, on a lighter note, 2007, when I started Curie Manavata, that time my loan, which I had taken on my head, was close to around 3 crore 75 lakh rupees, which increased to around 6 crore rupees by the end of 2007. And I used to tell my wife very clearly that, and very adamantly also, I would say, that in the next 10 years, I want to lead a loan-free life, because no doctor likes loans. But today, in the last 14 years, my loans have not reduced from that 6.5 crores to zero. I had planned that in 10 years, I want to be loan-free. However, instead of reducing, today my loans are 173 crores. But even if my loans have increased from 6.5 crores to 173 crores, but the enterprise value, more than earning money, the fortune which has come out and the brand value which has come out, that is much more. We need to be very honest in asking the right questions to yourself and planning meticulously at all the various cornerstones during the journey of a successful business model, I was put it. In fact, there are many in this country who are great doctorpreneurs, and I think we should take lead from them, and we should take, we should follow their footsteps. HCG is one of them, with Dr. Ajay Kumar, Apollo Hospitals. In fact, I was very keen and very surprised that the first Apollo Hospital, when it came up, at that time, Dr. Pratap Reddy, sir, was 52 years of age. Dr. Ajay Kumar started HCG at the age of 54 years of age. But Dr. Devi Shetty started much earlier. And all these, including care hospitals, teleradiology, Dr. Agarwal's, and so many enterprises, are excellent examples of doctorpreneurs. And I think we should take a lead from them and move forward, taking small steps, rightful steps. Now, in the last 20 years, I have been repeatedly hearing that most of us, including myself, we actually try to shy away whether medicine is a profession or medicine is a business. So some of us, we say that medicine is a profession. Some of us are like, no, sulkingly, they say, no, medicine is a business. Well, the world has accepted it that medicine is a business. However, then why are we trying to deny from the facts? I don't mind saying that, yes, medicine is a business for me, but I am in the business of bringing back smiles. But while in this business, I clearly understand the difference between profit and greed. I want my organization to be a profitable organization. I don't want it to be a greedy organization. If I say that I don't want my organization to be a profitable organization, then the organization cannot survive, it cannot grow. For the survival, for growth, for it being an organization where, as I said today, 680 families are part of HCG Manavta Cancer Center, Nasik. So when there are 680 families which are dependent on this organization without having any financial support from a state or the central government or any, then we have to admit it and understand the ethos and the philosophy of the organization and move forward. See, it's like, it's been a long journey, but in 1990, I was doing my 12th standard, and with a very clear vision that I wanted to become a petrochemical engineer. But not all dreams come true. I have, in fact, done 15 days of petrochemical engineering at MIT Pune, because I had no medical background in my family, and I was quite happy that, okay, let me do something new, and I wanted to do petrochemical engineering. However, my grandma was diagnosed with cervical cancer, and I realized that no, probably, and my dad was the one who said that we have everything. We have a social scenario, we have financially we are sound, but we lack medical professional in our family. And I decided that let me go ahead with medicine, and I went to JNMC Belgaum and did my MBBS from there, with a very clear vision that I want to pursue surgical oncology only. And well, 95 to 2000, I was lucky enough to get trained in one of the leading institutes in this country. It's my alma mater. Tata Memorial Hospital gave me what I actually wanted. After that, I went on to do my MRCS at the Royal College of Surgeons, Edinburgh. I was the second Indian to do my MRCS, to clear my MRCS examination. Had an opportunity to work at the Christie Cancer Center. However, during that era, I had 9 of my family members who were diagnosed with cancer in a span of less than 10 years. So probably destiny had chosen me to move away from petrochemical engineering to medicine to take care of my own family and my own city, is what I put. So the zeal to serve my family was something which brought me from Tata Memorial to Christie to Nasik. I started my practice at the end of 2000, and it was with late Dr. Vasant Pawar sir, where I started my surgical oncology practice. I was very clear right from day one that I wanted to practice only surgical oncology, no hybrid practices, no general surgery. And well, that helped me. Cancer, I realized and I understood that I am into a surgical oncology practice, and I realized that surgical oncology is a global concern. In the years to come, we are going to see more and more cancer patients in this country, and probably what the patients needed was comprehensive cancer care, where it was a scenario where I was operating a patient in various nursing homes. Chemotherapy was given bits and pieces. There were no major radiation therapy facilities available in Nasik other than Uddhav Memorial, which had a Cobalt Center, and Pravara had a Cobalt Center. Entire North Maharashtra did not have a single radiation facility. So this fracture treatment scenario was something disturbing. And probably I realized that the need of Nasik at that point of time was a comprehensive cancer care facility. That was something which I sensed it, and I started looking forward to opportunities to create that. That was my major persuasion, that I was not very happy only performing surgeries. In fact, Dr. Vasant Bede sir and Dr. Sampath Pawar sir, they know that my first surgical case used to start at 4 a.m. in the morning. And I used to finish my OPD around midnight. I'm thankful to my wife that she did not divorce me during those days. But more than the work pressure, what was disturbing was the fracture treatment which was there. And I decided to take a jump and set up a cancer center, which would be a comprehensive cancer center. So 14th May 2007, we started with 35 beds of Curie Manavta Cancer Center. And it was more of a surgical or a oncology nursing home. It had the first linear accelerator radiation machine in Maharashtra after Mumbai, Pune. In fact, when I had decided to put up a LINAC, many friends and colleagues said that, well, this is not the right decision, because that time a LINAC was costing almost 6.5 crores. And it was like one of the senior clinicians and senior members from the medical fraternity had, maybe with concern, said that, Raj, there are better ways to commit suicide rather than trying to set up a cancer center. But I felt, well, my gut was saying that I need to do it. So I followed my gut. No due diligences, no financial models. I said, fine, I need to be here. I need to be committed. And we started it. The first linear accelerator in North Maharashtra, the first PET CT scan in North Maharashtra, and 35 beds went on from 2007 till 2014 or till 2014 end. We had already achieved a few milestones. The first NABH accredited cancer hospital in central India. We had treated almost 40,000 patients by that time, and we are involved in more than 200 clinical trials. And out of these 40,000 patients, there are 29,000 patients who were below poverty line who were treated in various government-run schemes. Academics also was an integral part during that period for me and my colleagues, where we started these MUHS-run fellowship programs in breast surgery, head neck surgery, medical oncology, clinical research we started in. In fact, Curie Manavta Cancer Center was the first private hospital in Maharashtra to start these fellowship programs under the Maharashtra University of Health Sciences. We were supported by society at large, where we started this Arogya Saheli, an initiative as part of a CSR activity, where by 2015, we had screened more than 16,000 ladies completely free of cost for early signs of cervical and breast cancers. That was also the time that I felt that myths and misconceptions about cancer was so large in society that they needed to be addressed. So I wrote about 2 books called as Ashish Ankur. One was about the basic causes and the symptomatology of various cancers, and second one was about the success stories of cancer. And both these books have been more than 10,000 copies of the first edition have been sold, and the success stories, more than 23,000 copies have been sold in Maharashtra. And all these funds were used for the needy cancer patients. While all this thing was going on one side I was happy, but started realizing the fact that if you look at the commercial or the consumer related ideology, there's something called the law of attraction in industry. If you buy a car, any car, you must have realized that the car maker changes the model every 7 years. If it is software, soft drink or anything, the innovator always changes the brand or the way in which the model has been put forward for the consumer every 7 years, because there is something called as a law of attraction. A human mind cannot remain attached to a particular thing for more than 7 years. However, as doctors, we felt that it was infinite. We felt that patient was coming to the hospital in pain, patient was in need of care. So for him or for her, the type of hospital, the type of bed sheets, the color of the ceiling, the type of fan did not really make a difference. In fact, so many patients used to come to me during that era. They used to ask me, sir, fine, we would like to go and get operated in Mumbai or Pune or wherever it is, and we would like to come for follow-up with you. And I have to ask them, why? Why is it that you would prefer going to Mumbai or Pune? Nothing against our colleagues and seniors in Mumbai, Pune, but why is it that you want to go there? So there was something called as a social ego. That social ego was such that more than if you actually try to say that what are the expectations of a patient from a hospital or for a doctor, most of us feel that it is the money, the pricing which actually dictates. Honestly speaking, the pricing is the least of the factor. The most important factor is customer satisfaction. The second part comes up the product, what you are offering, and third is pricing. Truly so, had it been only free treatment which is attracting a patient, then probably all government-run hospitals would be flooded with all these scheme patients. Scheme patients, in spite of having a free treatment in government hospital, they want to take free treatment in private hospitals because customer satisfaction is the most important fact. So, well, I am a follower, or I believe in Bapu, that customer is the king. Here, my customer was my patient, and I had to follow the expectations of my patient as to what he was expecting what was his requirement, and I realized that my patient's requirement was hospitality. Patient needed hospitality along with the medical care which we were offering. So the hospitality could come with the infrastructure which was at par with any of the major cities in the country. It had all the technology, all the ambience, all the comforts which were the patients needed. And then we started working on a project plan for that. And I realized that my dream was to create an infrastructure in Nasik which was at par with any. I'm not talking on Mumbai or Pune. I was looking at a center, maybe Sloan could be like that. Maybe why not Harvard can come to Nasik. So, but the dream which I was looking at, the dream was worth 200 crores. And that 200 crores figure did not actually pull me back. I felt fine that it's going to cost me 200 crores. How do I raise this 200 crores? And that time I realized that no bank was going to give me an investment of 200 crores. However, working for close to 8 years after setting up Curie Manavata Cancer Center, there was a brand value. All of us, in fact, in Nasik, we know Dr. Kakatkar sir. We have seen seniors, clinicians. Dr. Mutha sir is there. Dr. Ghadge sir. All of them are excellent clinicians who have dedicated last 3.5 decades for this. So each one of them have a brand value, and I felt I had created a brand over those 7-8 years of working, and that time was there to capitalize on that brand value. And also, it was a time to move from me to we. We, as doctors, we always try to feel very insecure of parting away with a brand. But I accepted that I had to move away with my brand and to capitalize on that. And that was a time I shared my hands with HCG, and I actually diluted my brand 51% to HCG, and HCG Manavata Cancer Center came into existence in 2018. Now, I feel as doctors, since it's a more of a virtual, but with more than 800 doctors part of this meeting, I would like to ask each one of you all in person, and you all answer to yourself that when you ask, what do you want to earn? So 99% of us, we say that we would like to earn money against the professional services which we are doing. I feel that it's not money which is important. It is a fortune which is going to really make a difference. And I had realized that dream early, that it was not the money part which was going to come forward. If I had to do something big, it was a fortune which had to be created. And 2018, I actually diluted 51% of my shares. Now, what were these 51% shares? These 51% shares were not in the form of any item. It was not in the form of any infrastructure. It was not in the form of any particular bank balance. It was in the form of the goodwill. It was in the form of the brand value, which Dr. Raj Nagarkar and his team has created. It was not an individual. It was the clinical colleagues and it was the staff. Because by that time, we had moved from a 35-member team to 375-member team. And HCG sensed this opportunity and they diluted, they took 51% share in HCG Manavata Cancer Center, against which HCG at that point of time gave us 72 crore rupees for that 51%. You might call it as a virtual. It was just on a piece of paper. There was no transfer of property. It was more so a transfer of a value which as doctors we had created by a service to patients with a 40,000 plus patient pool in Nasik. And well, we have always been extremely lucky to be blessed by the Almighty in all our endeavors. And HCG Manavata Cancer Center came into existence on 14th May 2018. 14th May is an auspicious day for me because it's my father's birthday. So 11 years after Curie Manavata was formed, we started HCG Manavata. And the punchline was very clear that accept your illness with grace. We make it happen at HCG Manavata. So to understand, to realize the fact that we were now moving forward from a section of our patients who wanted patient care, now we are moving forward to a section of our patients who wanted their care related to their therapy, but they wanted it with grace. They wanted it with hospitality. They wanted it that their social ego needs to be addressed. There were patients who were from small areas. I remember a patient from Pet coming to me and telling, sir, मला मुंबईला जाऊन ऑपरेशन करायचं. म्हटलं मुंबईला का जायचंय? The answer was, गावातल्या लोकांना कसं सांगेल की नाशिकमध्ये ऑपरेशन करून घेतलं. So that was a social ego which he had, that he wanted to be treated in a big hospital, in a big city, so he could tell his tell the family members or friends or in his village that I have gone and got my treatment done in a big hospital. So that had to be addressed. So the new premises, a 180,000 square feet premises of new HCG Manavata campus came up addressing that social ego of our patients, and it had everything. Every time I used to go abroad to various hospitals, I used to feel, why can't this setup be in India? Why can't this setup be in my city? I felt that I do not wish to give others an opportunity to say, or I did not want to depend on others to create that. I created that setup myself. And it was all, again, I repeat, as doctors, we might be my chartered accountant many times tells me, so that you are a poor financial planner because you don't look at the return on investment or the financial parts of it. When we were setting up the center in Nasik, he was behind me that, sir, 50% paisa yahan pe dalo, put 50% of the funds in Pune, you start a setup in Pune. But I said that I have to give back something to my own city. And we created a campus, an ambience where patient does not want to be treated as a patient, and illnesses can also be you can, I can't say enjoy, but at least you can face those illnesses in a better atmosphere, in a less gloomy atmosphere, because hospital ceilings are boring and those hospital ceilings need to be changed. And when the setup came up, what should be the technology to put in? So radiation department, which is one of the most capital intense department of a cancer center. So my colleagues, Dr. Vijay, Dr. Prakash, they were like, so let us put in a true beam machine. So my simple part was, which is the best available machine in the country today? The answer was a tomotherapy H machine. I said, why not put a tomotherapy H? So the thing was, if we can get a radiation unit for 8 or 10 crores, why are we talking about investing 22 crore rupees? Where in 22 crores, you could actually manage getting 2 or 3 radiation facilities. But I felt, no, here it was not about how much. I said, put tomotherapy only. And it was the 6th machine in the country which came in Nasik. And I do not regret that investment. I do not regret that investment because that gave us the brand value required. And today, even in the post-COVID scenario where we are going through, we see a good number of international patients who come to Nasik because they feel that this center has given them the required therapy, technology, and the ambience also. In fact, the first slide on this, first image on this slide, left-hand side up, is our bunker of a tomotherapy H machine. In fact, the tomotherapy H bunker was designed in such a way where I had told my architect that I don't want a bunker which has plain walls. I don't want a patient to be there inside thinking that I'm alone in this room surrounded by walls which are plain and which are non-talkative. So I told him, you design it like a beach. And when the entire bunker was designed, the engineers had come from US for the installation of the machine. There were 64 tomotherapy H machines at that point of time installed world over. And the engineer put that image of the bunker on his Facebook wall, saying that this is one of the most beautiful bunkers which I've seen. And believe me, his Facebook friend was a gentleman from Dubai who was diagnosed to have a brain tumor. Just on that profile, he shared that patient from Dubai for his radiation came down to Nasik, stayed in Nasik and took his treatment. So I feel that no investment, no attempt goes to waste. We should try and make it as fruitful and as ethically driven as possible. And technology, as we've always said, that the best buildings do not make the best homes. The best infrastructures do not make best hospitals. If you want to go ahead, you should go alone. But if you want to go far, you have to go together. And I think HCG Manavata Cancer Center, we have reached this far is entirely because of our team effort. At this point of time, happy to say that we have a team of 35 plus full-time consultants who are instrumental in where we are reaching forward. Even during the COVID era, 25 plus bone marrow transplant, 324 robotic surgeries in 365 days has actually helped us be what we are. Keeping patient-centric ideas, every patient, and particularly when it comes to cancer care, there is a lot of emotional support required for the patient, for the family, for the caregivers. Our psycho-oncology department was actively involved in that. We are happy that now HCG Manavata Cancer Center for last 3 years, we are recognized by Diplomat of the National Board of Examinations for DNB in surgical oncology. This is a third batch of students. This year, we'll be starting a DNB radiation oncology. Hematology has already been approved. It's starting a DNB radiology and pathology in this next academic session, along with the MUHS courses. Now, patients have continued to be involved. A team of 680 people. Today, we see close to 450 to 500 patients on a daily basis who, with more than 210 radiation patients and 300 plus surgeries per month, is what we have been supported. Where people used to talk about one radiation facility in a cancer center, I'm proud of my colleagues where we have 3 radiation machines in a cancer center and we are constructing 2 additional bunkers because we feel that in the years to come, these 3 machines will be inadequate or incomplete. Financially, see, if you are doing genuine work, even in a place like Nasik, we have been able to meet annual targets of 110 CR plus. Well, this can be possible if you are working in volumes. It's not that you have to be a very costly organization. It has to be as I said, we understand the difference between profit and greed. And on 26 January, the state administration, they honored us with an award because in the entire state of Maharashtra, after Tata Memorial Hospital, highest number of patients being treated in the government-run schemes was done at HCG Manavata Cancer Center. And we treated more than 38,000 patients, where our old hospital has been completely dedicated to these government-run scheme patients. We don't charge the patient anything. While these volumes were working out, it was heard for, it was noted, it was taken cognizance of beyond the 7 Cs. In fact, Professor Mark Slack and his team at Cambridge Medical Robotics, they understood our capabilities, our skills, and our scope. And we tied up in 2019 with CMR for the Versius surgical robotic system. And as I said, in 2020, in 365 days, we have done 324 robotic surgeries, which by itself is something like a record. And because of that, we are now a training institute for CMR for robotic training. We have surgeons coming from India, from Middle East, from UK and Europe as well for training themselves in robotic surgery. And that speaks of the quality of work and it helps us remain updated also. Over these years, we had patients coming from North Maharashtra, we had patients coming from South Gujarat, we had patients coming from Shahpur and almost up till Pune. But there was time to move ahead. And 2019, we started our outreach OPD in Uzbekistan at Tashkent. We had monthly OPDs over there. And over these OPDs, we saw so many patients and these patients started coming to Nasik. And now we'll be starting our daycare facilities again from March in Uzbekistan. And I feel that as a doctor, I'll just take another 2 minutes. As an individual, we always think about earning money. My dream, and in fact, I feel every doctor's dream should be to create a fortune and not just to earn money. Because money and fortune, though they sound alike, they are not alike. They're quite different. Recently, we launched the free mobile cancer screening van. And thanks to the trust of the hospitals, HCG Manavata Cancer Center new setup has already tied up with 2 global giants for 200 super specialty beds and 100 mother and child beds. The construction is starting in this coming week. And 14th May 2022, I expect that we will be having 500 beds in the new campus where it would be more of a super specialty in mother child care and oncology. And in fact, I'm in Pune today and yesterday only, we have signed a deal for setting up a 50-bed cancer center at Parbhani as part of Dr. Praful Patil multi-speciality hospital, where we are putting up a radiation facility and high-end oncology care. So friends, I think that has been the journey of HCG Manavata Cancer Center, and I think this journey can be every doctor's journey. Every doctor is an entrepreneur. We need to understand our individual our strengths, and I feel that rather than investing into shares or investing into farms or investing into gold, you should invest in your own profession which you are trained at. And if you give back to your own profession what you are trained at, your profession is always going to reward you back, and it gives a sense of satisfaction. It gives a sense of gratitude. And if I could do it, I'm sure all of us can do it. All of you all should do it. We always calculate our commitment towards our society, towards our profession in terms of what our patients has given back. We always calculate our returns in terms of monetary gains. I think time has come that each one of us should calculate a brand value which we have given to our society. And if that brand value can be capitalized on, we can also be entrepreneurs, and it would be better that we run our own show rather than working for somebody else. Thank you very much for this opportunity which is given by IMA President Dr. Samir and the team, and I hope that I have done justice to this time slot which has been given to me. Thank you so much.
Great, sir. It was very nice to hear from you. And thank you for sharing clear, honest, and philosophical success story about being a doctorpreneur. And it is great insight for all of us, all our young doctors, to listen from you. Thanks a lot, sir. Thank you.
Thank you. Thank you.
Moving forward with our my friend, Dr. Sachin Devre, who is going to give insight us on laser in anorectal cases, a game changer. My friend Dr. Sachin has done MBBS and DNB general surgery at Bridge Candy Hospital. Dr. Sachin Devre is a very famous general laparoscopic and laser surgeon in Nasik. He has completed the training of laparoscopic surgery at Bridge Candy Hospital. He also acquired many other surgical skills while working with experts at Bombay Hospital, Jeju Hospital, Bhagwati Hospital, HN Hospital, and he has also he was responsible for handling the entire management of Holy Cross Hospital and Saint Luke Germany Hospital. And over the past 6 years, he has been active in Nashik. He's owner of Saru Hospital, and even he's a young doctorpreneur for all of us. He owns NIMS Hospital, SIMS Hospital, SIMS Yashodan Hospital, and he's planning for more venture in the future. Over to you, Sachin.
Good afternoon, everybody. I'm Dr. Sachin Devre from Nasik. Today we are going to talk about laser in anorectal surgery. First of all, I would like to say the audience is mixed, means everybody is not a surgeon over here and all the doctors are listening this lecture. So I will try to make it simple for each and every doctor. I need to correct a few concepts which are there in the common man's mind and even doctor's mind, that why and where we can use laser. Basically, we are using laser in anorectal surgeries, varicose veins, and some pilonidal sinus. So these are basic pathologies where we are using diode laser. And obviously our dermatology friends and plastic surgeon friends, they are using lasers for skin disorders. So here we are going to talk about lasers in anorectal diseases. So first we will come to what is anorectal diseases. This is innovative topic. This is something new. This is new for each and every person. The newer lasers are coming, newer wavelengths are coming. So people are confused where to use laser, how to use laser, and whether it is going to be useful, new innovation for all diseases or not, where we should stop, where we should use laser, and what is the role of the laser. So I have tried to get all the recent studies and all recent whatever trials are going on. So many trials are going on laser. But for this particular lecture, I have tried to get all the latest information for you people. So I will make it fast. Already it is afternoon. So we will start with the anorectal diseases. So definition of anorectal diseases is these are a group of medical disorder that occur at the junction of anal canal and the rectum. So anorectal diseases are commonly encountered in general surgical practice. So limitations with the use of scalpel during anorectal surgery. So this is very conventional method. Everybody is using scalpel or whatever cautery we are using. So scalpels have been used for many years because of their ease of use, accuracy, minimal damage to the surrounding tissue. One more important reason, we got that training since our residency and since our MBBS that everybody is using scalpel, we are using scalpel, but nowadays the laser is coming and people are started using lasers too. Scalpels cannot provide the hemostasis that is helpful for the use on highly vascular tissue. So anal canal is very much vascular. If you are not using a good hemostatic cautery, or you if you are not using laser, then you may face problem, you may see blood everywhere and it is difficult to stop that bleeding. So these are few limitations of the scalpel. Now we will come to the laser therapy. Laser therapy for anorectal diseases, as you all know that perianal skin is thin and sensitive, hence laser therapy is an innovative treatment for these lesions. Laser is non-contact method for treatment of perianal lesions that typically results in less bleeding, pain, discomfort for the patient. Thus, for the treatment of perianal and rectal tumors, anal fistula, hemorrhoids, and anal fissure, it is considered a suitable option. Laser versus scalpel. One characteristic difference between a laser and scalpel cut is the generation of coagulated tissue layer along the walls of laser incision. All laser tissue interaction produce some degree of tissue vaporization and surrounding zone of thermal necrosis. This zone of thermal damage should ideally be kept to minimum as it may impede wound healing and graft take and reduce tensile strength. So this is something pathophysiological which is not very useful for other people, but advantage of laser. So these are few advantage I'm going to talk about: the greater precision, a relatively bloodless surgical and post-surgical course, sterilization, vaporization, and cutting, minimal or no suturing required, much less or no post-surgical pain. We'll come to this. So these are few comparative studies. They have compared with the different pathologies. They use traditional surgery like scalpel and the laser surgery. So here you can see the hemorrhoids, anal fissure, fistula in ano. So this is blood loss. You can see in hemorrhoids, the average blood loss is around 20 ml, and in laser it is around 12 ml. So difference is around 8 ml. So this is the difference. So laser is less by 8 ml in hemorrhoids, 5 ml anal fissure, 5 ml fistula in ano, and 18 ml total. So in short, there is less blood loss if you are using laser as compared to scalpel. The rate of infection, again the same thing: hemorrhoid, anal fissure, fistula in ano, and these pathologies they have compared with the infection rate. Clear cut, you can see in hemorrhoids the infection rate is around 7.6%, and there is 0% infection rate if you are using laser in hemorrhoids. In anal fissure it is 12.55%. It is 0% in anal fissure. Now fistula in ano, it is already an infected pathology. where many times the infected anal glands are there and perianal abscess is there. Perianal abscess is uh, always there is a fistula in ano unless and until proven otherwise. So here also you can see it is infection rate is 42.8% in conventional method, and in laser surgery it is 16.6%. So it is definitely very less as compared to conventional method. This is also important point, mean healing duration. So in conventional method, whatever you do, generally 3 to 4 weeks it takes, but the mean time is 25 days for hemorrhoids, and in laser surgery it is 19 days. So anal fissure 20 days, laser 11 days, fistula in ano conventional 21 days, and in laser 14 days. So almost you can take an average of this figure also. It is around 1 week. 1 week prior you will get complete healing if you are using laser in anorectal diseases. So we'll come to the advantages of laser. So laser may be used to seal off blood vessels to help reduce blood loss during surgery, along with being able to help seal off infected areas. This is all done with minimal damage to the surrounding area. The other advantage of laser is that it may be used to seal nerve endings. This is very important. This is especially helpful in reducing pain in areas that have undergone recent surgeries. This makes it great alternative to pain medication and their side effects, although this type of surgery is not without its own side effects. So friends, this is very important point. Even if you are if surgeons are listening, and if we are talking about the fissure in ano surgery where we are doing the lateral sphincterotomy, we need to cut internal sphincter, and we are using scalpel or scissors to cut it. But if you are using laser in that case, then the pain may be very less as compared to the conventional surgery and all other surgeries, means fistula or hemorrhoids. Because of this point, this second point, the seal of nerve endings, the pain is lesser as compared to conventional surgery. So points to note: the factors that determine the initial tissue effect include the laser wavelength, laser power, available laser waveform, whether it is continuous, chopped or pulsed beam, and tissue thermal properties. So this laser wavelength, many machines are available in the market. They are having 980 nanometer wavelength machines. They are widely used, and nowadays 1470 nanometer. This is recent machines. They are providing 1470 nanometer. We are using at our center BioLitech Leonardo Dual 45 machine, which is having 1470 nanometer wavelength, and we can select the different modes, what surgery we are doing and what mode is required, that we can choose from that machine. We can do the settings and we can perform the surgery. So disadvantages of laser: obviously laser is not everything for each and every disease, each and every pathology. So there are disadvantages of laser. Laser beams can burn or destroy healthy tissue, which we should be very precise while selecting the wavelength, the energy, the total number of joules used. If you are using more joules, more energy you are delivering, then there are chances of injury to the surrounding tissue, can cause injuries that are painful and sometimes permanent. So laser is something blind procedure. I will say it is blind, means the probe is going inside the cavity and then we are burning, we are seeing, looking at the machine, and whatever machine is saying that we have delivered so much of energy, that accordingly we need to go. So machine is telling and our precision should be there on the patient. So friends, one very important point is that while using your laser machine or laser energy, you should be very particular. Machine should be very particular in delivering that energy and that particular wavelength, and the precision should be there. If you are using some local machine, I would say, or if you are using the same probe, same laser fiber again and again, though the machine is showing that you have done with so many joules, but that energy is not actually delivering to the tissue and everything is blind. You will just feel that you are finished with the surgery and it's done, but the work is not done because you have not delivered the exact amount of energy in exact wavelength. So that is the important point, and that is the disadvantage of laser, I will say, because we cannot see anything. It is not like a laparoscopic surgery where you can see everything. You have removed tumor, you can see, or even in open surgery you can see everything by your eyes. But in laser, we have to assume that this thing has happened. So now we will come to, in short, I will just tell you the other pathologies, each and every pathology individually, and the laser surgery, laser use, and in all these pathologies. First thing is fistula ano. Everybody is know we are using laser in fistula ano. It is having so many advantages to use laser in fistula in ano, and limitations too. The laser treatment for fistula in ano is also known as FILAC, fistula laser closure, or LAFT, laser ablation of fistula tract. Has gained increasing attention in the last decade. The procedure consists of delivering laser energy at 360-degree within the lumen of fistulas by means of radial fiber, which is slowly withdrawn from the external orifice. The laser ablation is limited to the lumen of the fistulas, making the technique sphincter saving. It is its main indication is the treatment of high fistulas in general. Of all fistulas where more invasive treatment may impair anal continence. So friends, for all other specialty friends, I would like to tell you the simple mechanism is, suppose this is the external opening of fistula. You need to, on MRI or whatever fistulogram, you need to get the exact length of that fistula or sinus tract, and suppose it is 10 centimeter, your fiber will go inside. 10 centimeter markings are there, and this fiber will generate, it will throw laser energy in 360-degree manner. So it will go inside. Per centimeter you need to deliver energy, and you need to withdraw it slowly. Every centimeter the machine will give you alarm, and then you have to withdraw it, and slowly you have to come up to the external opening point. So by the time you will reach to the external opening point, the whole fistula tract will be laser ablated. So its main indication is the treatment of high fistulas, and in general of all fistulas where more invasive treatment may impair anal continence. Again, I am coming to this point because sometimes the fistulas are starting from the anal verge or beside anal verge, and it is going directly towards the levator ana, very high fistulas where you, if you are going for open surgery, you need to open everything. Many times if it is transsphincteric or involving both the sphincters, you need to cut the sphincters in open surgery. And here, if you are going above dentate line, there are chances of fecal incontinence or impaired anal continence in conventional surgery. There people were doing this sort of surgeries with colostomy, temporary colostomy for 2 to 3 months, and then they are repairing everything, and again closing that colostomy. But nowadays, because of laser, we can reach up to that point, and we can directly apply laser energy, and there are good chances of healing. In this scenario, we can save the sphincter of the patient. The results of a few studies showed a variable percentage of success, but longer follow-ups were not necessarily associated with higher recurrence rate. Attention needs to be focused primarily on the efficacy of the procedure and not on failure in long term, like other sphincter saving treatments like fibrin glue and plugs. This is more for surgeons. So points to note, friends: the great variability in the type, length, and size of fistula treated may play a major role in affecting the success rate. So there are multiple types of fistulas. It is transsphincteric, intrasphincteric, suprasphincteric, extrasphincteric, horseshoe shape, low fistula, a complex fistula. So it depends which fistula you are going to treat with the laser. You should be very precise, and you should know the exact course of the fistula. For that, I would like to recommend you should If you are using laser, you should always try to investigate patient more prior to surgery. I would recommend to get MRI fistulogram done for these patients, and then you will get exact precise length of the fistula and the exact track and type of fistula, and then you can apply this laser energy to that patient. The shrinkage of fistula tracts caused by laser depends on the wavelength and the amount of energy of laser beam delivered within the tract. With the parameters used by most centers, the shrinkage effect should be successfully heal fistulas with a diameter of maximum 4 to 5 millimeter. There is no guarantee of efficiency of the larger fistulas. So this is very important point. If the fistula, the breadth, the diameter, if it is more than 5 millimeter, if you are dealing with 1 centimeter or 8 millimeter or larger diameter fistulas, then this laser thing cannot help you. There are chances of recurrence. In such a scenario, you should think about something like WAFT, video assisted fistula treatment, where, or the other methods you should use. First try to minimize this diameter to 4 to 5 millimeter, and then try to use laser in those cases. Points to note: there are few studies reported healing in healing percentage 14.6%. In this study, fistulas with a large internal orifice had only 15% healing rate compared to 49% healing in fistulas with narrow internal opening. This is again they are talking about the diameter. If the diameter is more, then chances of healing are less. If diameter is less, the chances of healing are more in laser treatment. Curettage and insertion of celastic drain in the lumen of the fistula in the first stage operation as a bridge to laser treatment. Second stage should be three months later, may induce the formation of fibrotic tissue, modeling the fistula around the draining loop. This process would help reach the optimal width and caliber 4 millimeter, making the fistulas more suitable for the following laser treatment. Again, they are first bringing it down to 4 millimeter, 5 millimeter diameter, and then treating with the laser. How much energy we should use to close the fistula? It is the point of debate. People are using different energies, different wavelengths. So this is controversial point, is how much energy we should use to close the fistula. This is not easy to establish. First of all, it is crucial to understand that to have more precise and reproducible parameters, the amount of energy delivered per centimeter of fistula should be measured. In fact, the measurement of total amount of joules delivered in a single procedure can be misleading, as it depends on energy settings, the wave, the length of the fistula, and the speed of the fiber withdrawal. So this is more for surgeons, not for the uh, other specialties. How much energy we should use to close the fistula? So the per centimeter different joules, different amount they have used. Fistula requiring more than 400 joules had a higher healing rate compared to fistulas requiring more than 400 joules. Delivering too much laser energy to a few millimeter of tissue may result in overburning of the fistula, with the potential effect of increasing the caliber of tract, hampering the shrinkage of effect of the laser. On other hand, too little energy could be insufficient to close the tract. As I said initially, if you should know very precisely what is the length, what is the diameter of the fistula, how much energy you are using, the withdrawal, you will, while operating, you will feel that resistance while withdrawing it. You should be precise about each and every point. If you are doing, because everything is blind, you are just, your MRI is helping you, your markings on the laser fiber, those are helping you, machine is helping you, everybody is everything is dictating that yes, we are delivering so much energy, we are at this point, this point, this point, but you cannot see directly by your eyes. So it is something blind procedure. So it can cause the potential damage to surrounding tissue, and it may be very less energy you are delivering, that you, it is not going to help that patient. patient may having recurrence of the disease. So different energy used by different authors. So people are using 90 joules per centimeter, 39 joules per centimeter, 120 joules per centimeter. The crucial component of the laser technique is still an open question. For us, we are using somewhere around 60 to 80 joules per centimeter with Biolitech Leonardo Dual 45 machine. So pitfalls. Being a blind procedure, many times I say during my lecture, it is a blind procedure. So being a blind procedure, the shrinkage effect cannot be controlled, and the accuracy and the difficulty in the calibrating the amount of energy delivered per centimeter of the fistula tract makes the procedure difficult to reproduce, because the uh, once you have delivered that energy, maybe few joules, 100, 150, or whatever it is joules, once you are coming out from that 1 centimeter, again going inside, it is difficult. The feeling of resistance while withdrawing the fiber from the fistula tract may be helpful in indicating the shrinkage of the tract around the fiber. This is practical thing. Once you will start operating with laser, you will feel that resistance and all other tactile sensations. Intraoperative anal ultrasound may also give some additional contribution to establish the efficacy of fistula shrinkage, but the importance of its routine use during PHYLAC needs to be demonstrated. So we are not using intraoperative ultrasonography. Few centers, they are using intraoperative ultrasonography, and they are, while performing surgery, just like laser surgery for varicose veins, they are using this TRUS, transrectal ultrasonography, and they can see their results on table. The another questionable point is the treatment of the external orifice. By intuition, the distal part of the fistula partly crossing the ischiorectal fossa, extending from the external margin of the external sphincter to the external orifice of the fistula, has lower potential for successful shrinkage by means of laser. This is mainly due to the soft and less fibrotic tissue surrounding the distal and subcutaneous part of fistula tract, which is less sensitive to the shrinkage effect delivered by the transluminal laser beam. In this regard, a core excision of distal tract of the fistula, including the external orifice, may be solution in the selected cases. So this is grossly about fistula in ano. Now we will talk in short about the acute fissure and hemorrhoids, the role of laser. So hemorrhoidal disease, this is very common disease. This is hemorrhoidal disease is ranked first among the diseases of the rectum and large intestine. The estimated worldwide prevalence ranges from 2.9 to 27.9%, of which more than 4% are symptomatic. Men are more frequently affected than women. Development of hemorrhoids and anorectal vascular cushions along with the internal anal sphincters are essential to maintain the continence, providing soft tissue support and keeping the anal canal closed tightly. Hemorrhoids are considered to be due to downward displacement of suspensory muscle. So as all there are different modalities, treatment options are available for the hemorrhoids, means piles. We are treating patients with conservative medical management, nor surgical treatment. Surgical techniques are indicated for the presence of significant external component, hypertrophied papillae, associated fissure, extensive thrombosis, recurrence of symptoms after repeated RBL. So RBL is rubber band ligation. The various non-surgical treatments include the rubber band ligation, injection sclerotherapy, cryotherapy, infrared coagulation, laser therapy, diathermy coagulation, and obviously the other methods, that those goes into the sclerotherapy only. People have invented their own sclerosants and they are using it. The complications associated with hemorrhoidectomy, are rare, and these are anal fissulas or fissure, constipation, excessive bleeding, excessive discharge of fluid from the rectum, fever, inability to urinate or have a bowel movement, severe pain, especially when having a bowel movement, severe redness and swelling at the rectal area, and side effects of anesthesia. Example, spinal anesthesia. Disadvantages of hemorrhoidopexy: a significantly higher rate of prolapse and reintervention of prolapse may cause serious post-operative complications such as rectal stricture and rectal perforation. This depends on the pathology, the patient's general overall health condition, the operating surgeon, his skills, his confidence, and his expertise in that particular type of surgery. Severe chronic anal pain and relatively expensive operation. Comparative study between intrahemorrhoidal diode laser treatment and Milligan-Morgan's hemorrhoidectomy. So friends, the hemorrhoidectomy what we are performing is standard, gold standard is Milligan-Morgan's hemorrhoidectomy, which is conventional excision of the hemorrhoids and keeping few normal skin tags in between the two excisions. So patient population 60 patients with symptomatic hemorrhoids of grade 2 and grade 3, and treatment 30 patients were treated with the diode laser coagulation and 30 patients were treated with Milligan-Morgan's hemorrhoidectomy. Means one is conventional excision of piles and the other group is laser coagulated. So in this comparison, they compared the bleeding and urine retention. The laser group, there was 0% bleeding and 0% urine retention was there. And Milligan Morgan, it was 1 and 4 p value is around 1 and 0.038. The post-operative complication, again acute thrombosis. Three patients found the acute thrombosis, and in Milligan Morgan, obviously the laser physiology is again coagulation is one of the components. So there was acute thrombosis in three patients in laser group. Milligan Morgan, it was zero. Anal discharge, there were three patients were having anal discharge, anal stenosis. Four patients were having anal stenosis in Milligan Morgan. So it is statistically significant anal stenosis in conventional Milligan-Morgan method, which is not seen in laser group. So comparison between the studied group according to 3 months of post-operative follow-up period. This is very important because at the end of 3 months of surgery, we consider that the complete healing is expected, and after complete healing, we can compare few things. So in terms of pain, bleeding, itching, reoperation for symptomatic hemorrhoids, complete resolution, medical treatment for residual symptoms. So complete resolution is seen in all the patients of laser group, and it is seen in only 27 patients. Out of these, 3 patients were having severe pain, or pain was the main complaint after 3 months, and itching was found in 1 patient in Milligan Morgan group, and medical treatment for residual symptoms means 3 patients of Milligan Morgan out of 33 patients they required repeat surgery or repeat intervention. So conclusion: intrahemorrhoidal therapy with a 980 nanometer diode laser is associated with reduction of post-operative pain, intraoperative bleeding, and administered with analgesics. Intrahemorrhoidal diode laser treatment, if available, is preferred to open hemorrhoidectomy. Laser ablation of fistula tract post-operative study. This is again the study they have performed on the fistula patient. So out of this 50 patient, 10 were having intersphincteric, 34 low transphincteric, and 6 had high transphincteric fistula. So they use 15-watt laser probe emitting at wavelength 1470 nanometer. We are using the same 1470 nanometer diode laser, producing 100 to 120 joules per centimeter of energy was applied. Laser ablation, the after laser ablation of these fistulas, their patient returned to daily activities within 7 days. The median follow-up period was 12 months. The success rate was 82%. It is quite higher rate, 82% successful rate. And patient for whom the laser treatment was unsuccessful, were later treated using traditional surgical methods. Laser ablation of fistula tract is safe, effective, sphincter-preserving therapy that can be successfully performed by surgeons. So, friends, we'll come to the end note. The chronic conditions like anal fissures and hemorrhoids are difficult to treat. Recent technology advantages have made the treatment of these conditions easier. New techniques can be used as a dual procedure when patients are suffering from combination of rectal problems. Now again we will come to our heading whether it is game changer or not. Yes, it is a game changer in anorectal benign diseases, but not an answer for each and everything. There are limitations to the laser also. We cannot use laser for each and everything. And this is my last point. I will just show you few laser machines. But before going to that, I would like to tell all the doctors there are so many misconceptions patient are having. They are asking for laser for everything. Means patient is coming with the hydrocele and he is saying I want to get it done with the laser. Patient is coming with the hernia, they are asking for laser. Patient with gallbladder, they are asking for laser. So it is misnomer. They want, maybe they want some recent method for his treatment. If patient is seeking for laparoscopy, he may say laser. Each and every condition they are asking for laser. So laser is having its limitation, and in those limitations also, even in hemorrhoids, in piles, in fissure, in fistula, in pilonidal sinus, in varicose veins, wherever we are using diode laser, in those conditions also we are having limitations, and laser is not an answer for each and everything. But wherever we are using laser, if we are using precisely with all the preoperative workup, appropriate preoperative workup, then definitely it is having fantastic results. So I will just show you newer laser equipment. There are so many CO2 and diode lasers in the market. 980 nanometer. This is Illinois CO2 30 watt 980 nanometer. So different manufacturers. I'm not going into that. Thank you so much, friends, for listening. This something boring topic for general population, and I would like to thanks IMA Nasik for giving me a chance to speak on this topic during Refreshercon 2021. I would like to uh, thanks all the organizers, including our beloved friend Pritam Aira. He is taking so much efforts, and every team of organizing committee, everybody is taking their efforts and making this conference successful, giving chance to each and every speaker. Thank you so much, friends.
Thank you, Sachin. Thank you for such a nice and short lecture. We are moving next with lecture by Dr. Vijay Haribhakti sir. Sir is going to speak on the first ever one-stop breast clinic in Mumbai. Dr. Haribhakti sir is a director of oncology and consultant surgical oncologist and microvascular and reconstructive surgeon with a 30-year of experience. Sir has done MBBS at GS Medical College, a fellowship from KM Hospital. Sir has also is being trained in New York, Belgium, London, and sir is being innovative since his residency, and hence he designed an instrument system for endoscopic assessment of the larynx, which was developed by the Car Stores company, and even he designed numerous appliances for head and neck cancer patients with various of needs. And Dr. Haribhakti sir has a passion for restoring quality of life to one and all, led him to set up a quality of life foundation, which is currently active. Over to you, sir. Sir.
Yes, can you hear me? Am I heard?
Yes, sir.
One
Yes,
moment. Sir. I'm just putting on my share screen. Wait a minute. So I have files. This is basic. One sec. One moment. I don't know why I'm not able to get my file onto this. Wait a minute. Oh, one sec. Hmm, one moment. I'll just check with my person. Yeah, I don't know what's happening.
आता परत 2 हॉस्पिटल येत आहे पुन्हा आपल्याकडे
I think sir has some difficulty in loading the PPTs. We have two lectures remaining, which will be interesting. We will have a talk on cybercrime and financial literacy, which will be decoded by our doctor member from Nasik. So 40 minutes more after Dr. Haribhakti sir's lecture.
One moment. With the Mac, I often have these problems, but
Can I help you with something, Dr. Vijay?
no, because my file. I've actually opened my file, but I'm not able to see it on my desktop, and I don't know what to do. So
Could you minimize this? I think I know what you want to do.
yeah, because I just cannot. Yeah. So wait a minute.
What is the file called? First OS Clinic.
Yes. Yes.
Can you see that it's written there?
Yeah.
Yeah, just double click on that.
Yeah.
Just double click on that.
Yeah, that's right. So I hope, okay, fine. I hope this one, because I'd kept another one on the desktop just for this, but let's see if it works. Are you able to see it now? Yeah.
Yes,
Are you
yes,
able
sir.
to, are you able to see it properly?
Yes, sir. Yes, sir. Thank you.
Okay, yeah. I think there was some issue with, it just wasn't opening. So anyway, so if I'm heard, I think I can go, and I hope all the slides come on properly. So firstly, let me thank you all for this invitation. I was really impressed when I saw some 700 plus participants still here, braving hunger and braving all that. So I think it's amazing. I think your ability to focus is amazing, because I saw tidbits of a lecture on financial planning, at which I'm extremely poor. Then I saw an absolutely mind-blowing lecture by my colleague and and my very respected junior, I should say, Raj Nagarkar, who gave a phenomenal lecture, and then something on the anal canal. I didn't even know there was so much to be said about it. But anyway, I'm here to share something very focused, and something that we just about started. You know, as Raj said in his lecture, whether you are in a 20 crore infrastructure or a 200 crore infrastructure or a 1,500 crore infrastructure, the most important thing is patient experience and what finally happens to the patient. And therefore, this is, I think, a somewhat overdue initiative that we just started recently on World Cancer Day.
On behalf of Sir H.N. Reliance Foundation Hospital, I'm deeply humbled to share that we are playing our part. On World Cancer Day 2021, we are proud to set that bar even higher. As an Indian, and especially as a woman, it is my greatest honor to announce the launch of a one-stop breast clinic.
So this was Mrs. Neeta Ambani, our chairperson, and we really have the good fortune of all the support that we can really garner from our administration for this initiative. And therefore, let me start with our mission. It's very simple. Mission is for any woman with any issues related to the breasts. We wanted to create a go-to place which is designed to provide the best solutions modern medicine can offer in a context of excellence, empathy, and efficiency. The major focus is to provide a clear diagnosis and a holistic management plan within 2 hours. And I think that is the biggest challenge. All too often, we find patients going from pillar to post, waiting for appointments, and still not able to get a clear diagnosis, sometimes for weeks. And this is something we wanted to end. And this is a new beginning, I think, for women in general in our city and in our community. Now, where does this need arise? What is the need for a one-stop breast clinic? I think we all acknowledge that the 3 main pillars of assessment for a patient are as follows. First, a detailed and complete history and clinical examination and assessment by the oncologist. Then there is mandatory imaging, be it mammography, ultrasound, and in some cases, MRI. And finally, biopsy. So the challenge was, is there a way we can get all this done in a seamless way such that the patient gets an answer in 2 hours? And that is what created the one-stop breast clinic. So the relevance is self-evident. We know that breast cancer is the top women's cancer worldwide. It is now also the top women's cancer in our country and the top women's cancer in our city, Mumbai. And I'm sure that's true for Nasik and for any of the major metros in our country. The overall prevalence being over 2 million cases internationally. And this is Globocan data. Very, very astounding figures for the kind of prevalence that we are seeing for this one disease. And what are the current realities? Let's take a real humble look. And I think the truth is we have a lot of late diagnosis. Now, why is this unfortunate? In India, breast cancer gets diagnosed typically in younger women, almost a decade younger than their Western counterparts. This is a known fact which, for some reason, we have not been able to change. On the average, these cancers also get detected in more advanced stages. And thus, we have a very unfortunate combination of seeing more advanced cancers in younger women in the prime of their lives. And this is something that we need to reverse. And I'm sure, even in other centers, I'm sure somebody like Raj Nagarkar at the HCG Manavta Center can do this. We should all get together and do this and make a difference to the women in our country. What are the other current realities? And this is something I see almost in every clinic repeating dozens of times, hundreds of times, thousands of times, and I just don't know what we can do to prevent it except create awareness about it. So inappropriate biopsies, not only do women present late in our country, but also most frequently to non-specialist breast centers, to perhaps general surgeons, to perhaps gynecologists, all of whom with best intentions do their best. But to this date, we are still seeing incision biopsies, excision biopsies, and fine needle biopsies. Let me tell you, in all humility, these are all completely historical. Today, the clear consensus internationally is the core biopsy. So we have core biopsy as a standard. However, we regularly see so many women coming with large hematomas that the entire breast is blue and black, and yet with inconclusive biopsies owing to inappropriate technique and inappropriate ultrasound guidance. And this is something all of us see, and let us accept this is something we have to change. And what is the next thing which we see? And this is again, I mean, I keep referring to Raj's lecture because he ended his lecture saying, "Together we go." And so true. I think he was so right in setting up a team, because I believe, I mean, my career must be maybe about 10 to 15 years longer than his, but I completely believe that we need multidisciplinary care. And then when it concerns breast cancer, multidisciplinary care, which is considered mandatory in all advanced centers in the Western world, it is woefully inadequate in our country. Majority of the patients approach surgeons and get surgery first, regardless. Consequently, what do we see? A disproportionate number of mastectomies, practically no breast reconstruction. We often hear people saying, our women don't want breast reconstruction. I think that is a lot of nonsense. How can our women accept being mutilated? I think it is a myth. We need to change it. Practically no oncoplastic surgery. Today, I have to say in all humility that without oncoplastic surgery, I would consider it inappropriate to handle breast cancer. It is so very important in the armamentarium of a surgeon today. And what's worse, you have infrequent and poorly executed breast conservation surgery. So what happens, unfortunately, is that there is a lot of needless mutilation. And this is again something we need to somehow address and we need to change. So what are the implications of the current health scene? Breast cancer gets diagnosed late. Advanced cancers predominate. The burden of metastatic cancer consequently is high, making the costs of treatment extremely high. The moment you have metastasis, you have to use the most sophisticated avenues for treatment available, and the cost rides up. The socioeconomic implications of this are disastrous. And despite all of that, you have overall poor outcomes in terms of survival and quality of life. Again, this is something we need to consider it our bounden duty to reverse. Now, how is this one-stop breast clinic planned? Very simple, actually. We've just set up a nice space, which, again, I'm moving back to Raj's lecture. He showed that bunker, which was so beautiful. So this room is actually a very comfortingly designed room. And You have all the means for assessing a patient, but there is space, there is comfortable space for seating for the patient and for the relatives, and there is a TV there to educate patients. And so it's actually a nice examination room, which is really set up for good examination and good patient and family education, to put it really simply. And this clinic then reaches out to the other parts of the hospital where they are escorted seamlessly. So the patient is first seen by a surgeon, then the most essential imaging, that is mammography and ultrasound, is included in the basic package for those who haven't had it outside. Biopsy, whenever needed, is performed. We even have a facility to do an immediate INR to confirm safety of biopsy. And we do a core biopsy. We send 2 cores for frozen section so that in less than 2 hours, we have a final consult which takes into account the imaging findings, the biopsy findings when needed, and a combined opinion. All of us sit together, the medical oncologists, the radiation oncologists, the surgeons. So whoever is needed is brought in order to give a composite combined opinion. So that's the departments participating. In oncology, it's surgical, medical, as well as radiation. The departments of radiology, pathology, rehab. We have the finest rehab service in the country. Whether it's physical or psychological, we consider it crucial. We have nursing support, and we have a whole patient experience team which looks into how the patient is feeling right through the process. So how it works is as follows. The patient comes and gets registered at the one-stop clinic. The detailed clinical assessment happens. The patient is then escorted to the imaging area. The biopsy is performed whenever indicated and asked for by the clinician. All the reports are immediately conveyed to the clinician. And the patient, by the time the patient returns for a second consult, all the findings are known, and the patient is presented a complete plan of action in 2 hours. What does this achieve for a patient? A lot. A clear diagnosis based on the 3 essential pillars of assessment, i.e. clinical assessment, imaging, and biopsy, all within 2 hours. This cuts out days and often weeks of delay, anxiety, confusion, cost, and multiple appointments, not to speak of variable standards of care and unreliable solo opinions. And what it achieves really is a prompt diagnosis, state-of-the-art care, and total rehabilitation, which translate to improved survival and quality of life. So what are the next steps after this? The one-stop clinic provides a seamless pathway to the finest care anywhere at our institution. When it's surgery, it's every type of surgery, which includes all varieties of breast reconstruction, whether it be implant-based or microvascular flap-based, or regional flap-based. So all and every variety of surgery is offered. In radiotherapy, we have the most efficient and the least toxic protocols with predictably good outcomes. I would like to mention, for specificity over here, ours is one of the only centers which practices surface-guided radiotherapy, and where we have deep inspiratory breath hold radiotherapy to prevent radiation to the coronaries for radiation for left-sided breast cancers. And now the latest thing is we have started the fast forward protocol, which completes the entire treatment with an integrated boost in 5 working days. So that's radiotherapy. Come to systemic therapy, and we have the best available chemotherapy, hormone therapy, and targeted therapy, all given with a consensus based on a detailed tumor board discussion. And rehabilitation. We have complete physical and psychological rehabilitation from the finest rehab center in the country. So let's summarize the gains for women. We have optimal advice for prevention. We have the best strategy for early diagnosis. We have multidisciplinary treatment planning. We have state-of-the-art treatment. We have supported every step. We've improved survival. We have enhanced quality of life. And that brings me to my very last slide, is why do all this? Because all of us should aim not for a patient who keeps coming as a patient, but for a patient who turns into a survivor. So a time comes, therefore, when a patient really stops being a patient, when she re-enters her life with confidence and courage, when she needs reassurance rather than any active treatment, and when she can contribute to the journey of other women. That is survivorship, which is our ultimate goal. I thank you. I did not want to take much of your time, so I wanted to keep it short, but I think it is important. It is very important that you should get that this is an important initiative, and I'm hoping and praying that more and more women get aware of this and use it to their advantage so that they have improved quality of life and improved survival. Thank you very much for your attention.
Thank you, sir. Thank you for your lucid presentation, and thank you for patient waiting.
Yeah.
Thank you, sir.
Yeah. Okay. Thank you. Yeah.
Moving to our next topic. I invite Dr. Omkar Gande. He's a cyber security expert, digital consultant, founder and director, BeThrive Digital Private Limited, Pune, CEO on Web Technologies, and is a president of Cyber Sakshar. He has completed his master's in computer science. He's a certified ethical hacker. He has more than 80 worldwide certifications in the field of cyber security and information technology. And is pursuing PhD in cyber digital transformation from MIT University. He has assisted Maharashtra Police in various cases and awareness regarding cyber crimes and spreading cyber awareness all over Maharashtra with more than 1,000 programs conducted till date. So I invite Dr. Omkar Gande. Over to you, sir.
Thank you so much all for first of all inviting me for this. And I'm not wasting much time in introducing myself. So I'm directly starting. I hope you can see my screen. So I mostly I am featured in various newspapers and various news channels, various radio channels, and I assist Maharashtra Police and Maharashtra Cyber Crime Department from last 5 to 6 years. So without wasting any time, get back to the lecture. So exactly what is cyber security? I know our topic is cyber crime, but from basic point of view, I just want to ask you, all common people and all techno-savvy people know that for the cyber security, but exact definition is something different. Because many people think that cyber security is only type of security requires online, but it's not the case. You will need the cyber security online, even offline also, because if you are not online currently, then also hackers or criminals can attack your mobile phones or any of your devices or bank account or anything. So all these things are required. Okay, voice is cracking. Okay. So I am audible now.
Yes, sir, you're audible, but your voice is cracking a lot. If you're using headphones, I suggest that you remove them. Mr. Omkar,
Yeah.
are you using headphones?
Yeah, I am using, but
I suggest you remove the headphones.
hello. Now you can hear properly.
No, I cannot because of the quality is not very well.
Hello. Now you can hear.
That is not going to help, sir.
Okay.
Hello.
Yeah,
Now
this
you
is
can
much
hear.
better. Much better.
Okay.
Yeah, please carry on.
Okay. So exactly, cybersecurity is regarding online and offline both. So after cybersecurity, the next term in our mind is hacker. So what is exactly hacker? Many people think that hacker is a criminal or hacker is a thief, or many movies uh, show that hacker is a criminal or something else. But there are three types of hackers. The first and the most dangerous type of hacker is black hat hacker. Black hat hacker is the criminal, or we can say the cyber criminal type of hacker. He can attack various banks or companies or any. They can do financial frauds. So mostly they are only for making money and making fame. So another type of hacker is white hat hacker. These are good hackers, or these mostly help government or police department or various government agencies to help in cybercrime analysis or cybercrime investigations. So these are good type of hackers. Then third and most dangerous type of hacker is gray hat hacker. Gray hat hacker is a combination of black and white. Means for daytime or for some time they are good hackers, that is white hat, and for sometimes they attack the same system they are protecting. So they become more dangerous and gray hat hackers. And one more thing to add, they can't be tracked because they are the investigation officers for the same crime they are committing. So from simple things to complex, the first and the most important part is password. Everybody know what is password. Password is just a kind of word or a sentence or something like a voice or anything which is used to pass something means pass the login, pass the door, pass the security, everything. So there are lots of common passwords that are used by various common peoples, but they don't know these are risky. Every year, almost all security agencies list out various common passwords. You can search for list of common passwords in 2020, list of common passwords in 2019, or even list of common passwords in January 2021. So these are some common passwords which are 1234566. Verity password itself is used as password. 1234 up to 9, 12 up to 0. These are very common passwords used nowadays for various sites. But some of the sites like banking sites, social media sites don't allow users to use these passwords. They allow users to use combination passwords. Combination means it has words, alphabets, some special characters like @hash, comma, dot, something. So for common passwords, these are some of the common passwords which are combination. Means, for example, you can see on screen ABC at 123456. ABC is your name. For example, someone's name is Ram, then RAM, R capital, @12345 is most commonly used password. Name @12345 or 12345 @name and first letter is capital. Or even for more security, people use name @mobile number, first letter is capital. So these are the worst common type of passwords which are in combination. People use them for Facebook, Twitter, Yahoo, or something, YouTube, or even for banking sites also. Another one big mistake is using same password for all the websites. Mostly people use same password for Facebook, same password for Gmail, same password for various OTT platforms like Amazon Prime, or Hotstar or something. Or even they are using the same password for some net banking sites or some online booking sites also. So never use same password for all the websites. So some people use password with website name. For example, ABC @12345 Facebook, ABC @12345 Twitter, ABC @12345 Book My Show. So never use this type of password also. Never use same password, or never use your name in your password. Never use your mobile number, your date of birth, your car number, bike number, license number, Aadhaar card number as a password. Many people use this type of passwords. So what are the cyber crimes? There are lots of cyber crimes all over the India. Every day the ratio is increasing. Registered cyber crimes every day is one cyber crime for every minute in India. It is registered cyber crime, means people registered proper written and online FIR for this. Actual this count is for registered cyber crimes only. Actual count for cyber crimes is one cyber crime for every second in India. So how exactly the cyber crimes are investigated? Almost 90% people feel that cybercrime investigation is very hard, or it's very tough, or it's time consuming, and it needs some technical knowledge. It's quite possible to investigate with some sort of computer knowledge also. Some cases are hard to crack, and some cases are really easy to crack. For example, we take example that if your Facebook account is hacked by someone and you registered a written and legal FIR for this, then what is the procedure cyber experts do, and what is the procedure for police to do? Firstly, uh, police will take you, or cyber experts will take your profile link or profile passwords, or the your email you are using, and then police will contact to the website or the social media operator, that is Facebook or Twitter or Gmail or something, and they will ask the social media operator for IP address, date, and time of all the duration for the month, or for 2 months, or for 6 months. What is IP address? Almost everybody knows about IP address. That is Internet Protocol Address. Every electronic device which is connected to internet has its own IP address, just like our physical address. So every IP address is unique for unique time and unique date for unique user. So social media operator like Facebook or Twitter or Instagram or Gmail gives IP address and date time for the account which is uh, compromised or hacked. So the IP address is just a number, just 6 to 7 or 8, 9, 10 numbers. So with IP address, we can trace which service provider or which internet service provider is using this IP address, means Airtel, Idea, BSNL, or any private or local internet service. So after contacting Airtel, Idea, or the internet service provider, we get exact details of the SIM card which is using the IP address on that day and on that time. So with that SIM card address, police can arrest the criminal easily. But whole this process takes almost 8 to 9 months to to investigate, because all the procedure take time up to 2 to 3 days. Only the process taking time more is collecting data from Facebook or any foreign social media company. So if we are talking about cyber laws in India, so I just want to add something that never my lecture is never one to one, or I want always replies from your side. So you can ask me any question or doubt after lecture or in between the lecture also. So cyber laws in India, there are lots of big and normal cyber laws in India, which people know, that creating Facebook account, creating Facebook fake account, hacking something, or attacking on banks, attacking on people for money frauds, and all these things are cyber frauds are under cyber laws, and people or the criminal can get large amount of fine, or he will be in jail for 5 to 6 or 7 years. But there are some laws we don't know that they exist in India. One of the law is cyberbullying. You can't bully anybody on digital platform. You can't insult anybody on digital platform, just like in Zoom meetings, or on social media platforms, or in comments, or direct messages, or on WhatsApp. So it is a crime, but of course it is bailable, but it's a crime. Cyber stalking, stalk someone on internet platforms, stalk someone on social media platforms like Facebook, Instagram, just watch their stories, watch their actions, what they're doing, how they're enjoying life, or downloading their photos, and just stalking them all the time. It is also crime, but it is also a bailable crime. Then cyber trolling. Cyber trolling is everybody know, most people troll politicians, relatives, then celebrities relatives. So trolling is a crime, and cyber trolling is also a crime, because in cyber trolling people forget their limits, what they're saying in comments, what they're making in videos. They use various bad words for the celebrities, so it is also crime, but it is also bailable. Most of the celebrities ignore this kind of trollers, but it is a crime. Then same trolling happens in games also. Just the PUBG mobile is banned. When PUBG was in active in India, many people used to troll in game also, but it is also a cyber crime. And the most dangerous crimes is child pornography. In regarding cyber child pornography, means you're creating such videos or images, manipulating them, transporting them or transferring them, downloading them, keeping them in your mobile, or sharing them on various platforms is also a crime. And remember, this is not bailable. So if you are caught in this, then okay. So other than this, some crimes are uh, very dangerous than this. So for these crimes, you must have a cyber awareness. Many people used to say, हमें कोई जरूरत नहीं है साइबर अवेयरनेस की, हमें सब कुछ पता है. लेकिन ऐसा नहीं होता. हमें हर एक चीज के बारे में जानकारी होनी ही चाहिए. For example, if you are using your mobile phone, I repeat, if you are using your mobile phone, then it's fine. But if you are using your friend's mobile phone without his or her permission, then it is a cyber crime, and 99% of civilians don't know about this. I repeat, if you are using your friend's mobile phone without his or her permission, then it is a cyber crime, and a serious cyber crime, because by laws or by various IT acts, it is first crime. if you are using someone's electronic device like laptop, pen drive, modem, or even smart watches without permission, then also it is a kind of cybercrime. And if, of course, we are living in India, so in bracket, if complaint, then only it is a cybercrime. Otherwise, it is not. So, if you are using any electronic device of your friend or family person without his or her permission, then it is cybercrime. I repeat, if you are using, if you are using and watching the data in that, if you are using the electronic device, or if you are using his or her laptop, watching his or her private data, then it is also a cyber crime. If you are using electronic device like mobile phone and laptop or something else, and watching and editing data or deleting his or her data, then it is a severe cyber crime, and you will be in jail if he or she complains. Also, if you are using any kind of electronic device in your company as provided by your employer, if you are employee and various PCs, computers, laptops, or electronic devices are provided by company or employer, if you are using without company consent uh, all these electronic devices for your personal use, then it is also a cybercrime and company can file complaint against you. So never use your company's public properties or corporate properties for your personal use. Company can file complaint against you, and it is very serious kind of complaint. So I just want to add something. I think you must have heard in various news, or even you have watched my videos on YouTube also, that Zoom is not safe, and we are conducting this conference, a very good conference, or Zoom also. But I want to repeat you something, that Zoom is still not safe to use if you are sharing something. If you are sharing something about your financial discussions, or your some company sensitive information on Zoom, then don't use Zoom for such meetings. You can use Google Meet or WhatsApp call. Just like someone has just dropped a Dr. Ramesh Panchal has just dropped his Gmail means email address and mobile number. So never drop your mobile numbers or your email addresses anywhere, because I think your this number or this email is linked with your SBI or your any kind of bank account. If this number or this email is linked with any bank account, then never drop such Gmail anywhere, because it will harm your digital privacy. With only a email address or with only a mobile number, your bank account can be easily hacked. This lecture is not practical session and we have very limited time, but if I will request IMA to conduct a physical workshop on this, so that I can physically show you these things, that how email address or a mobile number can be dangerous for yourself also. So dear sir, I wanted to know that some data. Okay. Negative feedbacks, it is not cybercrime. What action against it? Actually, it is not cybercrime, but you can take action against them if they are defaming. Okay, yes, correct. You can take action against such if they are repeating the same behavior again and again. Okay, so moving to next topic. I think you have seen this kind of buttons on internet, that click here to download, green, red, yellow, black, blue color buttons, and if you click on these links, then nothing happens. Just it redirects to another website, and it again redirects to another website. Your you keep jumping from one website to another website. These kind of buttons are used to insert malware in your system. These kind of buttons used by hackers to insert malware or adware in your system, mobile, mobile or your laptop. So if you click on login with Facebook button, then something like this may appear on your screen as a pop-up that your Facebook session is timeout, and please enter your email address and password again. And we believe that this is a Facebook real timeout screen, and we enter again the email and password and click on login, but nothing happens because this is a fake pop-up, and no such pop-up or no such timeout notice is given by Facebook. I repeat, no such session timeout notice is given by Facebook. So if you have ever seen such pop-up in your laptop or in your mobile, then please reset your password immediately. So these kind of pages are called as phishing pages or phishing websites, means look-alike website of a original website. Color combination, logos, fonts, content, each and everything is same as the original website, and we believe that the current website is the original one, but it's not. We have to clearly notice the URL of the website, that it is correct or not. Many people still don't notice the domain or the URL of the website at www.xyz.com. What is that XYZ? We must have to notice. If you are using HDFC Bank, or if you are using ICICI Bank, or if you are using the State Bank of India, then for example, State Bank of India, SBIonline.com is suppose a official website, but hackers do sbjbank.com, sbjonline.com, sbionline2.com, sbionline.com, anything they can use and fool you with this help of phishing sites. So the another one and the most important topic for doctors, because I am feeling very proud to say that in last 6 to 7 years I have hardly seen 6 to 7 cases or cyber frauds happened with doctors. Other than doctors, many professions are there which are non-computing, but doctors nowadays are very techno savvy. They mostly don't believe in any kind of cyber frauds that someone call them, your credit card is blocked and kindly complete your KYC, or kindly give your OTP, we are talking from bank, and all these things. But nowadays doctors are the only profession, non-computing profession, which are more techno savvy than others. So the only fraud happening with doctors is SIM swap fraud. What is exactly SIM swap fraud is? You can take screenshot of this, or you will get all these recordings on YouTube also. But it is very important kind of fraud. How this happen? Your mobile number. That's why I told earlier that never post your mobile numbers which are linked with your bank accounts. So what happens? Criminal or hacker can attack your mobile number easily with the help of some free softwares that are available on internet. So what they do, they attack on your mobile number by SMS bombing. There are lots of softwares for SMS bombing, which makes your SIM card weaker. With the help of SMS bombing softwares, your SIM card becomes inactive for some time, and you will see the message on your mobile number that no network available, or service not available, or emergency calls only. And mostly this is done on Friday night or Saturday night, because mostly the SIM galleries or SIM companies or internet providers are off on Saturday, Sunday, or mostly on Sunday. So the hacker will contact, once the hacker has completed his attack on your SIM card, then he will contact the Airtel ID or whichever SIM is you're using, and they will ask for duplicate SIM card on your name only. How they can issue a duplicate SIM card on your name? Very, very, very easy, and always remember, never share your Aadhaar card copy. Never share your Aadhaar card copy, PAN card copy, or driving license copy to anyone on internet. Mostly we keep our scanned copies of Aadhaar card, scanned copies of driving license, scanned copies of PAN card on WhatsApp or on email, and we frequently easily share them with anybody. uh, Sharing Xerox copies of Aadhaar card, sharing of scanned copies of Aadhaar card is very risky. So never share. Such data is collected by these attackers, and they use the same Aadhaar card or same data for creating your duplicate SIM card from original mobile company. So they can issue a duplicate SIM card from mobile company. They get SIM card duplicate with only 100 or 150 rupees, and they will swap your SIM card. Then they will issue a notice on your net banking or your bank that forget password or forget pin or forget mpin, and they will get all the OTPs regarding the passwords, and they can easily they can do easily transactions of 1 lakh, 2 lakh, 3 lakhs in these 24 hours, because they get whole Sunday for this. And still your original mobile SIM card is showing no service or emergency calls only. Then all the transactions are completed, all the money is transferred to hacker's account. Then on Monday morning you visit Idea Retail or some mobile gallery, and you will get to know that your mobile is your SIM card is already copied or it is already swapped. So this kind of fraud is very, very, very risky, and currently from lockdown it's very attacking various people. So how to uh, okay, so how to prevent this kind of behaviors from these hackers? So never share your mobile number which is linked to your bank account. Never share your any kind of Xerox copy of your any document like Aadhaar card, driving license, PAN card, Xerox or scanned copy. Many people use scanned copies for various KYCs, and they hand over these scanned copies to their employees or their um, anyone like friends and all. So never share, never share with anyone, so you can avoid these kind of frauds. And if something happens with your account or something happens with your SIM card, then immediately rush to your nearest police station or cyber police station. For Nasik, we have a very uh, trained staff of cybercrime on Gangapur Road, in front of KTHM College, behind the city office. You can rush to the Nashik cybercrime anytime. So next type of fraud is OLX fraud. So this kind of fraud is very risky, and it is happening every day almost in Nashik also. So OLX fraud is done, as you can see on screen. A motorcycle is listed on OLX, and these guys want to sell his motorcycle, and people uh, there are some people or their gang or their racket of fake army officers. They use these kind of canteen cards or these kind of fake Aadhaar cards, which are clearly seen edited on mobile. These kind of army cards, and they easily fraud these kind of people. They can easily, you can see on mobile screen, these all are fraud photographs. They just ask you to share their okay, they just ask you to share your UPI ID, that is something ABCD at the rate HDFC Bank, ABCD at the rate SBI Bank, yeah, or OK Axis or OK SBI, and they will send you a QR code, and they will ask you to scan the QR code and type your PIN so that you will receive the money. And people believe and they lose their money. I think almost of us know that scanning QR code and typing PIN is only required only if we are sending money, not receiving money. So never share QR code or never type PIN to receive money. So it is basic cyber etiquettes or basic cyber awareness. So I think we have very less time, and I need to skip many topics, but it is a very my last topic is spy app. I can show you a demo online for this. But what is spy app? You can spy anybody from any location to any kind of action doing on mobile. For example, if you have installed spy app on your wife's phone or husband's phone or girlfriend's phone, boyfriend's phone, or anybody else, so you can monitor his or her each and every activity, like his location, his contacts, his audio recording, voice recordings, then camera. You can on his or her camera, front camera, back camera, anytime. All his or her WhatsApp messages, all it's a normal SMS, Facebook, each and everything you can monitor remotely online. So if your mobile is having spy app, then you can't identify the spy app, because as you can see on screen, Android system lock, Google services, or smartphone or SIM toolkit, these kind of spy apps are seen on your downloads or your app store or your app application manager. So if you notice that you can't even uninstall the spy app also, so firstly you can't identify the spy app that is exists on your mobile, and even you cannot uninstall the spy app because it requires the password which is added by the attacker or the one who has installed spy app on your mobile. So using spy app is officially legal for only two people. One for the parents, those who are having kids or children less than 18 years, and for the employer, those are giving mobiles from company to their employees. They can install spy app on their mobiles, so they can track activity of their children or spy on the activity of employees. All other people can't use spy app because it's illegal, but you can find easily that your mobile is having smartphone, sorry, spy app. Okay, then last topic is dark web. First, I'm just introducing dark web. I think you have already heard about dark web, that dark web is underworld of internet. Dark web is famous, or we can say infamous, for two kind of things. One, drugs and guns. Just like our Amazon, Flipkart, and all these e-commerce websites, dark web has their own websites for selling drugs online, selling guns and RDX online. And secondly, human trafficking. Mostly human means living human is sold on dark web with the help of e-commerce websites, just like our normal Amazon, Flipkart. So dark web using is not legal or not even illegal also in India. So people always in confusion that whether to use or not, but I will suggest never use dark web in your life, because dark web is very, very, very dangerous for everyone, and it's we can't track anybody on dark web because it's very impossible task. Okay, so I'm at the end of my seminar. So Cyber Saksha is my company, and uh, in all Maharashtra I mostly conduct cyber security awareness programs and workshops for various kind of students, colleges, schools, clubs, hospitals, for advocates, police officers, doctors, and other professionals also. So I am sharing my social media and my mobile numbers, which are not linked with any bank account with you. So you can contact me anytime on these numbers, or you can find me on Facebook, Instagram, Twitter, LinkedIn, or even on Google, or even on YouTube. So that if you have any query or any kind of doubt regarding cybercrime or cyber security, then you can call me or WhatsApp me. So thank you so much, IMA and Dr. Prajakta LLM, for inviting me for this wonderful seminar and wonderful conference. So if anybody has any doubts, they can post on chat.
Thank you, sir. Thank you for making us cyber literate, what I can say. And we definitely would like to be associated with you for further such programs, which will help us in becoming more aware about these sort of cyber crimes, which are increasing day by day. Thank you, sir. Thank you. So moving on to our final talk of the day, I invite Dr. Praveen Gadsing. He is MCH pediatric surgeon and he secured gold medalist in it. He is also PG diploma holder in hospital and healthcare management, PG diploma in medical legal services. He has performed more than 15,000 complex surgeries till date. Complex intersex surgeries conducted for more than 150 patients. He is also one of our doctorpreneur. He has written a book on financial literacy decoded. Its editing is in progress. He has set up health resort with novel concept of holistic healing. He's also advisor to several hospitals on efficient and cost-effective hospital management. So let's hear from him about financial literacy. Over to you, Dr. Praveen.
Hello, good afternoon, everybody. Myself, Dr. Praveen Gadsing from Nasik, pediatric surgeon. Today, we have been exhausted with all the technical as well as lectures regarding entrepreneurship. So I will be just taking ahead with my talk regarding financial literacy. Actually, every doctor has a dream of setting up a successful private practice, owning his own hospital and infrastructure, getting fame, recognition, wealth, and prosperity. In previous chapter, we have seen, but what's the reality? The reality are we are stuck up with a very hard work, laborious work, working for 15 hours, 14 hours, 10 hours, 8 hours. As per labor law, also we should work only for 48 hours a week, but we are working double than that. Secondly, the reality is we are exploited from many corporates, patients, from the laws. There's no time for yourself, no time for family, no holidays, no festival. We can achieve financial stability. Listen this word. We can achieve financial stability, but not financial freedom. 95% case of doctor is they are financially stable, not free. And again, they are having multiple financial issues, health issues. So just thinking of why this reality is because our mental status or our thinking is slightly different. And what is that thinking which differentiate between a common person and an entrepreneur is? First thing is source of income. A doctor always and always 95%, this is an average 95%, I would say, thinks on active source of income, never on passive source of income. If you want to increase his practice, or if you want to increase, become big, richer, what he does is he start doing overtime rather than leverages, which is not the thing with businessmen. They think of leverage. The doctor will increase his OPD hours. He will start working on Sundays. He will start working late night. He will start one more hospital, one more OPD. He will increase his workload, but never think on leverage. The third thing is replication. This is not seen with most of the doctors because their business is individual dependent. And mind it, an individual dependent business is not a replicable mode of business. It's only the system dependent business which is replicable. And scalability, again, as a work pattern I've told you, our scalability is in terms of addition, not multiplication. If suppose I am doing 2 surgeries, to increase my payment, I will go to 3 surgeries, 4 surgeries, but I will not think of multiplication of this. So this is the reality, that we think on different working pattern, different income sources, different replicability pattern, and different method of additions. Now, why this reality is really happening? So first thing is, see on left side you could see only a light kite will fly high. Only ventures with low liabilities and low wealth will make progress. So here I am going to see is misuse of resources. My model of that will be coming later on. Do a business with minimum optimal resources. Don't do extravagant money. Don't use extravagant space. Your staff should be utilized, not underutilized. Have you seen any of the small hospitals giving target to the staff? No, because we don't have that concept or idea. Second is denial of acceptance. We are not ready to accept that to start a business, our technical knowledge is not the sufficient knowledge. We have to gain a financial knowledge or a commercial knowledge. Secondly, mental attitude. We think that I am a doctor, I should focus only on treating patient. If that is the focus, then why are you building the hospitals? So first change the attitude that I am becoming starting a hospital, so I should know each and everything about how to start a hospital, how to run a hospital, how to replicate it. Our educational background is also one of the most common cause, because in school it is always taught get high grades, do competition, come first, you should be ahead of all, and here the competition starts and our team approach becomes less, and we are only becoming technically skilled laborers, no team attitude at all. Then thought process about money and fortune. It is very commonly seen ki mala bas maji hi एवढीच practice पाहिजे. After few years, when the practice starts slowing down, people actually try to fool ourselves by saying that I myself had made the practice slow. But actual reality is that most of us also know, don't say it to anyone, but realize yourself that our practices are getting decreased. Then being busy. Most of the doctors, अरे आज काय वेळच मिळाला नाही, मी सीए कडे जाऊ शकलो नाही, I could not think of different things because I was busy. Were we really busy? Swami Vivekananda has very well said, जो आदमी कहता है कि मैं व्यस्त हूं, वो एक्चुअली में व्यस्त नहीं है, तो वो अस्त व्यस्त है. He is not planned, he is not busy, he is not planned basically. And lack of financial knowledge, definitely, and indecisiveness. So here we could see all these points. So if we start on changing this, we can really go ahead and achieve our dreams. So now, once we know what we are, what is the cause behind us, then only we can go ahead and get this knowledge. Now we know the causes. Now we'll go why this is happening and what is the real solution for it. And remember, guys, the solution for this change in reality is only and only by gaining financial literacy and understanding what is techno-commercial aspects of business. Now we will understand it. So what is financial IQ? Financial IQ in my terms regarding a doctor profession is considered is nothing but techno-commercial knowledge, acquiring techno-commercial knowledge. See, we all, for the business, two knowledges are required. One is technical knowledge and other is commercial knowledge. Almost all of us has technical knowledge, but most of us are lacking commercial knowledge. Once I utter the word commercial knowledge, the critic starts raising their eyebrows. They start saying all these blah blah questions. This guy is doing commercialization of profession. He's just a money minting attitude. His quality of services will be hampered. His customers will be suffering. The commercial attitude to profession is unethical. He is a money-minded person, and all these things. But guys, these things are spoken by them because they don't know exact meaning of commercial aspects. So we will really understand what are the commercial aspects of business. In commercial aspects, it's gaining financial literacy. After gaining that financial literacy, applying that financial knowledge in your business management, preparing short-term, mid-term, and long-term business plans, knowing which business entity suits you and which will be a long-term business entity, building a hospital or an organization that is a system dependent, not people dependent. We have seen many n number of hospitals which has gone from water high to crash once the doctor was not there, because all the hospitals, most of the hospitals built were on doctor dependent hospitals. Then understanding the financial journey of life, learning new trends of investment, understanding taxations. I'll be briefing this in very short things because of time limit. So now here, a tabulated form I have just seen, a technical smart people. All of us, 100% of doctors are technical smart. Technical smart means T. They are technical skills. They have logical thinkers. They also a thinker. They are analytical thinker, critical thinkers. But the second part, that is techno-commercial, only 5% of us achieve this knowledge. C, that is creative thinker. And P thinker means they know the people skills, how to communicate with the people, how to get the work done from the people, how to arrange the people. These two are the most important thing to grow a business. Then our business will grow. They say that he was topper in the class, but his business practice is not getting on because he was focusing on this technical part, not on the commercial part. So this technical-commercial aspects has 8 pillars. One is financial literacy, then financial management, business planning, all this thing. Now we'll go step by step to each of them. Now the financial literacy is required. First thing, as I told you, most of the doctors are financially stable. First, become financially stable. Then this is also required to overcome the financial crisis. Once this financial stability and crisis is gone, the real thing comes is financial freedom. And that is the achievement. And if you achieve this, then you guys are going to rock. Now we will just understand, as we know, as our life goes, there is childhood, then there is adulthood, then old age. Similarly, a financial journey of a person goes on. First is a beginning, then there is a financial stability phase, then there is a financial security phase, then financial freedom and financial abundance. Guys, the last 3 stages, rather the last 2 stages, stage 5 and stage 6, if you will see this, these stages are achieved only by a person who is having a passive source of income, while the first 4 things are achieved by a person having an active source of income. This is a chart. It is a very descriptive chart. In the first 4 stages, first 3 stages rather, most of the income is active income, and all the doctors fall in this category. Maybe a doctor earning a lakh rupees a day, but that lakh rupees is only till the time he is earning. The moment he meets an accident or some sort of anything and he is not able to perform, from that lakh rupees it comes to 0 rupees. So I am telling you, understand the difference between financial stability and financial freedom. And this is happening because he is doing his active work, and this passive work can only bring you financial freedom and financial stability. And the most important thing is what all things we should buy during these stages. During these first 3 stages, most of the newcomers now, after entering in the business, start building big homes, getting big cars, and what happens is they build up the liabilities. And once the liabilities are built up, the person goes under severe mental stress, because he has a loan to prepay. During these first stages, if we focus more on business, then the latter 3 stages can buy any damn thing for you. They can buy you farmhouses, they can buy you luxurious cars, they can buy you luxurious vacations, any damn thing. So in the first few phases, if you focus on your business, growing business, decreasing liability, increasing asset, you are going to achieve this. Now, after understanding the financial journey of life, let's understand different business entities. Many of these people, when starting a business, come there. बिझनेस चालू करायचा आहे, कसा चालू करायचा आहे, पार्टनरशिप करायची नाही, एंटर प्रोप्रायटरशिप करायची, कोणाचं नाव द्यायचं, काय द्यायचं, कंपनी. मग ते कोणाला तर विचारतात. दे आस्क देअर फ्रेंड्स, फॅमिलीज. दे से दॅट की अरे या ते कंपनीमध्ये कॉम्प्लायन्सेस जास्त असतात, काय माहिती नाही, चला पार्टनरशिप चालू करू, लेटर ऑन विल सी इट. It doesn't make much difference. Then the CA to decrease his works. I am not pointing anyone, but just decrease to work. They will say that ki partnership la jawa, hela jawa, tela jawa. But what is our goal? What is our aim? If we want a business which has a high replicability and high scalability, then only you are going to earn passive income, and then we are going to go rich. At that moment, we should go for something which has tax benefits. आपण आताचं बजेट ऐकलं, बजेटमध्ये ऐकलं की मोदी सरकारने बजेटमध्ये फक्त आणि फक्त श्रीमंत लोकांसाठी हे केलं. ही हॅड नॉट गिव्हन बेनिफिट्स टू द people, श्रीमंत लोक. He had given benefits to companies, and he has given benefits to some of the company laws. So while starting business, we go for partnership or sole proprietorship because the setup cost is low, the maintenance is low. So we go for this. But if you see, guys, the scalability, the tax efficiency, and the replication and replaceable part, if you see, it is best with a corporation or a private limited company. So before starting any business, remember this chart and go as much as possible with a company. Again, I am telling you, if you want to be a replicable, you should always own a system-oriented business. There are many doctors which we have seen, guys. They were the topmost doctors. Means I have a great respect for Dr. Mandke sir, but I could see him just because he was very much a dependent person, sir, self-made man. But what were the systems? So it's not here. But what I want to say is that we should not be an operator-dependent person. We should be a system-dependent business. Because system-dependent business is replaceable, replicable, accountable, expansion is easy, and operated on SOPs. So what are the 4 pillars of system? The 4 pillars of system are: first is financial management, then customers. Customers are not only your patients, but customers could be the person who is sending you the patient. The partners who are attached to you, they are also your customers. The shareholders which are attached to you, they are also your customers. The learning, growth, and analysis, and your internal processes. These 4 things. So how the business goes? So the business, now see, you will see it. First is setting up a business. And while setting up a business, first thing you need is money, and you need a customers. So here you should focus on marketing and sales. When your business is starting, you should focus on your customer services and your internal process. Then once the business management, it is on financial management and administration. And to expand the business, analysis and replication is needed. So in finances, what all things is required? It's required is your revenue, your income, your expense, your return on investment, your net income. In customer, we only think of customer satisfaction. But really speaking, guys, I just ask you a question. How many of you think of leads and conversion of leads? Hardly 4 to 5 people, 4 to 5% of the people. We don't know the concept of leads. We don't know the concept of leads to conversion. So focus on that. How to generate leads, how to generate that lead generated should be converted to satisfied customers. Then lastly, we just once learning and growth. We don't have a protocol. We don't have induction programs for our staff. And we see that once our staff is gone, the other staff comes, and we are really crippled because that our staff system is not a SOP dependent system. Then internal processes. We don't have all the inventories properly made. Many of the times that machine goods break down, we just keep on asking, अरे कुठून घेतली होती, काय झालं होतं, CMC आहे का, warranty आहे का. Do we really have? No, we don't have. So focus on this inventory, quality control, and most importantly, as I have always told you, leads. You should catch these leads. Now, starting a business, we always say that ki, it is a vision, ka hai, mission, ka hai, and it is a very vague terminology. We really don't know what is vision, what is mission. So this is a just a one pager. One pager, you can really understand what does it really means. What is vision, what is mission. Suppose today I am here, and after 5 years, what I want to do? I want to start a 200-bedded hospital or these things. The time or the point from A to B is called as vision. Why I want to go from A to B? That is my mission. How I will be going from A to B is what is my values. And why I want to go, what I wish to achieve from that are my objectives and plans. So while making a business plan, these things, if you really jot down, you can really make a good business plan. So as I told you, vision, mission, objectives, then your marketing plan, financial product, all these things, I have already spoken to you. One more very important thing is documentation of documents. I really will focus on this because most of the time we are not aware of our income, expenditure, assets, liabilities, all our documents. Why the documentation is necessary? Because this documentation helps us in knowing our financial position, making our financial plans, making our expansion, identifying our assets, and identifying our liabilities. Many of the time we have seen that some husband is gone in some accident and the wife don't know what all loan she has, what all property she has. In fact, sometimes they are in the hospital, get hospitalized, and they don't know whether they have their medical policies or not. So it is a sincere request by me to all that you should have a proper documentation of these documents. And these documents should be known to your family, your near ones, so that they can really know what all things you are. And second important, as I have told you, that it will help us to judge whether it is a liability or asset. Suppose you are buying a property is bought, very simple formula is there. A home is bought, a office is bought, a business is bought. Who is the owner? You alone are your owner, or it is a conjoint property? Then from which builder you have bought it? Whether the sale deed is done or sale agreement is done, how much is the loan, whether it is insured, who is the nominee. And after buying, sometimes what we do is we have money, we buy a property, and later on that property is kept on. So think of whether it is a dead investment, it is liability or asset. If it is an asset, it's very, very good. If it is a dead investment or liability, try to convert it into asset or sell it as quickly as possible, because that liquidity you can use for buying an asset. Send the documentation of your policies. I have seen many of my friends who lost their husband or this, and they were not knowing what all policies they were having, and they are stuck up with money crunch. So our families should know what all life insurances are made, mediclaim, children plans, vehicle insurance, property insurances, all those. Regarding house rental properties also, we should have a tenant name, KYC, the rent agreement, and also by finding out this, you should find out really whether the rental property is a liability or asset, whether it is giving a proper amount you require. The rental yield should be ideally 4%. If it is giving beyond that, then I think you should really think of what we are doing. So knowing to know, documenting this is really important. Then your investments and savings also. This is also very important that you need to document. Then your loan documents. Then your all savings, bank accounts, current accounts. This all you think you should have a documentation, proper documents. And if you are in a hospital, you should have your high valuable, just like your ventilators are there, your dialysis machines, your CT scan machines. Everywhere this is very, very important, because the CMCs are there, the all the parts comes into play, and for this the documentation is really, really very, very must. Just as we have told you, I have told you that there is no like a jaduchi kadi where you can become overnight success. What to become success? You have to first gain knowledge, analyze the market, and then after analyzing it, implement it and apply it, and you will gain success. I analyzed the market, then I started implementing it. And after analyzing, what I thought is, in doctors there was no unity, and in doctor there is lot of common needs which are required, and what we are doing, which we are doing it, getting it done from some big giants companies. They were becoming rich and we were rich. So what I thought is, I found out that common needs. I started gathering together and I started a movement called as cooperative to corporate. It is a movement of the doctors, by the doctors, for the doctors, and I could proudly say that I have joined more than 200 doctors in this movement. And through this movement, we have started 6 units, 2 diagnostic centers, a pharma company, and we have started with Skill India, housekeeping services, and all these things we have started. Then again, I told you, there's something called as problem solving product. We should focus on problem solving product. The need of today's hours. See, now you see the real estate is going down, everything is going down. But in real estate, those builders who are focusing on luxuries now, they are going down. But those persons who are focusing on affordable homes, affordable cars, affordable luxury items, they are booming. They are booming. Similarly, I thought it, if this is the thing, then why not we go for affordable hospitals? There are 3 categories of patient. One are poor categories, one are very rich patients, and one is the middle class patient. So the corporates cater this, the poor. Now the category which is remaining for the 95% of doctors, again I will tell you, 95% of the doctors are the affordable homes. So why not go for something called as local corporates? So what is the need of these people? They need an infrastructure which has a good infrastructure, good services, and which manages all the critical care patients. And believe me, guys, if size really would have mattered, then elephant would have become the king of jungle, not the lion. It's not the size which matters, it's the services which matter. So focus on what is called as affordable homes. I've just made a start on simple researches. If you want to set up a 20 to 30 bedded small setup with general basic units, your child, this cost should go around 8 to 10 lakhs per bed. If you are doing 15 lakhs expenses on this, guys, it will be not that cost effective. For 15 beds, it should be something around 12 lakhs per bed. For 100 beds, they normally don't go for general basic unit, they go for critical care. Actually, for 100 beds, the cost should be slightly lower. So if you are starting up with cardiac unit, and if you are going up with diagnostic centers, these are the simple, some research made formulas. It's not a very these things. So go for affordable things, and you will realize that you don't get burdens of loans, debts, and there is really a very sukun ka practice. Then business behind business. Then the third point which I focused on was, I am focusing only on business this practice. So why should not I go for a thing where I am outsourcing and where most of my money, if I am earning something, suppose 100 rupees, of this, like 50 to 60 rupees are going on my diagnostics, my pharmas, then my housekeepings, then my oxygen plants, then my waste, this, then my staff. So why we are going this and giving it to others, and why we are just doing so hard works? Definitely this is not an unethical practice, this is an ethical practice. I'm not doing anything. So we should focus on these things. So why we not start so fortunately, I would again proudly say that we have started our own diagnostic center, and it is one of the best running diagnostic centers. We have seen that in Forbes list, the pharma companies are getting listed. But what about the doctors? Are they getting listed? Then why, guys, we are not coming together with a common platform to go for these things? Then your nursing paramedic centers, your housekeeping centers, if all the guys can come together, we can really make a huge difference, and the investment cost will be very low for each. So guys, I can again proudly say that within just 2 years, we have gone very rapidly with this same concept of cooperative to corporate, local corporate, and business behind business. We have gone a very big unit, and I I can again proudly say that it is a totally loan-free unit, not a single penny loan of anyone, any bank is there on us. And with this, I would summarize my lecture in 4 to 5 messages. Take home message: if you want to become an entrepreneur, if you want to become a successful businessman, there is no jadoo ki kandi. It's you have to gain a financial literacy, and it doesn't cost a lot. It only costs 30 minutes a day. That means in a month it's something around 900 hours. And we are so brilliant. We have learned Harrison and all these things, so complicated things. We can learn this in just a month's period, and we can start it applying. Then apply this techno-commercial knowledge. Try to understand that we are lacking a techno-commercial knowledge, and once you accept that we are lacking it, we gain it, and we apply the technical commercial knowledge, and our business will grow. Be honest to ourselves. Don't try to say that ki मी खूप शिकलेलो आहे, मला सगळं येतं. We are really very lacking in ourselves in financial literacy. So accept our shortcomings and change our perspective. It will definitely change. And analyze and research. Start finding opportunities in our business. See, there are many common, just I told you, there is a need of chain of local corporate hospitals, affordable hospitals. There is a need for diagnostic centers. There is a need of all these things. Try and find out the opportunities and loopholes in your own business, because your businesses can go and give you much more than the other businesses. So if you go and do in this way, definitely you are going to achieve a success, and your business model is going to proliferate, and you are not going to depend on your active income of source. You will become a passive income source, and you can live a financially free life. Thank you so much.
Thank you, Praveen, for such an excellent and informative talk. Thank you very much. I would like to ask Dr. Sudarshan Aire, Secretary IMA Nasik, to propose a vote of thanks.
Thank you so much. I'm Dr. Sudarshan Aire, Secretary IMA Nashik. I'll be taking just 2 minutes to just give my vote of thanks. I'm here for the formal Thanksgiving ceremony for the Refreshercon 2021. The concept of rhythm was come up on the background of COVID to seek and to have normalcy of everybody's life. First of all, I would like to thank our state president, Dr. Ramkrishna Londhe, for having faith in us and supporting us, and also would like to thank Nashik IMA president, Dr. Samir Chandratre sir, for believing in our views, concepts, and capabilities. My organizing team, member of Rhythm 2021, Dr. Prashant Birla sir, Dr. Chandrasekhar Pethe, Dr. Kiran Birari, Dr. Pritam Ahir, Dr. Ninad Chopre, Dr. Muktesh Daun, Dr. Nikita Patil, Dr. Bhausaheb Bachchao, Dr. Anand Saraf, Dr. Vivek Khose, Dr. Supriya Mangulkar, Dr. Supriya Dange, Dr. Swati Chauhan, Dr. Sudarshan Pandit. Also, I would like to thank our treasurer, Dr. Prashant Sonone sir, for his leadership, Dr. Prajakta Lele, our CWC member, Dr. Rajendra Kulkarni sir, our office bearer, Dr. Mrs. Pooja Chandratre, Mr. Dhamne, also our technical crew, Mr. Birari, Mr. Chorges, and Mr. Shekhar Khaina. Also, I would like to thank all the people who supported immensely right from the day of conception of idea to conception of rhythm till this moment when I am standing in front of you for Thanksgiving. Also, not to forget the backbone of this conference who are working on toes since yesterday morning and making things very easy and smooth for all the doctors across Maharashtra to have this knowledge bonanza rhythm, none other than the DG sheet. I would like to thank Mr. Dipen Mehta and his team and also Pallavi Dharmadekari and her team. I would like to conclude this conference with Thanksgiving not only limiting to the members who were physically present throughout the conference, but also for all of you who join us across Maharashtra. Not to forget, I would like to thank HN Reliance Hospital Mumbai, team of ICMO, for giving us a wonderful workshop and taking our knowledge one step ahead. Thank you, Dr. Jumana Haji, Dr. Anvay Mule sir, Dr. Talhan Darin, and the whole Reliance team for this workshop. Our sponsor, Oakard Hospital, Apollo Hospital, Ashoka Hospital, Sahyadri Hospital, Magnum Hospital, Dr. Praveen Garsing, Narayani Hospital, Dr. Sachin Devre, and MOC Hope Team, Nashik. Also, Aries Pharma Company. Finally, I would like to say thank you so much for everyone who supported us, who are with us till the end. Have a great time and have a happy weekend. Thank you so much.
तुम्ही केलंच ना
नाही आपोआप झालं
नाही नाही क्लोज तुम्ही केलंच ना क्लोजिंग झालं आता काही नाही ना काढायचं
Sir.